Sampath ma'am is a YouTube live. Okay.
Okay.
We are live
So I
now.
think we can start.
Shall we start?
Yes, ma'am.
Good morning to all. I welcome you all for the wonderful webinar organized by Tamil Nadu Federation of Obstetrics and Gynecology. This is a mid-year conference of TNFOG with Karnataka Society of Obstetrics and Gynecological Societies. So TNFOG with Kasoga. This is the 2-day program. Today we will be completely having the obstetric session and tomorrow we will be having the gynae session. So I welcome you all. Now,
good morning, brother.
Hey,
Shri
prayer-
Priya, you have to mute others. Yeah, when others speaking.
Okay, ma'am.
You can mute others. So I invited Dr. Vidya Topi, Dr. Revati Madam, Dr. Rajeshwari, and the entire Kasoga team and the TNFOG team, the faculties and delegates. I should thank Vidya Topi for accepting within a short duration, I think. And she has given many faculties from Kasoga and from Tamil Nadu, we have many faculties. I think first we can.
This is also our TNFOG mid-year conference.
Yes, madam. This is the mid-year conference. Madam, first shall we have the prayer and then welcome address by Dr. Revati
madam.
and Vidya
No,
Topi?
madam. Sampath ma'am. Next, Revati ma'am to address, then Vidya Topi madam, then Rajeshwari madam.
Rajeshwari. Okay, so I invite our President, Dr. the Revati Janakiraman, to address the gathering.
Good morning, dear friends. It is indeed a great pleasure for me to invite you all. And this venture of 2 days CME, including Kasaga and Tamil Nadu, is really a wonderful one. I am sure all of you will be benefited by the nice topics. I think all the topics are chosen by Dr. Sampath. The credit goes to her. And I wish you the conference a great success. And I also wish Dr. Vidya Topi success in her election. Thank you. Welcome you all.
Dr. Vidya Topi is the Karnataka Society President, taken over 15 days back, I think. Illa Vidya?
1 month, 1 month.
1 month. So I invited Dr. Vidya Topi for her wishes.
Yeah. Thank you, Dr. Sampath, Dr. Revati, and all Tamil Nadu and Karnataka faculties, those who have joined. I welcome them all. And it is all A to Z in obstetrics and gynecology, which Sampath and we all Kasogians, we have planned. And actually, we had planned all South Zone, but it was not possible. At least we two together, we have done this venture. And I think all the delegates and all the faculties are going to enjoy this academic feast. My secretary, all the members from the Kasoga, we wish this venture a great success. And we are always there to cooperate and commit to all South Zone ventures, what we are going to take in the next 1 year. Thank you very much, Dr. Revati and Dr. Sampath, to bring in Kasoga in this venture. And thank you very much. Thank you very much.
Thank you.
Dr. Rajeshwari, 2 words she will talk, my
Yes,
secretary.
Yes. Yes, Dr. Rajeshwari, welcome.
Yeah.
Good morning, everybody, and heartiest congratulations for teaming up both the major societies of South India, the Kasoga and the Tamil Nadu Federation of ONG. We are indeed proud to be associated with all the faculty, respected presidents of both the association secretaries, and the dear faculty members. Hearty welcome to this wonderful association of both state societies and scientific bonanza that we have in plan for both the society associations. I wish everybody all the very best and great success for this 2 days program. Thank you for giving me this opportunity. Thank you.
Thank you, Dr. Rajeshwari, for the wonderful cooperation. So Priya would have called you, I think, a minimum of 30 times per day.
That is a pleasure, madam. We want the best for everybody. Yeah.
Okay.
But main skeleton is Dr. Sampath only. I congratulate her.
Oh,
Yes,
Vidya,
thank you.
all supports only with single bank.
Thank
Now
you.
I invite today's coordinator.
Prayer song, please. Prayer song.
First a prayer song, then I will introduce Dr. Radhika.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Good morning. Good morning, Manova. Hello.
Sambat ma'am, you are muted, ma'am. Sambat ma'am, you are muted.
Yes. Radhika is our coordinator and Vidya Topi, who is your coordinator?
Our coordinator has joined, Dr. Shruti Bhavi.
Dr. Shruti. Oh, Radhika and Dr. Shruti will take over the session. Dr. Radhika is consultant from ASI Hospital, Tirunelveli, MRCOG in US, member of Oxy, RCOG, IMA, and she is interested in medical complication and high-risk pregnancy. Vidya Topi, do you want to introduce your coordinator or myself?
You can introduce so that
Yes,
you also
Dr.
know our coordinator.
Yes, Dr. Shruti, welcome. Dr. Shruti is Associate Professor and Unit Chief of Department of OBG, GAMS, Gadak, Karnataka, President IMA Gadak, President Gadak OBGN Society 22-23 and Secretary of COX 2019-20. And she has done her DJO in Belgaum and MD in Bijapur. Oh, Bijapur is Vidya Topi is the queen of Bijapur. Okay.
No, she is our EC member also. EC
Okay.
member of Kasoga. Yes.
So co-investigator for WHO trial labor care guide and co-investigator for WHO STEP MAC trial and a nodal officer for Lakshya program. Very good national and international publications. She has many and iconic healthcare leadership award, obstetrician gynecologist, Golden AIM Conference 2023. Dhira
Yes.
Champion Award, and she was the Common Era Orator for the year 2021 South Zone, participated in RCOG World Congress 2021 and Appreciation Award for COVID Warrior and won second prize for Consultant Pesa. So, Dr. Shruti, you have a wonderful CV. Welcome, Dr. Shruti.
Yes.
Thank you so much, ma'am.
Radhika,
Ma'am, you were my chairperson during the AICOG oration also.
No problem. I welcome you for our Kodaikanal conference for some keynote address or
Yes,
talk,
yes.
whatever it is.
Yes, ma'am. Thank you so much.
Welcome. Dr. Radhika, you can take off. Dr. Radhika?
Good morning.
Radhika, you have to unmute yourself. Yes.
Good morning, madam. Welcome all delegates and panelists. So we will start the program now. First I'll introduce Dr. P.P. Premalata madam, who is the HOD and Professor of Obs and Gynae Department, Tagore Medical College and Hospital. She's a retired professor, MMC and KGH project officer, and she has 28 years of teaching experience. She has done more than 100 adolescent programs and cancer screenings, and she's presented a paper in PIGO International Conference. And I invite respected Dr. Monambal madam, who is the ex-president of OGCON and IMA Perambur, and she's done MD OG in Madras Medical College in 1986, DGU on KMC, and her undergraduation was in Chengalpet Medical College, and she has a long service of 33 years and teaching experience of 22 years after passing MD in Stanley Medical College. And she has a very great administrative experience of 10 years. She's been an examiner in Tamil Nadu, MGR Medical College, Andhra Pradesh and Karnataka and Pondicherry. And she is an excellent teacher for the UGs, PGs and dependent B students and a guide to PhDs also.
Good morning, madam. Thank you very much for your warm welcome on this.
Thank you, madam. Can you please take over?
Thank you
Yeah.
for your introduction. Shall we start the capsule presentation now?
Yes, ma'am.
Yes, area.
Premlata madam, you can introduce Dr. Kritika or Mohanambal madam, anyone.
I thank the TNFOC and also Karnataka Society for giving us this chance. The first presentation is on first trimester complication that the hyperemesis PUQ score in NBP by Dr. Kritika Meenakshi. Dr. Kritika Meenakshi is a consultant, Nanganallur Maternity and Faculty Center, member of Royal College of Obstetrician and Gynecologist, fellowship in minimal assessment surgery, diploma in reparative medicine, ICOG certified faculty, IMS menopause practitioner, speaker in many national and state conferences, participated in the student exchange programs in emergency medicine, Best Outgoing Student Award in MSOG, Best Outgoing Student Award in MBBS, and their special interest is in endoscopy and infertility. Over to you, Kritika.
I request all the speakers to stick on to the time.
Good morning, everyone. Shall I discuss? Yeah. Good morning, everyone. At the outset, I'd like to thank TNFOG and Kasoga for giving me the opportunity to talk in this prestigious forum. The topic for today is PUQ score in nausea vomiting of pregnancy. So next slide, please. Yeah. So it's a quite common condition. Nausea vomiting of pregnancy is a quite common condition. At the same time, it's the most neglected condition because we now look at the two case scenarios. One, we have a teenage pregnant who is 8-weeker with recurrent vomiting episodes. She went to the PhD and she had very lost follow-up. Finally, she ended with pulse query and BP query in an ER. Now, another scenario in a metropolitan city, we have a 32-year-old pregnant with IVF conception who vomited only thrice, but she was given over treatment with IV fluids and admission. But why there is a difference in the care of treatment? This is because there is no standard of care. What to do next? So to give a standard treatment for everyone, we need a proper protocol. That's why this PUQ score comes into scenario. Next slide, please. Next slide, please. Yes. So nausea, vomiting of pregnancy. So any degree of nausea or vomiting during pregnancy is considered. Usually it starts in the first trimester. So we brand it as nausea, vomiting only when the other causes of nausea, vomiting are excluded. Next slide, please. Yes. So why we are quite worried about this nausea vomiting? Because it has a huge impact on the quality of life of the women. Unwanted admissions increases the healthcare cost, and the women's productive life is gone, and it increases as the severity of hyperemesis increases, it coincides with the complications. So the Wernicke's encephalopathy or Korsakoff psychosis increases with the severity. So the routine screening is very important to control the severity so that to improve the outcome of the pregnancy. Next slide, please. Yes. So now coming on to the molecular basis, now the researchers have found that chromosome 19 and chromosome 4, two genes have been identified to find out the cause of hyperemesis. And mostly the research is focused on growth differentiation factor 15, which again causes the vomiting center area of prostoма to increase the vomiting. Next slide, please. Yes. So here we can see the molecular basis of the hyperemesis. Next slide, please. The next slide, yeah. So we all know the etiology focuses on HCG, thyroid, TNF-alpha, and H. pylori. Next slide. So the recent research focused on H. pylori, which is an important marker of hyperemesis gravidarum. Next slide, please. So now why we need this scoring? We need the scoring because the assessment of nausea vomiting is subjective. So the severe cases are missed, and on the other hand, unwanted admission, unwanted healthcare costs. Next slide. So that came a road scoring. So road scoring is basically used for chemotherapy patients, assessing the physical symptoms and also the severity based upon the stress. It uses 8 questions to grade the severity of vomiting, but this is not pregnancy specific. Next slide. So at the end, we came to a score unique for pregnancy. This was done in 2002 by the Mother Risk Program by Canada. So it is a NVP helpline in Canada, which gave the scoring. Pregnancy unique quantification of NMC score. So this is it was started as a 12-hour questionnaire, so to assess the severity of the symptoms. So the advantage is that it is an objective scoring and it is a validated index. Next slide. So 3 symptoms are assessed. One is the nausea, second is the vomiting, and third is the retching. So these symptoms are assessed in the form of 3 questions, so that according to the score is given. Next. Initially, the original puke score was done for 12 hours, but later it was modified for 24 hours. So why 24? Because it gives an accurate reflection of the severity of symptoms over a period of 24 hours. So the all aspect of the daily life, including the nighttime, is also included. At the same time, more than a day will cause recall errors. So it is a short one. Next. Yes. So here the RCOG presents the puke scoring system. So in the last 24 hours, the first question will be regarding the nausea. How many times she felt nauseated? The score is from 1 to 5. And the second question goes for how many times she vomited. And the third will goes for how many times she retched. Retching was there. So in a score of 15, so mild will be from less than 13, moderate is 7 to 12, and severe is 13 to 15. Next. So it also includes lifestyle scoring. How many hours the women slept? So how is the well-being? So we add everything so that we could put a total score. Next. So what are the advantages of a puke scoring? As I told, it gives a systematic assessment, objective assessment, so we can avoid unwanted hospital admission, unwanted anxiety to the patient can be reduced. And the advantage is that rather than a rote scoring, it is pregnancy specific and we can monitor the treatment progress. So after admission also, we can assess the puke score in 2-3 days to assess how the treatment works, how the antiemetics works, whether we need to change the antibiotic or antiemetic or any IV fluid can be understood. Next. Yes. So RCOG presents this initial assessment. We need to exclude the other causes, record the puke score, assess the patient completely, assess for hydration status, monitor any electrolyte imbalance or weight loss so that hyperemesis gravidarum can be identified, offer advice and support. Now, classify them according to puke score. So when the puke score is between 3 and 12, and when there is no complication, the patient can be monitored in the community with the help of antiemetics, lifestyle, and dietary changes. On the same hand, when the puke score is 13 or above, but there is no complication and the patient is responding to antiemetics, she can be still monitored without any inpatient using a care called ambulatory day care. Until the patient is having ketonuria, she can be provided ambulatory day care. So what is the ambulatory day care? Ambulatory day care is just nothing but fast IV hydration with normal saline and potassium. So if there is no contraindication for the same, we can give antiemetics and thiamine to combat B1 deficiency. But anytime, irrespective of the puke score, if the patient is not responding to ambulatory management or if there is any complication, inpatient management is suggested. So when the patient is in inpatient management, care should be given because since she is having severe vomiting, care should be given for trauma prophylaxis and multidisciplinary approach, and also steroid should be considered. Next. Ambulatory daycare. So there is multiple RCT supporting ambulatory daycare versus inpatient management, because one of the studies shows that with subcutaneous metoclopramide, 89% gave a positive feedback with ambulatory daycare so that inpatient can be reduced. Next. Next slide. Yes. So another classification according to this article as mild, moderate, and severe, such as that when the puke score is less than 6, We can concentrate on small dietary meals, high protein carbohydrate, avoidance of spicy food, and we need to avoid starvation, so that because it can also aggravate vomiting, and adequate rest, because fatigue induced nausea will be there. So adequate rest is also important. In case of a moderate NVP, so ginger, ACOG suggests ginger as the first line treatment for NVP, and RCOG also recommends ginger for mild and moderate NVP, because gingerol will modulate the serotonin and dopamine receptors, increases the gastric motility, and has a positive effect on nausea. So first line management according to this article is pyridoxine, doxylamine, but according to RCOG, pyridoxine and doxylamine are not recommended. When the puke score is more than 30, we need to assess for rehydration, vitamin supplementation, and thiamine, and also IP management is required. Next. Yes. So when the NVP is mild, daycare management can be done in the community. Next. So I have already told about the ambulatory daycare, where parental fluids and parental vitamins are done in the OP basis, and this daycare management gives the high patient satisfaction. Next. So here RCOG recommends this first line and second line and management for nausea and vomiting. Cyclizine, prochlorperazine, promethazine has been suggested as the first line, owing to the teratogenic effects of other drugs, including metoclopramide and ondansetron. Second line will be the other drugs like metoclopramide, domperidone, and ondansetron. Finally, when it is refractory, we go on to steroids, hydrocortisone, and then to prednisone. Next slide, please. Yes. So when it is an intractable vomiting, but other complications, infections are there, other comorbids are there, when we go for inpatient management. So for assessing whether it needs inpatient or outpatient, we need a puke scoring. Next. So there is one more score again, which is more precise than puke score. It's called health score. This is basically for severe symptoms of hyperemesis gravidarum. It contains more questions to assess the severity, like weight loss, whether the ability to drink water and eat food, so that the severity of hyperemesis and electrolyte imbalance can be assessed. Next. Yeah. So finally, so the using of puke score in MVP is to improve the standard of care, to give proper treatment, and also to avoid unnecessary admissions, so that the impact of the pregnancy can also be reduced. So we need to take it as a routine. So in our antenatal OPD, routine screening for the symptoms of nausea need to be done, so that earlier we can identify the women, and earlier antiemetics and lifestyle modification and dietary changes can be given. So it should be taken as a routine step in the OPD, assessing with the puke score. See, it is very simple. Paramedical you can also use it, so that the easy assessment can be there. So the standard of care is also improved. So mental health again need to be assessed, because nausea vomiting can also have the psychological impact. So counseling should be given to the women, reassurance should be given, proper time and warning signs need to be elaborated, so that she can come to the facility and take the good care. So these are the importance of a puke score in the management of nausea and vomiting. Thank you, everyone.
Thank you, Kritika. It has been very nice knowing about different type of management, even talking about the ginger and all, and different scores for hyperemesis and vomiting. Thank you.
Usually the hyperemesis is a very common thing. Day to day we have been seeing it. The pet child will be coming back 3 times vomiting. The other person who doesn't look after, even 20 times she vomit, nobody will be recording. The score will be of permanent use. Thank you. It was nice presentation.
Next speaker, Mohanambal madam, can you introduce? Hey, Radhika, adutha CV poda solpa.
Yes, ma'am.
Rakesh Kurikar is going to present about topic. Is exclusive in fact the IVF practice. Yeah, is IVF practice for more than 17 years in Africa. Current executive committee member in KSOTA, South Zone 23-25. Honorary Treasurer for Bangalore Society OBG 22-23, and Honorary Secretary Bangalore Society 21-22, Chairperson for Reproductive Endocrinology Committee KSOEDA 21-22, Executive Committee member KSR 19-21, and member of OXY Endoscopy committee 19 to 21 and 21 to 23. Number of FOX, ISAR, KSAR, IFS, ICOG, IAGE, AG. He's in teaching question. He's a teacher, former assistant professor, JNMC Bangalore, and now also he's in the teaching process. His academic experience so much. He had given so much of articles in journal, international and national journal, infertility as well as fetal medicine. He had published 5 research papers at international index scientific journals of first author. Welcome to you,
We will
sir.
be talking about cell-free DNA.
Thank you all for having me here, Dr. Vidya Tobbi, Dr. Rajeshri Palladi madam, and all the members of the TN Tamil Nadu FOG. I'm happy that I could be invited. And my topic is quite simple, that is cell-free DNA. And it is quite prevalent that nowadays we are hearing it was not there 10 years back, and now cell-free DNA is quite commonly heard. And screening is process. So basically what is needed is we need to check who are the people who are at risk of certain things. So that is the idea of any screening program, and any disease or any condition to have the people. And the aneuploidy rate of any of these trisomy 21, 18 and 13 are, the frequency is 1 in 700 for Down syndrome, 1 in 5,000 for Edwards, and 1 in 16,000 for trisomy 13. So what are the parameters for this accuracy? So we should have a detection rate. We should have a well-documented false positive rates, positive predictive value, odds of being affected given a positive result. So all these are important. Minimum detection rate should be 75%. So fetal aneuploidy screening methods, the efficacies are generally in the first trimester. When you do, the main criteria included, everything is a maternal age. Along with that, if you do a NT, the detection rate is 75 to 80% with a false positive rate of 5%. Whereas if you combine the test with a NT or a tracheostomy flow or the dectosonosis flow, then you will have a almost detection rate of 93 to 96% with a false positive rate of 2.5%. In the second trimester, along with the maternal age, if you are including the NT, the PAPA, as well as the quadruple test, the detection rate goes as high as 94%. And this is one of the important observations. So many papers have appreciated the cell-free DNA screening for aneuploidies, and the detection rate as high as 99.2% for trisomy 21 and 96.3% with trisomy 18 with less false positive rate. So this is a lot of papers are coming up with showing a good detection rate values. And traditional screening, combined test, as well as if you compare with the cell-free DNA testing, which is most sensitive, most specific screening with a low false positive rate, that is 99.9% sensitive and specific screening, and positive predictive value of 49.5% in low-risk population. And the advantage is it gives us a wider range of gestational window for screening, unlike just doing NT scan or quadruple markers, which should be done by 12 to 13 weeks. So this can be done even later. And common aneuploidies can also be detected, and odds of having an affected features is 1 to 1. So this is a very important finding. And cell-free DNA can also detect common aneuploidies, wherein just NT scan with aneuploidy screen and detect the below. So initially it was identified in 97, but commercially was not available till 2011. And cell-free DNA, which can also do RS genotyping of the fetus. It actually NIPT also is called as NIPT, but it's a misnomer, though the serum biochemistry testing is a little bit of invasive. And the cell-free DNA comes into maternal circulation from 10 weeks till term, and it gets cleared within hours. And 2 to 12% of total cell-free DNA is fetal, and it contains of a short DNA fragments. And primary first trimester screen contingent to the first trimester screen, it can be done. This is different uses of this, and need for good awareness and knowledge of NIPT is required prior to using it. So this is a contingent model for the combined test. If it is a low risk, anomalies can directly at 18 to 19 weeks, but in high risk, when it's 1 to 100, then it might need invasive testing also in combination, as it's not a foolproof method. Intermediate risk, genetic chronogram with NIPT suffices. In few cases where if it is high risk of 1 to 100, you may need to go for an invasive testing. So prerequisites, everything, family history, including the case review, baseline ultrasound, information regarding trisomies should be done. And turnaround time is generally 2 weeks, and low risk and high risk pregnancies, based on that, the risk results will come. High risk confirmation may be required with amniocentesis or CVS. It's a supplementary along with this. Low risk pregnancy to be followed with the routine antenatal care. In the era of NIPT, the ultrasound, the ISOG consensus statement said that all women should be offered a first trimester ultrasound scan according to ISOG guidelines, regardless of their intention to undergo cell-free DNA testing. So cell-free DNA testing does not replace the regular NT scan or the first trimester scan. It is a supplement, so it has to be taken as a supplement and cannot be replacement. So it is to date a pregnancy, to confirm number of viability, the ultrasound. So maternal pathology and other screening has to be done by ultrasound. So with the USC findings, the no NIPT can be done. In the presence of structural abnormalities of the fetus, you cannot do the NIPT. If NT is more, 99th percentile, you cannot do NIPT alone. And invasive testing, where it is required, you don't need to do NIPT, and 8% unemployed is on array. So in these situations of ultrasound findings, you don't need to do a cell-free DNA testing. And the procedure, the scanned and dated by ultrasound, including fetal number and chorionicity, 10 to 20 ml of maternal venous blood and the STREC tube as indicated is taken. It's important that you need to take a consent for this, and because it involves the invasive testing, invasive genetic testing, preferably done in a PNGT recognized center, and is supposed to be received in the lab within 72 to 96 hours. And it's a massive parallel sequencing. Single nucleotide polymorphism is the technology used. And this is how a separation of the maternal DNA from the fetal cell-free DNA is done. This is a picture depicting the same. These cell-free DNA fragments are sequenced, the chromosome origin is established, and the quantity of each chromosome is determined. And SNP-based NIPT can differentiate maternal DNA from fetal, determines the zygosity and determines the fetal sex, though it's not allowed in India, it's not done. And Z-score differentiates the total cell-free DNA attributed to fetal trisomy, reflects number of standard deviations. I do not go into details of the techniques because of paucity of the time. And fetal fraction is the percentage of the fetal cell-free DNA in the sample, that is fetal DNA divided by fetal DNA plus maternal DNA. So fetal fraction increases with the gestational age. So NIPT results of the cell-free DNA comes as low risk, or a test failure, or a high risk. So if it's a high risk, then confirmatory test by immunosynthesis or NIPT or a CVS may be required. It might come as failure or no call test also. Wherein blood collection may be inappropriate, low fetal fraction could be there, or assay failure could be there. So low fetal fraction, maternal causes are obesity, autoimmune disorders, or maternal medications like low molecular heparin, or any of the other medications. Low fetal fraction, fetal causes could be aneuploidies with poor placental function, trisomy 18, 13, Turner's, and triploidy, twins, IVF pregnancies, or early gestation age. These are the cases wherein there is possible that low fetal fraction could be there. So management of the failed results, this is a detailed table showing how to manage it. If it is failed, we can repeat it. If it is normal, then no test. If it is abnormal, then invasive test may be required. So false positive NIPT is common. So maternal aneuploidy, wherein it can happen, maternal mosaicism, or the maternal copy number variations, or neoplasm, or prior organ transplants. So this is a placental cause of confined placental mosaicism, when it can happen. Amniocentesis is the best way, or the test of the choice, to put an end to that. And vanishing twin or single twin demise, the cell-free DNA cannot be done at least 8 weeks post-demise, because it can give an error and it can give a wrong value. So in vanishing twins or single twin demise, it cannot be done, especially for even fetal reductions. Screening for trisomies by the cell-free DNA in twin pregnancy, it can be done, and the efficacy is similar to that reported in a single pregnancy and is superior to that of first trimester combined test and second trimester biochemical testing. So number of cases of trisomy 18 and 13 is too small, and it is quite efficient and almost equal. If you see the table, the diagnosis rate is quite superior as compared to even the single or the twin pregnancy. So even it can be performed in the twin pregnancy also, provided you don't do it in the vanishing of the if one fetus is dead. Okay. So screening of chromosomes should be performed with the first trimester ultrasound markers in the twins. About twins, it is not advised. And in the case of testing by singletons and twin pregnancies, it is almost the same. And the risk of failure only in case of advanced age, obesity, black, nulliparous woman, or trichonic twin pregnancy. Non-invasive in context of non-invasive testing in context of IVF and PGTA. If you have done a pre-implantation genetic testing, I do a lot of PGTA in my patients, and then, but that doesn't mean that if you got a PGTA normal report, it doesn't mean that you have to forego doing testing. So non-invasive prenatal testing is recommended. The ultrasound as first trimester is recommended. The other tests also as recommended, though you have a transfer of PGTA embryo, because it doesn't guarantee a chromosomally normal child. Sex chromosome abnormalities are the performance screening these, and these are microdeletions. And the content of cell-free DNA is the trisomies, the sex chromosome aneuploidies, microdeletions, gene-wide assessments, and single gene disorders. And even it can be used to assess the RH genotyping of the fetus and assess the genotype in the fathers first. So who are the candidates for the test? Advanced maternal age above 35, personal family history of prior pregnancy with a trisomy, intermediate risk for aneuploidy, and parental balance translocation with the increased risk of fetal trisomy. Contraindications: if already there is fetal anomaly on the ultrasound, triplet pregnancy, vanished twins, no genetic abnormalities that cannot be diagnosed by NIPT, and T is more than 3.5 millimeter. These are the conditions wherein cell-free DNA testing is not recommended. So its advantage is non-invasive, no risk of infection, no risk of miscarriage specific to the pregnancy, and most sensitive and specific for common aneuploidies. In few limitations of the cell-free DNA, no result in few patients, cost is little higher side, fails to pick up other aneuploidies, need amniocentesis for proper confirmation. So to summarize, NIPT is a screening test with a high sensitivity, and patient should never be offered the option of termination without confirmation. Negative test is reassuring, does not replace a good ultrasound scan, no role in the presence of structural abnormalities, avoid home collections because of PCP and GT, need to fill the Form F in approved centers for genetic sample collections. Thank you again for inviting me here, and have a good day.
Thank you. It's a nice topic. So hereafter, all consanguineous marriage also we can include this. Apart from this, repeated thing.
Yeah. Now the
It's a new era. We have been doing all this basic procedure. Welcome.
Hello.
Yes,
We'll
ma'am.
go to the next topic.
Yes,
Yeah.
ma'am. Please.
So that is preeclampsia is still a nightmare for us. So prediction of preeclampsia is very, very essential. Prediction of preeclampsia, the talk next will be given by Dr. Gomati M. Can we have the CV? Priya? Dr. Gomati is consultant obstetrician and gynecologist, visiting consultant in Bevel, Sudarshan and AC Hospital, former assistant professor at RSRM, and she did her UG in KMC and PG in Stanley Medical College. Oxy Life member, won Easter Gold Medal Award in contraception quiz, has 9 years of experience and special interest in high-risk pregnancy, infertility, and laparoscopic colposcopy. Over to you, Dr. Gomati.
Very good morning, ma'am. I thank TN Fogg and Kasogo and Dr. Sampath Kumari ma'am for giving this opportunity. And I thank Dr. Premlata ma'am for introducing me. Now let's go to the topic. The topic for today's discussion is predictors of preeclampsia. So what is the need for improved prediction? The hypertensive disorder of pregnancy is approximately 10 to 15% of all pregnant women, and preeclampsia affects 3 to 5% and contributes to 10 to 15% of direct maternal deaths and 5 lakhs fetal and neonatal deaths. The early onset preeclampsia contribute to 0.38% of pregnancy, but the late onset preeclampsia is 7 times higher and severe, leading to the perinatal mortality and MMR. So what is the effective predictive test? The effective predictive tests facilitate early diagnosis, targeted surveillance, and timely delivery. What is the ideal biomarker? The ideal biomarker should play a central role in pathogenesis, be specific for the condition. It should appear early or before the clinical manifestation, and it should be easy and cheap to detect in maternal blood or urine. It should correlate with the severity of the condition. It should show high sensitivity and specificity, and it should not be detected or in very low levels in normal pregnancy. So what are the various tests available for the prediction of preeclampsia? The testings are related to the various pathogenesis, that is poor placental perfusion, fetoplacental endocrine dysfunction, renal dysfunction, endothelial dysfunction leading to oxidative stress and other parameters. So all these are the factors we are testing. So how we evaluate the blood pressure changes in response to stimulus? We do a rollover test, isometric hand grip test, angiotensin 2 infusion test. The rollover test, the rolling over from the left lateral position to supine position increases the blood pressure to more than 20 millimeter of mercury. That indicates a positive test. Angiotensin sensitivity test also gives the same result. So the sensitivity of the test is 55 to 70% and specificity is 85%, but it is inaccurate and time consuming. We can measure the mid-trimester mean arterial pressure, which is more than 90 millimeter of mercury in second trimester. We can also measure the uterine artery Doppler and 24 hours ambulatory blood pressure monitoring. So what is the role of uterine artery Doppler? The uterine artery Doppler at 22 to 24 weeks, due to the impaired trophoblastic invasion of the spiral arterioles, the spiral remodeling does not occur. So there will be muscular intima layer will be present. So this abnormal uterine artery waveform is predicted as pulsatility index more than 95% and presence of diastolic notching in the abnormal uterine artery waveform. This shows the increased risk of preeclampsia to 6-fold times. The sensitivity of uterine artery is 20 to 60%, and in very severe form, the sensitivity can rise up to 80 to 90%. Although it is not a perfect screening test, it is the best available test for the early detection. So now, from shifting of the paradigm from the second trimester to the first trimester, the uterine artery Doppler at 11 to 13 weeks showing the increased impedance of flow to the uterine artery. It is combined with the maternal factor derived a priori risk with the uterine artery Doppler. It shows a detection rate of 81% for early preeclampsia and 45% for the late preeclampsia. So we also have other markers for detection or for prediction of preeclampsia, like human chorionic gonadotrophin, which is increased in preeclampsia, alpha fetoprotein, estradiol, corticotrophin releasing hormone, placental protein 13. All are increased. Inhibin A and PAP, pregnancy-associated plasma protein, are low in the prediction of preeclampsia. Coming to the serum uric acid, there is hyperuricemia due to low uric acid clearance, low GFR, increased tubular reabsorption, and decreased tubular secretion. The sensitivity of this test ranges from 0 to 55%, and the specificity ranges from 79 to 95%. There will be microalbuminuria in preeclampsia with sensitivity ranges from as low as 7% to as high as 90%, and the specificity is 29 to 97%. The role of urinary calcium, that is preeclampsia, is associated with hypocalciuria. So the 24 hours urinary calcium measurement shows less than 12 milligram per deciliter, shows a positive predictive value of 85% with negative predictive value of 91%. We can also measure a spot calcium creatinine ratio, which is normal in pregnancy is 0.4. If in chronic hypertension, it is 0.2, and in preeclampsia, it is 0.03. So we can, the first stage is the poor trophoblastic invasion, and the second stage of preeclampsia is the maternal strom due to endothelial dysfunction and oxidative stress. These are the major participants in preeclampsia. So due to endothelial dysfunction, the fibronectin, which is high molecular weight protein present in the endothelial layer, is increased. There thrombocytopenia and platelet dysfunction are the integral part of the preeclampsia. Endothelial C-reactive protein, plasminogen activator inhibitor, placental growth factor, or the multiple factors, innumerable biochemical markers are there. According to the NICE guidelines, where women is considered to be a high risk for developing preeclampsia if any one high risk factor, that is hypertensive in previous pregnancy, chronic hypertension, chronic renal disease, diabetes, autoimmune disease, or any two moderate risk factors, that is nulliparity, age more than 40, BMI more than 35, family history of preeclampsia or interpregnancy interval more than 10 years. So the traditional screening approach of this includes that pre-trial screening program for preeclampsia. It is conducted in a 7 NHS maternity hospital in England. A prospective multicentric study SPRE was carried out in England, which evaluated the performance of screening of preeclampsia by Bayes theorem method. The Bayes theorem method is a combined screening. Yes, ma'am.
Okay. Screen has come. Actually, the slide was not moving. Now it has come.
Combined screening, it is a mean arterial pressure, uterine artery pulsatility index, maternal characteristic, medical history, placental growth factor, and PAP-A. So this all together, this SPRE as a prospective trial of detecting a positive case that increases from NICE shows a detection rate of 10%. When SPRE is used, that is a multi-combined screening approach is used, the screen positive rate increases to 42% and the detection rate increases from 30 to 82.4%. So coming to 11 to 13 weeks pregnancy with the medical history, with the ultrasound markers and the biochemical markers, we calculate the preeclampsia risk qualification and we classify as low risk and high risk. And according to the high risk, we give intensive antenatal care or low dose aspirin prophylaxis before 16 weeks. There are innumerable biochemical markers for the prediction of preeclampsia and the list goes on. And I'm discussing only a few. That is a PAP-A, when used as a single biochemical marker, is only 10 to 20% detector sensitive, but combined with the ultrasound, our PAP-A is a powerful predictor of a biochemical marker of preeclampsia. Its prediction rate is 70% with a false positive rate of 5%. But at term, plasma PAP-A have shown to increase in pregnancy complicated by PE and HELD, but it is still not predictive. Placental protein 13, a member of galactine family produced by the placental trophoblastic cells, is associated with normal placentation. In normal pregnancy, it slowly rises with increasing gestational age. But in preeclampsia, it is very low, but it is a weak marker of preeclampsia at term. Coming to elevated soluble of FMS like tyrosine kinase, SFLT1, the elevated soluble FMS occurs before the clinical symptoms. The levels correlate with the time of onset of clinically manifest PE and partly with the disease severity. Early onset preeclampsia exhibit higher levels of SFLT. It is observed 5 weeks before the onset of preeclampsia. Coming to the angiogenic and anti-angiogenic factor imbalance, vascular endothelial growth factor and placental growth factor decreases, SFLT1 and SGNG increases. The cell-free DNA released due to accelerated apoptosis of the cytotrophoblast is increased in preeclampsia is also a predictor as discussed by the previous speaker. The other markers are HbA1c and the list goes on like serum cysteine. In a prognosis study, the ratio of SFLT and PJU, if it is less than 38%, it is 99.3% negative predictive value. It has a high negative predictive value that rules out in a high-risk patient. So other markers are HbF, A1M plays a role in pathophysiology. The biomarker can appear as early as 10 weeks. There are lots and lots of biomarkers which are being continuously detected, even proteomics, genomics, mRNA, or still in trials. So what are the genes for preeclampsia discovered? The genes which are our errors are MCP factor 1 and factor H play a role in regulating immune response. This could also explain the possible link to preeclampsia with the women with lupus or autoimmune disease or increased risk of preeclampsia. So these biomarkers helps to predict the development of preeclampsia. Some tests are predictors of severity of preeclampsia in third trimester, and some biomarkers are used to forecast the recurrent preeclampsia. Currently, no single screening test is reliable, valid, or economical. Hence, a combination of tests and risk factors is superior than single predictors. So comparing to the combination of factors, the advantages and disadvantages of one or two methods. So when we go for clinical guidelines, applying the preeclampsia risk score, going with NICE and ACOG, it uses only the maternal and pregnancy characteristic and existing maternal risk factors. So the advantages are there is no specific blood testing, there is no ultrasound, there is no additional cost. But you can assess the patient when they come come at the first visit itself. But the disadvantage is it is a modest test performance and its sensitivity is 41% only for preterm preeclampsia, but it is worse for all, that is late preeclampsia. We will not be able to apply it. So coming to the first trimester combined algorithm screening for preeclampsia, which has mean arterial pressure, mean uterine artery with PEGF with ultrasound, it has higher sensitivity of detecting preterm preeclampsia, 82%. And but the additional cost of doing PEGF, ultrasound to do a maternal uterine artery. So these are the additional costs. It does not predict term preeclampsia with high sensitivity. So you can't reduce the rate. So other will be the SFLTs to PAGF ratio, which is more than 38 is screen positive. Again, it is limited to suspected preeclampsia at less than 37 weeks and not applicable to the general population, only for the high risk population. We can't rule in a patient with preeclampsia patient. And PAGF alone is less than 100 picogram per ml represents screen positive. Again, it is limited to suspected preeclampsia of less than 35%, not applicable to the general pregnant population. So what is the conclusion? The preeclampsia may never be totally predictable. Better prediction would help to focus on antenatal care more effectively. Clinical triage remains the mainstay of care. So at each visit, antenatal visit, we have to monitor the patient with the clinical history, BP monitoring, and with the first trimester screening, we have to identify the early onset preeclampsia. With the early onset preeclampsia, we can put the patient as a high risk group and a low risk monitoring system. So time-honored clinical approach, distinctive to identify early disease versus women already have established preeclampsia. For the women with established preeclampsia, predictive tests could enable for personalized stratification for whom we have to need high intensity surveillance on low intensity surveillance. There is no role, actually there is no ruling test for the term preeclampsia, which is the unmet need of the hour. Thank you.
Thank you very much.
Thank you, Gomati.
It
has been a
nice
very
topic.
elaborate presentation. You have been talking about starting from the history, clinical side, and ended up with the clinical thing is very important rather than the biochemical ones. Thank you. Over to you, ma'am. Madam.
Early suspicion and detection is more important rather than leaving the case up to the time.
So we ended our session 1.
Thank you so much. Thank you so much, ma'am. That was a wonderful session. Now we move on to the second session. The chairpersons are Dr. Chandra Punnuswamy and Dr. Malini for this session. It's my honor to introduce Dr. Chandra Punnuswamy, ma'am. She is the MBBS DGO and Diploma in Reproductive Medicine, Chandra Fertility Center and Chandra Nursing Home, Tamil Nadu. She has done her undergraduation and post-graduation in Stanley Medical College, Chennai, and was awarded Best Outgoing Student of the Batch. She was the first obstetrician, sonologist, laparoscopist, and first IVF specialist in her district. She has delivered IVF babies of Namakkal district in 2008. She is Foxy Life member since 1981 and many gold medals for proficiency in anatomy, ophthalmology, medicine, pediatrics, obstetrics, and gynecology.
Thank you.
Founder member of Salem Society and life member of IMAGS ISAR. And she is also instrumental in the formation of founder president Namakkal Obstetric and Gynae Society and many presentations, paper presentations to her credit. She was a chairperson in ISAR 2015 and Articon Salem and was awarded Best Doctor Award by Namakkal IMA. And she is interested in infertility and high-risk obstetrics. We welcome you, ma'am.
Thank you. Thank you, Dr. Shruti.
Thank you, ma'am. Now, Dr. Malini M, she's had done her undergraduation from Madurai Medical College, DGO from MMC and in KMC. She's an assistant professor, Karur, GMC, and she's now secretary, Karur Obstetric and Gynec Society, and her special interests are high-risk obstetrics and gynae endoscopy. We welcome you also, ma'am.
Thank you, ma'am. Thank you for your kind.
We would like to introduce our speakers by the chairpersons. Yeah.
Okay.
Chandra ma'am, please.
Yeah, this is first topic is by Dr. Sindhura.
Yes, ma'am.
Yeah, because it was a different thing in the program. So I thought, okay. And she did her MBBS in Dr. PS Institute of Medical Science Research Foundation and the MSOG in Chettinad Hospital Research Institute. And she is currently working as assistant professor at Panimalar Medical College Research Institute, Chennai. And she presented posters and papers in national, international conferences. So she has published many papers in index journals. Peer-reviewed papers in the field of obstetrics in index journals, and her area of interest is high-risk obstetrics. At the outset, it's my proud privilege to be part of faculty of this A2 is that obstetric conference conducted by Tamil Nadu Federation of OG and Karnataka State. And I thank Dr. Sampath, Dr. Revati, and all faculties of Kerala, organizers of Karnataka Society for this nice opportunity. Now I call upon Dr. Sindhura to deliver her lecture. Dr. Sindhura, please.
1 minute, ma'am.
Yeah.
Ma'am, am I audible, ma'am?
Yes, yes, you are very much audible.
Good morning, everyone. I would like to thank TNFOG for giving this opportunity. My topic is on postpartum depression. Postpartum depression can occur at any time during the first 12 months after delivery. Postpartum depression affects 10 to 25% of the mothers and 10 to 15% of the fathers as well. Postpartum depression is most frequently underdiagnosed obstetric complication. 0.1 to 0.2% of women experience postpartum psychosis, usually within the first 4 weeks following delivery. 50 to 80% of the women experience transient baby blues within the first 2 weeks following delivery. Postpartum depression is common, with 6.8 to 16.5% of women experience, also known as postpartum major depression. So differences between postpartum blues, postpartum depression, and psychosis. 50 to 85% mothers experience postpartum blues in first 2 weeks postpartum. Symptoms are irritability, anxiety, fluctuating mood, and increased emotional reactivity. Spontaneously remission will be there, not considered as such psychiatric disorder. Postpartum depression occurs in 13% of the mothers in first year postpartum. Symptoms are excessive guilt, anxiety, depressed mood, insomnia, suicidal tendencies, and fatigue. Moderate to severe symptoms are present. They require prolonged, if prolonged, they might require the treatment. Postpartum psychosis. 0.01 mothers in the first months of postpartum experience postpartum psychosis. Symptoms are mild or rapid cycling, agitation, delusions, hallucinations, cognitive impairment, and low insight. So in severe cases, these are considered as psychiatric emergencies and often necessitates hospitalization. Some facts about postpartum depression. Up to 1 in 5 women will suffer from maternal mental health disorders like postpartum depression. Less than 15% of the women will receive the treatment. 1 in 7 women will experience depression during the pregnancy. Up to 50% of the women living in low socioeconomic conditions will suffer a mental health disorder. More than 6 lakh women will suffer from maternal mental health, according to US statistics. Anxiety and depression have given rise to 37% in teenage girls. Rates of depression are more than double in Black moms. Not only just moms, entire the family and the fathers also experience postpartum depression. Risk factors include personal history of depression or anxiety, younger maternal age groups, lack of support system from the family, lower social economic classes, unintended pregnancies, substance or alcohol abuses, NICU stays, birthing complications, and feeding difficulties. So etiology, various theories have been postulated like hormonal excess or deficiencies of estrogens, progesterone, prolactin, thyroxine, or tryptophan. So what happens when there is postpartum depression? It impairs the relationship between the bonding between the mother and child, decreases the rates of breastfeeding, decreases the interest in caring for the baby, increased risk for the behavioral and mood disorders in the child. There is an increased risk of domestic abuse and child neglect. So symptoms of postpartum depression: hopelessness, helplessness, persistent sadness, irritability, low self-esteem, loss of pleasure in activities, mood changes, sleep and appetite disturbances, anger, inability to adjust to the role of motherhood, inability to concentrate. Symptoms ranges from mild dysphoria to suicidal tendencies to psychotic depression. These symptoms doesn't last for just a few days. Half of the women are asymptomatic for nearly 6 years. One of the women continue to be symptomatic at 12 months, especially if they are. Impact of postpartum depression. Potential impacts will be on baby: delayed cognitive and psychological development. Baby will be fussier, delayed motor skills, and increased healthcare resource use. So there will be disturbance in the marriage relationships and partner relationships. So what can be done in such situations? Screening, whether all women to be screened or certain women to be screened. Why to be screened? Because women may be unable to recognize if she is depressed, may believe her symptoms are normal for a new mom, fear being labeled as a bad mother if she admits her bad experiences. Maternal experience does not meet the society's picture. So she may be fear of her baby will be taken from her side if admits to her crazy symptoms. So when to screen this woman? At preconception visit, during prenatal intake and subsequent visits, during postpartum checkups, at the first postpartum checkup, and at family planning visits during the first year of postpartum. So what are the screening tools available? Edinburgh Postnatal Depression Scale. First thing, it is a sensitive but not specific. It is designed for home or OP use. 10 questions will be there, can be completed within 5 minutes. 0 to 3 scores depending upon the severity. 9 or less indicates low for depression. 10 to 12, modest concern for depression. 13 to 18, moderate concern. 19 and above are considered as severe depression and worry about the suicidal tendencies. So next score will be PHQ-9, Patient Health Questionnaire. These symptoms, consists of 9 items. Within the symptoms in the past 2 weeks, high sensitivity 88% and specificity will be 88%. So both high rates of sensitivity and specificity. Next, 20-item questionnaire based on CESD, Center for Epidemiological Studies Depression Scale. It is a 20-item questionnaire based on symptoms in the last 7 days. So more than 16 will be considered as depression. One more scale, postpartum depression screening scale will be there. More than 7 items are included in the initial screening. More than 14 will be considered as depression, and extensive survey will be done in such cases, which includes 28 additional items. So we can screen. So we have to be familiar with the tool, its validity and its limitations. When we are screening, we have to referral and referral. We have to have a referral network available for the women who are screened positive. Document the screening and referral if we have made. Follow up with the referral doctors and inquire. So treatment consists of psychological treatments, that is talking treatment, usually first line treatment, consists of 3 types. Guided self-help, which involves working through a book or online course on your own or with the help of a therapist. It includes 9 to 12 weeks of duration. Next is cognitive behavioral therapy. It can be carried out either one-to-one with a therapist or in a group discussion. So duration will be 3 to 4 months. Interpersonal therapy, which involves talking to a therapist about problems experiencing by her. In duration is 3 to 4 months. Next, antidepressants, selective serotonin reuptake inhibitors, fluoxetine, sertraline. Fluoxetine will be 20 mg per day. Effective dosage, sertraline 50 to 200 mg per day. Few studies have shown effective results. When these are not effective, serotonin non-epinephrine reuptake inhibitors, venlafaxine may be used. Other methods, transcranial magnetic stimulation. This is a non-invasive and uses the magnetic waves to stimulate and activate the nerve cells. People whoever are in depression, they have less nerve cells. So when we use this transcranial stimulation, they activate these nerve cells and results will be there. Usually done in 5 times a week for 4 to 6 weeks. Side effects are headache, lightheadedness, scalp discomfort, and facial muscle twitching. Other methods like exercise, yoga, acupuncture, vitamins, omega-3 fatty acids, folic acid, bright light therapy are other methods. Take-home messages, postpartum depression is relatively common, may have long-term consequences for the mother, infant, and the family, easily missed, but should be screened for them and can be treated successfully. Thank you, ma'am. Thank you, Sampath ma'am, for giving this opportunity. Thank you, TNFOG and Kasoga team. Thank you, ma'am.
Thank you, Sindhura madam. That was an excellent presentation, starting from screening and diagnosis and ending with the various treatment modalities. That was an excellent presentation. Thank you.
Thank you, ma'am. Thank you.
1 minute, Dr. Sindhuri. Dr. Sindhuri.
Yes, ma'am. Madam is online.
Yeah. I mean, what do you think of the cause of this postpartum depression? Because we were in obstetric practice since almost 3 decades, 35 years, but we haven't come across so much of postpartum depression as nowadays. So you have to stress on family association, because giving childbirth, delivering a child, and it's a welcome to the family and it's a happy occasion. So during antenatal visits itself, we have to teach them, and we have to involve all the family members, mother-in-laws, everybody. Nowadays, we are seeing only the husband and wife are coming to the antenatal room checkup. So this factor should be, those days when we started our practice, 3 or 4 people will come for the antenatal checkup. So we have to remove the cause of being loneliness. That will be the main cause, I think so. Okay, next speaker then. Dr. Malini, can you introduce the next speaker? Yeah.
I'm happy to introduce Dr. Vanitha Rukmani madam. Madam has done as her UG in Madurai
Vanitha,
Medical College.
CV is not there?
Yes, ma'am, it's there.
Okay.
Madam has undergone undergraduation at Madras Medical College and DGO at Stanley Medical College and MSOG in Taini Medical College. Madam is at present Senior Assistant Professor at Taini Medical College. Madam is a consultant obstetrician and gynecologist in Taini. Madam is the executive member of TNFOG and secretary of the Taini Obstetrics Society. She is a speaker and organizing secretary for FOXY meetings in Taini. She has presented papers in many state and nation conferences and published many papers in national and international journals. Her special field of interest is high-risk obstetrics and infertility. Welcome you, ma'am.
Thank you, madam, for the kind introduction. I thank TNFOG, Dr. Revati Janakiraman madam and Dr. Sampath Kumari madam for the invitation. My topic is acute tocolysis. Tocolytics word starts.
Sorry to interrupt, ma'am. Can you make it full screen, ma'am?
You just click on the slideshow.
Yes, ma'am.
And from beginning.
Yes, ma'am.
To the left, there is from beginning, ma'am. You can click on that. Yes,
So
ma'am. Thank you.
today is acute tocolysis. It arises from the Greek word tokos, which means childbirth, and lytics, which means capable of dissolving, to terminate the childbirth. The definition is, it refers to the pharmacological agents to relax the uterine myometrium and to abolish the uterine contractions and benefit to the mother as well as to the
ಟೈಪೇ ಮಾಡ್ತಾ ಇದ್ದೆ ನಾನು. I wanted to tell you, ನಿನ್ನ ಹಿಂದ್ಗಡೆಯಿಂದ
know some definitions regarding uterine tachysystole, which is 5 or more contractions in 10 minutes over a period of 30 minutes. And hypertonus is contractions with a duration lasting more than 2 minutes, contractions of normal duration occurring with a relaxation time of less than 60 seconds. And why do we need tocolytics? This is to prevent preterm labor, because preterm labor is responsible for 75 to 90% of neonatal mortality and more than 50% of neurodevelopment disability occurs. So these complications are more if the delivery is less than 34 weeks of gestation. And what is the rationale behind tocolytics? Various meta-analysis and research reviews prove that tocolytic agents are effective for up to 48 hours and may prolong pregnancy for up to 7 days, but does not show any significant reduction in perinatal mortality and morbidity. So what are the benefits of tocolytics? They are administered to optimize the time in utero and for administration of corticosteroids for fetal lung maturity and to facilitate transfer of the patient to a tertiary care referral center. The indications could be to reduce the preterm labor with confirmed gestational age between 24 and 34 weeks, and patients with regular uterine contractions of at least 30 seconds at a rate of 4 per 30 minutes, with a cervical dilatation of 1 to 3 cm and effacement of 50% with the normal fetal heart rate. Other indications being hypertonicity of the uterus in breech delivery, in shoulder dystocia, retained placenta, acute inversion of uterus, intrapartum version of fetal malpresentations. So what could be the contraindications? There are some contraindications, namely the chorioamnionitis or sepsis, preeclampsia and eclampsia, placental insufficiency, placental abruption, abnormal CTG, IUD. The classification of tocolytics being beta-2 agonist in the earlier days, terbutaline, isosuprine, ritodrine, magnesium sulfate, calcium channel blockers, nifedipine and nicardipine, oxytocin receptor antagonist, atosiban, non-steroidal anti-inflammatory drugs, and progesterone. So what is an ideal tocolytic agent? It is a uterospecific and it should have short-term as well as long-term benefits, and it should be safer to the mother and fetus, and it should be at an affordable cost. And there are some studies which support the tocolytic agents usage. So coming on to atosiban, it is the first tocolytic of choice current scenario, and it is an oxytocin antagonist and inhibits the uterine contractions. It acts only on the myometrium and myoepithelial tissue, which is uterospecific, and it has got a rapid onset of action, and it reduces the uterine contractions within 10 minutes and achieves uterine quiescence for 12 hours. So what is the dosage? The dosage is, so slide is it is given in 3 steps. Initial IV injection of 6.75 milligrams in 0.9 ml, which is slowly injected over a period of 1 minute, and continuous infusion at a rate of 24 ml per hour for up to 3 hours, total of 300 micrograms, and continuous infusion at a rate of 8 ml per hour up to 45 hours, total of 100 micrograms. So what is the advantage? It has got a very low incidence of maternal and fetal adverse effects, and it is safest in multiple pregnancies, anemia, and expanded blood volume states where other tocolytics will lead to pulmonary edema. So regarding infant safety, according to current meta-analysis study, no fetal side effects have been reported, and the follow-up study also noted no risk effects on the psychological and motor developmental. Regarding breastfeeding, no adverse effects on breastfeeding, while beta mimetics show some reduction in the milk production. Moving on to calcium channel blockers, These drugs reduce the intracellular calcium levels by blocking the transmembrane calcium transport. So the drug of choice is nifedipine, which is given at an initial dose of 20 milligrams, followed by 3 further doses of 20 milligrams every 30 minutes if the contractions continue. And the maintenance dose is 20 to 40 milligrams orally, 4th hourly for 48 hours, and not more than 160 milligrams per 24 hours. And caution with doses more than 60 milligrams. Moving on to magnesium sulfate, it is also given for fetal neuroprotection. It acts by inhibiting the myometrial contractions, and the IV loading dose is 4 grams over a period of 30 minutes and maintenance dose of 1 gram per hour till delivery. And the side effects are cardiac arrhythmias and hypocalcemia, and it is contraindicated in myasthenia gravis. So this atosiban is as effective as nifedipine with few cardiovascular side effects, but the nifedipine is not uterospecific, so it has got some side effects when compared to atosiban. Moving on to beta agonist, these reduce the sensitivity to calcium and total intracellular calcium concentrations, causing myometric relaxation. But they are reduced rarely because of their adverse side effects being palpitations, tremor, tachycardia, pulmonary edema, myocardial ischemia, and hyperglycemia. Coming on to terbutaline, which is still used for emergency treatment of intrapartum uterine hyperstimulation to prevent fetal bradycardia. It is given as 250 micrograms subcutaneous or 0.5 ml by slow IV. Monitor the blood pressure and heart rate before administration and every 15 minutes for 1 hour after administration with continuous electronic fetal monitoring. And the specific antidote is metoprolol. Regarding ritotril, it is started by IV infusion in 5% dextrose, 50 micrograms per minute, and it is increased by 50 micrograms per minute until the contraction stops or the toxicity develops. Maximum dose of 350 micrograms per minute is given after 12 hours oral therapy with 10 to 20 milligrams every 4 to 6 hours. Regarding isosuprene, it is given as 60 milligrams in 500 ml of 5% dextrose, 8 drops, and the maintenance dose of 60 milligrams per day. It is given oral or IM, and it should be stopped when there is a tachycardia of pulse more than 140 with hypotension or pulmonary edema. Regarding NSAIDs, indomethacin is given as 100 milligrams per rectal, followed by 50 milligrams per oral every 6 hours for 8 doses, and the side effects being premature ductus closure, oligohydramnias, necrotizing enterocolitis, and intraventricular hemorrhage will occur. Progesterone are also being used to prevent the preterm labor, and the dydrogesterone 10 milligrams orally daily can be given twice a day, and the micronized progesterone 200 micrograms twice a day can be given. Vaginal progesterone of 100 micrograms daily. Regarding nitric oxide donors, injection NTG 50 to 100 micrograms per ml is given, or a nitrodome patch of 10 milligrams. In summary, the first line drug of choice being atosiban and nifedipine, and the maintenance therapy of tocolytis does not improve the perinatal outcome and so not recommended, and use of multiple tocolytic agents are also not recommended due to adverse side effects. Thank you.
Please unmute, ma'am. Chandra Panuswamy, ma'am.
Okay. Thank you, Vanita, for your excellent presentation. It was a lucid, clear presentation. And you can take up the questions in the chat box because we are running out of time, it seems. Okay. Dr. Malini. So now I would like to introduce Dr. Sushma Dev. She is Associate Professor, Mysore Medical College and Research Institute, and she is the Director and Chief Consultant of Aishwarya Hospital, Mysore, and she is the President of SMFF Mysore Chapter 2022 to 25, and she is the Chairperson Quiz Committee of Karnataka State OG Association, and she is the Secretary of Mysore OG Society 2022, and she is a member of Endometriosis Committee, MTP Committee, and She has got award of Dr. M.G. Hayarmat Yuva Oration, and she did her MBBS from Mysore Medical College and MSOG from JIPMET Pondicherry, and she has done diploma in gynec endoscopy, and she has got 15 years of undergraduate and postgraduate teaching experience, and now she's going to deliver her lecture. Please, yeah, Doris is yours, Dr.
Thank you so much, ma'am, for the kind introduction. Shall I share my screen?
Yes, ma'am.
It is visible, right?
Yeah.
Yeah. Very good morning, everyone. Firstly, I would like to thank the team of the today's conference, the TNFOG, and especially Vidya Tobi ma'am and also Rajashri ma'am and Sampath Kumari ma'am for giving me this opportunity. It is indeed a honor and great pleasure to be part of it. My topic is thromboprophylaxis in labor and delivery. Indeed, a very interesting and topic. Before we go into the details, let us look at the magnitude of thromboembolism. The venous thromboembolism is the third leading cause of maternal death in the developed world. And when you look at the WHO statistics, which dictated the maternal deaths in the 2015 years, so here when you consider the whole world, the maternal mortality from the VTE is contributed by about 3%, and it stands about 7th place. So when you take globally, it still has a significant mark as a cause of maternal mortality. So it's an important cause of severe maternal morbidity as well. And in pregnancy, the risk of VTE is increased about 4 to 6-fold compared to the non-pregnant population. So the incidence generally ranges to 2 per 1,000 pregnancy. And it's very important to understand that it's the leading important situation wherein we can prevent the death in the hospitalized patients. And the drawback is that often we don't have neither the time or there is a delayed diagnosis and we may not initiate the treatment. This was one of the newspaper article which was put up, and one of the lady, a pregnant mother, postnatally succumbed to the thrombotic episodes and the doctor was sued. So these are the situations which we see commonly in the current practice, and we should be thorough in our knowledge and how we evaluate, and we should be managing our mothers in the pregnancy and also postnatally and prevent mortality from the thromboembolism. So the scenario in India. So these are the articles, the data from the Indian publications, which clearly say that the prevalence of DVT in India is almost similar to the Western population, but only thing is we need to have our eye on concentrations and work towards the early diagnosis. And we have many literatures dictating that in India also, we see a significant number of VTE in pregnancy. So this is the Virchow's triad. So as we see in pregnancy, it predisposes all the factors responsible for the thromboembolism, that's the venous stasis, endothelial injury and everything. And of course, the pregnant mothers are at increased risk of this venous thromboembolism. Then when we look at the situation in the pregnancy, so the fatal antenatal death significantly occurs throughout the pregnancy and also in the postpartum periods. Primarily in the VTE, we have the DVT and also the pulmonary embolism. We commonly see deep venous thrombosis more in the antenatal period because of the venous stasis. But the pulmonary embolism, which is more often seen in the postpartum period, is an important cause for the maternal mortality. And of course, it is seen as a part of the antenatal as well. But when it comes to the maternal mortality, pulmonary embolism gives a major contribution. And when we look at the incidence, the majority of the women in the pregnancy, that is the maximum cases of VTEs occurs in the postpartum period. That is almost about 5 times more than in the antenatal period. Even in the antenatal period, we have the first trimester higher incidence of these VTEs.
So when we consider the postpartum VTE risk compared to the general population that's non-pregnant, the increased risk of VTE is almost 20 to 80-fold compared to the non-pregnant. That is such a high risk of VTE that every postpartum mother is exposed. And absolute risk peaks in the first 3 weeks of postpartum, and the lady needs to be followed up to the 6 weeks postpartum, and when there is a gradual decrease in the risk of this VTE. So these are the publications which say that published in the, that is, these are the large meta-analysis and meta-analysis and systematic reviews, and also the publications depicting the pulmonary embolisms in the postpartum period, which say that the postpartum period is the significant risk factor for the VTE, and also pulmonary embolism is an important cause for the postpartum maternal death. When we come to the maternal mortality and association with the pulmonary embolism, the situation is the tip of the iceberg. That is, given the obstetric pulmonary embolism mortality rate of about 3%, with nearly 25% of all the VT events which manifest as the pulmonary embolisms. So suppose a lady of pulmonary embolisms dies, and we would have already seen 132 cases of VTEs. So which means that tip of the iceberg is we only see the mortality cases due to the embolism, but behind that we have a large iceberg wherein we would have missed nearly 130 cases of venous thromboembolism. So this is the large burden of the thromboembolism risk which our mothers are exposed. Apart from this, the VT is associated with the significant morbidity and also the long-term impacts, which are the recurrent VTEs and the pulmonary embolisms and the post-thrombotic syndromes, which complicates up to 50% of the DVT patients and may lead to chronic leg pain, edema, erythema, ulcerations, lung affections, and also cardiovascular impact. The main role, that's the prevention, and to prevent all these complications, is the prophylaxis. VTE prophylaxis, as we discussed, this is the preventable cause of death, and this is the single cause of death which can be prevented by our systematic change in the clinical practice. So when we come to the management, we look at the VTE bundle, which is proposed by the Council of Patient Safety. So very importantly, a pregnant mother walks into us. All the pregnant mothers should be assessed for the VTE risk at multiple intervals, regularly, systematically in the pregnancy, primarily 4 situations. That is at the booking visit, any time of hospitalizations in the pregnancy, and birth hospitalization, that is when she gets admitted for the delivery, and also at the time of discharge in the postpartum periods. This bundle includes 4 R's, that is readiness, recognition and prevention of these episodes, response in terms of the thromboprophylaxis, and very importantly, reporting and systematic learning, whereas every maternity unit should be trained in a systematic way to analyze and to chart the risk factors and train the staffs and also update themselves with regard to the recent guidelines and the management protocols. And every institute should have this bundle follow-up and the management protocol in their institute, which should be part of the regular antenatal and the labor care. To propose the management guidelines, we have these following guidelines proposed by the Royal College of Obstetrics Gynecology, ACOG, the American College, and also ACCP, that's the American College of Stress Physicians, and National Partnership for the Maternal Safety. And maximum guidelines are taken up from the Royal College, and which is widely practiced worldwide. The RCOG guidelines, that's the Green Top guideline number 37A, which is proposed in 2015, that is the reducing the risk of VTE during pregnancy and postpartum. So here, this gives a systematic risk stratifications of all the pregnancies and also the postpartum situations, and the scoring is given. At the end of the total scoring, women are categorized, and the way we put the thromboprophylaxis protocols are analyzed. If the total score is 4 or more antenatally, you should consider thromboprophylaxis from the first trimester itself. If the total score 3 antenatally, consider thromboprophylaxis from 28 weeks. If the total score is 2 or more in the postnatal period, consider consider thromboprophylaxis for at least 10 days. If admitted to hospital antenatally, definitely consider thromboprophylaxis. If there is a prolonged admission of 3 or more days, which is very important, that we often miss our admitted patients giving any prophylaxis and risk stratification or readmission to the hospital within the puerperium, thromboprophylaxis should be given. This is the proposed chart of risk categorization by the RCOG. Here, when you look at that previous VTE and also the OHSs, the immediate score is 4. They put themselves at the risk of highest VTE risks, the OHSs, especially in the first trimester. And apart from that, we need to know the what other risk. That is the previous VTEs provoked by the major surgeries, known high-risk thrombophilias, which includes heritable and acquired thrombophilias. In the acquired, we have the antiphospholipid antibody syndromes, which we commonly see in our pregnant mothers, and also the medical comorbidities, there's cardiac disorders, lupus, and also autoimmune disorders, diabetes, nephropathy, sickle cell. So these are the candidates for prophylaxis. And very importantly, family history of unprovoked VTEs and known low-risk VTEs as well. Very importantly, is that is more than 35 puts you the woman at the risk of VTE, obesity, multiparity, smoker, and varicose veins. When we look at the obstetric risk factors, preeclampsia is a bad news. Preeclampsia in the pregnancy, so puts the woman at risk. And IVF conceptions, currently with the upsurge in the IVF conceptions, it definitely puts the women at the risk of VTE, and they should be on thromboprophylaxis. Multiple pregnancy. When it comes to cesarean, the emergency cesarean poses a higher risk compared to the elective, and also the instrumental deliveries, prolonged labor, PPH, blood loss more than 1 liter, preterm labor, and stillbirth. All this puts the women at risk of VTE risk. And also transient risk factors, that is the, suppose the woman undergoes any surgeries during the antenatal period, this puts the women at transient risk of venous thromboembolism. Another important situation, the immobility. Suppose the woman is almost bedridden or inactive in a pregnancy, and of course dehydration due to hyperemesis can also put the women at risk of VT. And current systemic infections, because we had an era of COVID wherein all our women were at risk of VTEs, so and they needed thromboprophylaxis. So, and also we classify the risk as low risk thrombophilia and high risk thrombophilia. Low risk, we have the factor 5 and the protein CS deficiency. And high risk thromboprophylaxis, that is factor 5 homozygous, and homozygous gene mutations puts the women. And very importantly, APS, antiphospholipid, puts the women at high risk thromboprophylaxis, requiring the anticoagulation throughout the pregnancy and also postpartum. This is the proposed thromboprophylaxis protocol in the antenatal period and also the postnatals. So I cannot just jump into the postnatal prophylaxis without giving at least we need to have a minimum information on the antenatal prophylaxis. So as we know that we have risk categorized the women based on our categories. So suppose the lady is a high risk category, she requires antenatal thromboprophylaxis with the low molecular weight heparin, and also you need to take the consultation with the hematologist for the follow-up with the this thromboprophylaxis. Suppose the woman has an intermediate risk, consider antenatal thromboprophylaxis with the low molecular weight heparin. And if she has 4 or more risk factors, prophylaxis, as we discussed, prophylaxis should be given from the first trimester, and she has 3 risk factors, 28 weeks, we should start the thromboprophylaxis. If she's a low risk category, no need of thromboprophylaxis, but we should encourage the women mobilizations and adequate hydration. She should be ambulating, active in the pregnancy, she should not restrict her activities unless she has other obstetric indications for rest. And when it comes to the postpartum thromboembolism prophylaxis, so very importantly, the women with high risk, there's the history of previous VTE and high risk thrombophilias and family history of thrombotic episodes and low risk thrombophilias. So they require, of course, the antenatal prophylaxis as well, and they need to go for a postnatal thromboprophylaxis should be continued definitely for 6 weeks, not just in the immediate postpartum period. That we need to take home as a message. And when it comes to the intermediate risk factors, where there is woman is morbidly obese, short-term surgeries, and she has low risk autoimmune disorders or medical disorders. So we need to give the woman short-term thromboprophylaxis as long as she's in the hospital, at least for about 10 days. And suppose she has additional thrombotic risk factors, we have to discuss with the hematologist for the need of continuation of the thromboprophylaxis for some more days. Suppose she doesn't have risk factors or 1 or 2 less than 2 risk factors, only recommended is the early mobilizations and adequate hydration. In grossly, we can consider 4 or more risk factors. Give prophylaxis throughout the pregnancy and 6 weeks postpartum, and 3 risk factors start prophylaxis at 28 weeks and continue till 6 weeks postpartum. And she has 2 risk factors, just give only postpartum thromboprophylaxis for 10 days. This is what we need to commonly practice, especially when we are doing a C-sections. It is more so in the emergency situations. Now let's discuss the agents which we use for the thromboprophylaxis. So these are the anticoagulants, that is low molecular weight heparin and unfractionated heparin. And primarily we give the heparin in the form of prophylaxis and the therapeutic heparin. So gold standard and the drug of choice is the low molecular weight heparin. Enoxaparin dose for the prophylaxis is the 40 mg once a day, and unfractionated heparin is given as 5,000 subcutaneous BD as proposed by the ACOG. For dosage, that is 1 mg per kg BID dosage, and unfractionated heparin, we have to give 10,000 units or more in divided doses. And you have to maintain your APTT values between 1.5 to 2.5, which has to be monitored regularly. So all of us know the difference and the benefits and the choice of the drug in the prophylaxis. There's the drug which is choice is the low molecular heparin, because it has got a better bioavailability, long duration administration, less side effects, less risk of heparin-induced thrombocytopenia.
I think Sushma ma'am, internet is a problem.
Screen stuck.
No. Sushma ma'am, internet some problem. We'll wait for 2 minutes.
Okay. It has to be reconnected, I think.
Yeah. Ma'am, you're muted, ma'am. The internet is gone. Sushma ma'am, your internet is...
I'll just share again. I need to share?
Yeah, please. Yeah, please, ma'am. Yeah.
Okay. Hope I did not miss the connection for long. Is it visible?
Yes.
Yes,
Visible. Sorry for the interruption. The drug of choice is the low molecular. It's visible, right?
Yes.
Yeah. Thank you. The drug of choice is the low molecular weight heparin for the prophylaxis, and oral antithrombin inhibitors, that is the newer anti-10A inhibitor, that is rivaroxaban. All these are not recommended in pregnancy, and only in the presence of heparin hypersensitivity, pantoporonax and IV direct thrombin inhibitors can be considered. But of course, we always use low molecular weight heparin in our clinical practice. Warfarin is only indicated in the presence of situation where heparin may not be suitable, that especially in the mechanical heart valve replace situations. So as we discussed, the woman has to be categorized throughout a pregnancy to know her risk categorizations. So I'll be concentrating the discussions for my topic, that is the birth hospitalizations and discharge, how we discharge the women and what is the protocol. These are the special situations which I'll be discussing, that is birth hospitalization, that when the woman gets admitted for the delivery. So very importantly, ambulation and placement of mechanical compression devices. It can be pneumatic or a DVT. Stocking should be encouraged in the women prior to the cesarean, and it has to be used in the postpartum period as well in all the women. And for the women who undergo cesarean section with additional risk factors, and suppose they have a thromboembolism risk factors, you can consider adding heparin along with the mechanical compression device. So this is the guideline proposed for the VTE prophylaxis in the situations of cesarean sections. That is when the woman is low risk, nothing is necessary except the ambulation, early ambulations, or we can consider using the mechanical prophylaxis in view of DVT stockings. Suppose she has a medium risk factors, that is cesarean section with the one major risk factor or two minor risk factors. So along with the mechanical prophylaxis, we can use the short dosage of short duration, that's up to 10 days of low molecular weight heparin prophylaxis. Suppose she is a high risk candidate with inherent thrombophilia. Most of the situation, these women are on antenatal thromboprophylaxis as well. So they need to continue along with the mechanical prophylaxis. The heparin should be continued for a long duration, definitely till 6 weeks of postpartum period. So even in the very high risk categories, so you have to decide whether they require only prophylactic dosage or the therapeutic dosage of thromboprophylaxis for a long duration. That has to be discussed along with the hematologist. So looking into the categorizations, when they require the therapeutic dosage, especially if they have multiple prior VTEs and prior VTE with high risk thrombophilias, antiphospholipids, so they have repeated recurrent episodes of VTEs, we should consider therapeutic thromboprophylaxis in these women. So other guidelines proposed for the cesarean birth VT prophylaxis are, we discussed the RCOG, that is ACOG, ACCP guidelines. So the overall guidelines all are similar, that they recommend in intermediate risk categories, as long as the patient is hospitalized, we have to give a prophylaxis. And in a high risk individual, we have to give 6 weeks postpartum thromboprophylaxis in all the women. And also the vaginal birth, of course, the vaginal birth is always safer and it carries the least risk of thromboembolism in the pregnant woman. But still, suppose she has additional risk factors, especially if she's a morbid obese and she doesn't have any other risk factor except for the obesity, only mechanical prophylaxis may be enough for some individuals. Suppose she is morbidly obese and she has prolonged hospitalization and she's also has other low risk thrombophilia risk factor, which puts her to medium risk factors. In that woman, along with the mechanical prophylaxis, we have to propose postpartum low molecular weight heparin prophylaxis for as long as she stays in the hospital for 10 days or 5 days, depending on the clinical situations. And suppose along with the morbid obesity, vaginal delivery women also have a high risk factors of VTEs, so she definitely will require prolonged thromboprophylaxis in the postpartum period. And it is a special situation that we commonly encountering because of the morbid obesity, because of their lifestyle changes. It's a very common that we encounter morbid obese women. In these women, we have to consider, because we may not be able to initiate enoxaparin in the immediate postpartum. So very important that we initiate the thromboprophylaxis as early as 6 to 12 hours. So we can start with the unfractionated heparin initially and later on switch over to low molecular weight heparin, and the dosage, as we discussed, should be titrated according to the woman's weight. So this is a very important discussion, that is neuraxial blockade, whether you're giving a spinal blockade or epidural, and how to manage the thromboprophylaxis. So what is the time gap between starting the subarachnoid blockade and what should the gap of, that is the stoppage? This was proposed by the Society of Anesthesia and the Perinatology consensus, and this chart will show that. So the guidelines are different for the unfractionated heparin and also for the low molecular weight heparin. So for when the woman is receiving a low dose unfractionated heparin in a prophylactic dosage, so we need to have a 4 to 6 hour gap from the last dosage before we go ahead with the neuraxial blockade. And suppose she's on an intermediate dose of 7,500 to 10,000 units, so we need 12 hours of gap, and she's on a therapeutic dosage, we need to have a 12 hours gap from the last dosage before we initiate the epidural analgesia or a subarachnoid block. The situation with the low molecular weight heparin, that is, if she's on a low dose prophylaxis, we need 12-hour gap from the last dose. We initiate the neuraxial blockade. Suppose she's on a high dose low molecular weight heparin, 24 hours. This is 12 hours and 24 hours. Suppose there is no time gap, we need to defer the giving the neuraxial blockade. Otherwise, there will be significant risk of hematoma in the epidural pathway. And very importantly, then how early should we restart the thromboprophylaxis following a neuraxial blockade? Very importantly, low molecular weight heparin. So we have to wait for 12 hours before the first dose of low molecular weight is given following a surgery. That's the following the subarachnoid blockade. And we have to wait for at least 4 hours after the epidural catheter is removed, provided the 12 hours has been elapsed since the cesarean, probably 12 hours for the from the time of the neuraxial blockade and 4 hours extra for the removal of the catheter, we can initiate the subsequent dosage of thromboprophylaxis. And suppose she needs a therapeutic dosage, you have to give her 24 hours gap before we start the first dose of heparin. So this is an important point which I wanted to stress, even though my topic is postpartum. That's because we really don't consider admission in the hospital as a risk factor at all. Suppose the woman is admitted for 2 to 3 days, it increases the VT risk about 4 times. And suppose she's hospitalized for more than 3 days, it increases the VT risk to 12 to 18 times from the non-pregnancy. It's a significant risk factor which the woman is put to. So the protocol is similar. Suppose she's on a long stay in the hospital, which puts herself into a medium risk category, and she will require a short-term thromboprophylaxis as long as she stays in the hospital, and she should be encouraged for early ambulation and adequate hydration. And suppose she has additional VTA risk, and we have to consider dosages according to the individual risk assessment. Very important, when the woman is admitted, we have to encourage ambulation, avoid dehydrations, and of course, as long as the situation is mandatory, then only we should necessitate the admissions. Routine admission, whenever the situation can be managed on OBD basis, we better defer the unnecessary hospital admission to the women. With this, we come to the take-home message. The pregnancy itself is a thrombotic status. Every woman should be assessed for the risk factors. The decision for the thromboprophylaxis should be individualized. Low molecular weight heparin is the drug of choice, and the threshold for the recommendation of thromboprophylaxis should be lower. We should have a very low suspicion that a low threshold to start a thromboprophylaxis, because the risk is very high for the VT and the duration of treatment is very short. If we delay our the prophylaxis, we might be ending up in a pulmonary embolisms, which is a mortal situations. So the below one is the theme for World Thrombosis Day, which is celebrated worldwide on 13th October. The theme was 2021 was the eyes open to thrombosis. We should pledge as this forum that we should have a high index of suspicion and low threshold, and we should keep our eyes and minds to for the thromboprophylaxis in pregnancy. And very importantly, what is the future of thromboprophylaxis? So this is the era of artificial intelligence. In future, the additional biomarkers which predict the VTE and safer medications and machine learning algorithms are already being proposed and still in the research levels. They will revolutionize the prevention and the prediction of venous thromboembolism. Thank you, organizers. At this forum, I take the privilege to welcome all of you for the FOXY South Zone Conference, which Mysore will be hosting in 2024. It's an immense pleasure that we see you all at Mysuru in 2024, and date will be shortly announced. We wish to see you all in Mysore. Thank you so much for the wonderful opportunity.
Thank you, Dr. Sushma, for your elaborate, excellent presentation. There is a request for PPT of Dr. Vanitha and Dr. Sushma from delegates. I don't know what the organizers are going to do. And I congratulate all the 3 speakers of this session for their excellent presentation. And thank you very much.
Thank you so much, ma'am.
Thank you so much, the chairpersons and the speakers, for a wonderful session. I request the speakers to answer the questions in the chat, question answer box, which I think in the first session also there are a few questions to Kritika ma'am and Gomti ma'am on NVP and preeclampsia. So I request the speakers to please answer them in the question answer box, as we have paucity of time. May we move on to the session number 3, that is a very important topic, keynote address on the near miss maternal mortality, the need to audit our heroic saves. I invite the chairpersons for the session, Dr. Shailaja Bidri ma'am and Dr. Shubha Ramarao ma'am. Dr. Shailaja Bidri ma'am, she is presently she's professor and HOD, Department of Obstetrics and Gynecology from BM Medical College Hospital and Research Center, Vijaypur. She has a teaching experience for undergraduate 27 years and PG 12 years, and she has many publications to her credit. She has she's project done international projects. She has coordinated with the Cradle 4 trial completion meeting, and which was conducted at London, and she has many paper presentations to her credit. And she was awarded as a senior scientist by BLD University and for her community service. Thank you, ma'am. We welcome you, ma'am. Dr. Shubha Ramarao, she is a senior consultant and HOD at St. Martha's Hospital. She was a president. She is president BSOG 2023 and 24, DNB teacher, and has an experience of 32 years. She's a life member of BSOG, AGOI, and BMS. She's vice president BMS, and she's been a faculty at all the national and many international conferences. Thank you so much, ma'am. We invite you for the conference. We request our chairpersons to introduce our speaker, Dr. Shubha SS.
Yeah, am I doing it or who's doing it?
Yeah, any of you, ma'am, Dr. Shailaja, ma'am, or you can just go on, ma'am. Dr. Shubha SS.
Yeah, at the outset, let me thank the organizers, the team Kasoga, especially Dr. Vidya, who was instrumental in calling me up and putting me on this program, and also the team from Tamil Nadu, which has given us this opportunity to share this session. Well, I have the pleasant duty of introducing Dr. Shubha SS, my namesake, but there is little difference in the spelling. She is an MD, DGO professor and HOD at Salem. She has had 25 years of experience of unblemished service, 21 years of undergraduate and postgraduate teaching experience. She is a master trainer in emergency obstetrics, Government of India. And she has published 20 original articles in national and international journals. She has got the Best Doctor Award, Chennai in 2015. And she's got the Best Performance Award in 2017 and 2018, given by the Salem District Collector. And also she has organized many CMEs and has presented papers in national conferences. So today I present to you Dr. Shubha SS for her keynote address.
Thank you, ma'am. Thank you for the kind words. I thank KSOGA and TNFOG for the opportunity, and a special thanks to Dr. Sampath Kumari ma'am, who has given me this opportunity to present in this forum. Today's topic is maternal near miss, why we need to audit our heroic saves. So what is maternal near miss? So a woman who survives life-threatening conditions during pregnancy, abortion, and childbirth, or within 42 days of pregnancy termination, irrespective of receiving emergency medical or surgical interventions, is called maternal near miss. WHO defines maternal near miss as a woman who already died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. So maternal near miss cases are more common than maternal deaths, and maternal near miss review yields valuable information regarding the severe morbidity which could lead to the death of the mother if not intervened properly at the right time. And all maternal near miss cases should be interpreted as free lessons and opportunities to improve the quality of service provision. So this is the burden of maternal near miss. Out of the total pregnancies, 75% are non-complicated pregnancies. Of the remaining 25% complicated pregnancies, we have around 9% of pregnancies with potentially life-threatening conditions, which may lead to either maternal near miss or maternal death if not intervened properly at the right time. So this is the spectrum of maternal near miss. So why near miss audit is important? Because near miss and maternal mortality, they have similar pathology and complications of pregnancy. By evaluating the maternal near miss cases, much can be learned about the causes and processes in place to tackle them. So maternal near miss cases are more common than maternal deaths, which by reviewing this, we get a comprehensive profile of the functioning of the healthcare system. And it shares the same pathway like normal pregnancy, morbidity, which leads to severe morbidity and leads to maternal near miss. And if not intervened, it may lead to maternal death. And maternal death review process is a potential threat to expose to public inquiry and outrage. But in maternal near miss review, it is less threatening to service providers and more valuable information can be obtained and utilized for improvement of obstetric health and reduction of maternal mortality. So maternal near miss review enables us to learn from the maternal near miss reviewer survivors, as women themselves are available for interview about the care they receive, and they can share their experiences in ICU and psychological devastation and trauma faced from severe maternal illness and being separated from the newborn. And maternal near miss review provides valuable information about social and family problems, lack of awareness of healthcare facilities, or any level of delays and which can be identified where they occur. And significance in reducing maternal mortality, and it is complementary to maternal death review in the appraisal of maternal health. And corrective actions to fill the gaps. So identifying gaps and reasons from severe maternal morbidities to take corrective actions and fill the gaps and improving the service delivery. So these are the utilities of maternal near miss audit. It determines the frequency of severe maternal complications, maternal near miss cases, and maternal deaths. And it helps us to evaluate a healthcare facility system's performance and determine the frequency of the use of the key interventions for the prevention and management of severe maternal complications. And it raises awareness and promote quality of care and foster towards the improvement of maternal health care. And maternal near miss assumptions, all maternal deaths involve at least one life-threatening condition. It can be an organ dysfunction. A substantial proportion of them have severe pregnancy-related complications like severe PPH or preeclampsia, or receive critical interventions, ICU care or transfusion. And in the year 2007, WHO established a technical working group comprising of obstetricians, midwives, epidemiologists, and public healthcare professionals to develop a standard definition and uniform identification criteria for maternal near miss cases in the year 2007. And near miss maternal morbidity is more in high income countries, and they are more than mortalities. So this is the maternal near miss approach, WHO guidelines. So we have severe maternal complications, critical interventions, and admission to ICU. So among the severe maternal complications defined as potentially life-threatening conditions include severe postpartum hemorrhage, severe preeclampsia, eclampsia, sepsis, and rupture uterus. And the critical interventions are those required in the management of life-threatening and potentially life-threatening conditions, which include blood transfusion, interventional radiology, and laparotomy. And in ICU admission, where we need 24-hour medical supervision and provide mechanical ventilation and continuous vasoactive drug support. So we have severe maternal outcomes and process indicators that assess the processes of healthcare. So these are the severe maternal complications, which we discussed already. So these are the steps in maternal near miss. So identification method, criteria which are fulfilled. Then we have to define the maternal near miss cases and the causes of maternal near miss. So according to WHO, we have the 3 criteria: disease specific criteria, organ dysfunction-based criteria, and the management or intervention-based criteria. So the disease-specific criteria, either severe preeclampsia or eclampsia, hemorrhage, sepsis, and uterine rupture. And intervention-based criteria is admission to ICU, obstetric hysterectomy, any massive blood transfusion, or the patient needs intubation or ventilation. And organ dysfunction-based criteria is based on the apparent clinical diseases, clinical markers, and management needs. And the aim is correction of the organ dysfunction and arrest the maternal near-miss progression to maternal death. So these are the inclusion criteria for maternal near-miss cases. So this we already discussed, severe maternal complications and the critical interventions to ICU use. And these are the life-threatening conditions which fulfill under the near-miss criteria. Can be a cardiovascular dysfunction, respiratory dysfunction, renal dysfunction, coagulation dysfunction, or hepatic dysfunction, or neurological dysfunction, or uterine dysfunction. So these are the critical interventions or ICU use. So this is the life-threatening cardiovascular system interventions. The patient may present with a shock, cardiac arrest, or use of continuous vasoactive drugs, or patient needs cardiopulmonary resuscitation, or patient has severe hypoperfusion. In respiratory system, whether the patient presents with acute cyanosis, gasping, or severe tachypnea or severe bradypnea, or intubation and ventilation not related to anesthesia, or severe hypoxemia. In hepatorenal system, whether the patient presents with jaundice or severe acute hyperbilirubinemia, or renal oliguria, or dialysis for acute renal failure, or severe acute azotemia. And in coagulation system, massive transfusion of more than 5 units of blood products, and in hemorrhage or infection leading to hysterectomy. And neurological system, patient present with stroke or uncontrollable fits or status epilepticus. And presence of any of these criteria, if the patient presents clinical or laboratory or management criteria, the case will be included as a near-miss. If the patient has any one of the following criteria, like loss of consciousness for more than or equal to 12 hours, or serum creatinine more than 3.5 milligram per deciliter, or transfusion of PRBCs more than 5 units, or if the patient presents with acidosis, pH less than 7.1, or serum lactate more than 5, or if the patient needs dialysis for acute renal failure, or if the patient needs CPR, all these are included as maternal near-miss cases. So EC criteria, so that for EC remembrance, we have a 5-factor scoring system for maternal near-miss cases. So any of these are present, also they are included as maternal near-miss. Patient has ICU admission and intubation more than 12 hours, unanticipated any surgical intervention, that also included as near-miss. And by following this category, we have a sensitivity of 100% and specificity of 93%. And EC 2-factor scoring system also is there. So, hello, madam. Any
morning. Subha, continue, Subha.
Yes, ma'am. Transfusion of more than 4 units of blood products and ICU admission. And these are the maternal near-miss indicators. So we have a maternal near-miss indicator, which refers to a woman who nearly died, but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy, or maternal death, or live birth, or severe maternal outcome. And we have women with life-threatening conditions, which refers to all women who either qualified as maternal near-miss cases or those who died. It is the sum of maternal near-miss and maternal deaths. And severe maternal outcome ratio is the number of women with life-threatening conditions per 1,000 live births. And this severe maternal outcome ratio estimates the amount of care and resources needed in an area or hospital or facility. And maternal near-miss ratio is the number of maternal near-miss cases per 1,000 live births. And this gives an estimate of the amount of care and resources to be needed in a hospital or area or facility. And maternal near-miss mortality ratio is the ratio between maternal near-miss cases and maternal deaths. And higher ratios indicate better care. So that is the maternal near miss by maternal death. And mortality index, it is the number of maternal deaths divided by the number of women with life-threatening conditions expressed as a percentage. The lower the index, better the quality of care. And perinatal outcome indicators are useful to complement the quality of care evaluation. So these are the process indicators which are already in place. The examples are the prevention of PPH, treatment of PPH, eclampsia, prevention of severe systemic infection or sepsis, and treatment of severe systemic infection or sepsis, and fetal lung maturation. These are the process indicators which are already in place. And now moving on to the maternal near miss review by the NHM guidelines, which was formed in the year 2014 by Ministry of Health and Family Welfare, Government of India. So we have the maternal near miss review, which is important to identify technical and non-technical causes of maternal near miss cases and identify the gaps and contextualize the corrective measures to give regular feedback and response needed to achieve the goals and identify best practices. So there are three categories of maternal near miss. The first is the pregnancy-specific obstetric and medical disorders. And second is the pre-existing disorders aggravated during pregnancy and the incidental and accidental causes in pregnancy. So these are the pregnancy-specific obstetric and medical disorders. And along with the previously what we talked, hemorrhage, sepsis, and hypertension. And in this NHM guidelines, they have included the postpartum collapse, liver dysfunction and failure, and cardiac dysfunction and failure. And pre-existing disorders aggravated during pregnancy are also included, like anemia, respiratory dysfunctions, cardiac dysfunctions, hepatic dysfunction, endocrinal disorders, diabetic ketoacidosis, thyroid crisis, or renal dysfunction or failure, which are aggravated during the present pregnancy. And incidental or accidental causes in pregnancy like anaphylaxis, infections, embolism, and infarction are also included. These are the NHM criteria for identification of maternal near miss cases. Minimum 3 criteria, one from each criteria to be fulfilled. Either it can be a clinical sign or symptom, along with one investigation and one intervention which is done. Or a single criteria in case the patient needs only cardiorespiratory collapse. That is also taken into account. So we have a facility-based maternal near miss review, FBMNM review form, and a maternal near miss review case register is maintained in each health facility or hospital to audit our own cases and how we have corrected our own cases. So it will evaluate the level of care at maternal life-saving emergency services. And this will also provide gaps for the corrective actions to be taken at various levels. So we have to identify, and the data is transmitted, and it is review is done at institutional and district level, and feedback and necessary action and corrective action is taken. So case identification, filling the tools, and facility-based review of cases and undertaking the local corrective action, which is important. And corrective measures are undertaken at different levels. It can be at institution or district-wise or state level. So the criteria for identifying and classifying the maternal near miss review. So based on the clinical finding, investigation, interventions, or any single criteria that indicates cardiorespiratory collapse, and categorized. And for identification of any adverse event in each category, and the result of any investigations which make the women fall under the maternal near miss category are identified, and the interventions that saved the mother is recorded, and it is reviewed, and it is analyzed. So these are the indicators for maternal near miss monitoring. So the total number of maternal near miss cases in the preceding month, and out of the total maternal near miss cases, we have to classify based on the following complications like PPH, eclampsia, anemia, septic abortion, and others, and the type of gaps identified after review in the concerned hospital, and status of corrective action taken for the gaps identified. And this is the maternal near miss criteria. So pregnancy-specific obstetric and medical disorders like abortions, ectopic pregnancy, gestational trophoblastic disease, antepartum hemorrhage, and any clinical finding, whether they have any symptom or sign in this, and result of the investigations. And these shown with this Orton symbol or heart symbol is, if they have any one of the following criteria, they will fit into the maternal near miss, like fall in oxygen saturation below 90%, or if they receive, if they have ICU admission requiring cardiorespiratory support, or blood and blood products that are equal to 5 units of transfusion, they'll fit into the maternal near miss category. And if they have any pregnancy-specific obstetric and medical disorders like sepsis, hypertension, and in this sepsis, if they need ICU admission and the blood component transfusion or use of cardiotonics like dobutamine, dopamine, or if they need any surgical procedure done like evacuation or laparotomy for drainage of pus, even if they have single criteria, they are fit into the maternal near miss. And in postpartum collapse, liver dysfunction, cardiac dysfunction or failure, and anemia in pre-existing disorders aggravated during pregnancy, you have all this: anemia, respiratory dysfunction, and cardiac dysfunction, hepatic dysfunction, endocrinal disorders, thyroid crisis, and neurological dysfunction. If they have they need mechanical ventilation and intubation, so they will come under maternal near miss. And renal dysfunction, if they have oliguria less than 400 ml and use the showing renal abnormalities, and if they have any medical renal disease also, that will come under maternal near miss. And any incidental and accidental causes in pregnancy, like any accidents or history of trauma, and if they have convulsions, they will be straightly fit into the maternal near miss. And anaphylaxis, which needs ICU admission or fall in oxygen saturation below 90%, or infections. So all this, embolism, all this will fit into the maternal near miss. This form is very, very important. So facility-based maternal near miss form. So it has 20 points in the maternal near miss form. The first will be the general information. Next will be the condition at the time of admission, type of admission, referral, illness, duration, status at admission. So underlying disorders at admission, whether they are admitted with any infection. So antenatal period, whether she received the antenatal care, number of visits, and complaints with duration. So if she has come with any vaginal bleeding, hours, days. So examination findings at the time of admission, how she was, and at the time of near miss. So when she needed ICU care, at the time of admission, what was her examination findings, like general examination, CVS, RS, abdominal findings, pervaginum examination, speculum examination, all this has to be entered. And investigations also at the time of admission and at the time of near miss. All that is to be filled, and delivery details, whether it was delivered in a private hospital or home or others, that she have labor pains, all this to be entered in the form, and mode of delivery, and pure perium, blood transfusion. So all these 20 points to be entered properly. And details of blood and component transfusion, details of baby, system involvement, condition at discharge, and interventional details, if anything is done, like internal iliac artery ligation. And in your opinion, where any of these factors are present, like any delay in women seeking health care, or any logistics issue, like lack of transport between health facilities, and any referral facility, in the present facility also any lack of medication, instrument, like that. And this form is to be filled and signed by the consultant. So these 20 points are to be filled and to be signed and sent. And this is a maternal near miss review register to be printed in an A3 size paper. Like that form should be, this register also to be maintained in the health facility. So what are the advantages of doing the maternal near miss review? It aids in recognizing the patterns and trends of maternal morbidity and mortality, and it assists in evaluation of the quality of healthcare at a facility and to monitor it. And it identifies the delays at various levels, which leads to maternal morbidity and mortality. And it facilitates detection of lacunae in the existing system and identifies any modifiable socio-demographic factors which are responsible for maternal morbidity and mortality, and assess in international comparisons in importing optimal health care. and it emerged as an adjunct and proxy measures to identify gaps in maternal health services. And it is a complementary to maternal mortality, can be taken to reduce the maternal mortality and long-term morbidity. Hence, it is mandatory to audit our heroic saves. Thank you, ma'am, for the opportunity, and I thank Dr. Sampath Kumari, ma'am, for giving me the opportunity. Thank you.
Dr. Shailaja is there? Well, indeed, it was in very exhaustive coverage on near miss mortality. And it is very important that we recognize our problems by doing audits. Then only we'll have systems in place to prevent such cases and those that can lead to mortality. So one of the most important things in reducing maternal mortality. Indeed, it was a very, very exhaustive talk, and I think the delegates would have taken a lot of points. And thank you, Dr. Shubha, for that good talk. And once again, I don't know if there are any questions in the chat box for you, because it's
Yes,
a key.
madam. Dr. Radhika is seeing the questions. Shubha, madam, she is seeing the questions, and if anything, Shubha, if you see any questions in the question answer chat box, please answer it.
Yes,
yeah. Wonderful presentation, Shubha. Thank you.
Very wonderful.
It was an excellent talk. It was an excellent talk. If she can share the near miss pro forma, we can definitely take it over to all medical colleges, and then we can come to some registry what we plan to. Yes, yes, Shubha.
Vidya, in your state, you don't have the near miss audit. In Tamil Nadu, they are conducting.
I know in Tamil Nadu they are working great on that. So same pro forma can be shared. Yeah.
I take this opportunity to invite Vidya, all your president secretary for our HRP-CON. That is on Kodaikanal. I want to honor all presidents of South. So please request all your presidents to join here Kodaikanal on August 11, 12, 13. Thank you. Yes, sir. Next session.
Thank you, Dr. Sampath Kumari. Thank you, Dr. Vidya.
Yes,
thank you. See you in Bangalore soon. Yeah.
Yes, madam. I see you in Kodaikanal on August.
Sure. Yeah.
The next, madam, the audio is.
Radhika Arambi.
Yes, ma'am. The next program is a panel discussion, infections in pregnancy. We are running late of time, so let's all stick on to time, please. So this, I'm going to introduce moderators, Dr. Sri Lakshmi and Dr. Srimati. Dr. Sri Lakshmi is a
Radhika, you can introduce the panelist also for want of time.
Okay, ma'am.
Short and
crisp. Okay, ma'am. She's a fellow in medical genetics, consultant fetal medicine, and she's finished her post-graduation in KMC Manipal. She's won lots of awards, and she's given lots of guest lectures, and she's the executive member of KSOGA and national corresponding author of Jogi. And next is another excellent one of the panelists, Dr. Srimati Raman, and she's a consultant obstetrician, Rangadur Memorial Hospital. She's done her MD, and she's FRCOG, and she's completed her CCT training from UK, and she is also an MRCOG examiner, reviewer for the Green Journal official publication of the ACOG, ranked in the top 10% of reviewers, and also a DNP trainer in RGUHS fellowship programs. She's won 10 gold medals, and her area of special interest, maternal medicine, high-risk pregnancy, advanced labor ward management. Moving on to the panelists, Dr. Jyoti Sharat Kumar is a consultant at Dr. Jyoti's Women's Care and Fertility Center and Guru Kotishwara Clinic. She's done her UG from Davangere and DGO from KIMS Hubli. She's the secretary of OBG Society, Chitradurga. Dr. Mangala Gadwal is a consultant obstetrician at GPV Super Specialty Hospital, Raichur, and president Raichur OBG Society. Welcome, ma'am. Dr. Sushma HP is from Hassan Institute of Medical Sciences, and she's done her MS in Regional Institute of Medical Sciences, Imphal, Manipur, consultant obstetrician gynecologist, and secretary of Hassan Society of OBG, She's won the Best Postgraduate Paper Award, OGCON 2020, and she has many publications in IJRCOG. And also she's had many case reports. Member of Emergency Obstetrics and Critical Care Committee 2023 to 25, KSOGA. Can we please start? And sorry, Dr. Shubharani Kadapati is a consultant from SS Kadapati Hospital, Ilkal, and she's presented various papers in state conferences. Areas of interest are preventive oncology, creating health awareness among the rural women, nutrition and fitness. And shall we move on to the...
No, next to Dr. Anita. Dr. Anita, next.
I think
Last.
Dr. Anita Gaurav Konin. Dr. Anita is has done her MBBS from MR Medical College, Kalaburagi, MS from SN Medical College, Bagalkot. She's an assistant professor at MR Medical College, Kalaburagi, treasurer of Gulbarga Obs and Gynae Society between 2022 and 23. She's also elected as a secretary and Violence Against Women Committee member, KSOGA, and she's speaker at many CMEs, presented poster at FIGO 2021. Welcome, dear madams, and let us start the panel discussion.
Yeah. Morning, everybody. Thanks for the opportunity given to us. Dr. Sri Lakshmi and I'm Dr. Srimati. And we thank the panelists and Vidya Tobi ma'am and Sampath Kumari ma'am for giving us the opportunity. So, as already been told by the organizers, time is short. So, I request all the panelists to be very crisp. We want it to be a practical panel discussion because we have lots to cover. So, basically, if you look at the importance of infections in pregnancy, we come across infections in everyday practice. It could be bacterial, viral, fungal, protozoal, zoonotic, name anything. You can have an infection. You can have an asymptomatic or you can have symptomatic infections. And you could have serious maternal complications. And it could also affect the fetus because there is a potential for vertical transmission, especially with a few infections. And this could result in miscarriages, structural abnormalities, FGR, and of course, long-term health issues and sequelae for the fetus. And we do have lots of difficulties and dilemmas. And we should always think about whether we can prevent an infection. So this is going to be the focus of today's panel discussion.
Yeah, good morning, everyone. Let's start with the panel, and we have well-read panelists over here. So now, may I ask Dr. Jyoti, should we screen for infections in pregnancy? And if so, why?
Yes, good morning to all. Yes, ma'am, during pregnancy, we should screen for very common infections. It is a must in order to prevent many maternal complications and fetal complications and to prevent vertical transmission and for prevention of maternal morbidity and fetal morbidity. To know the and the complications of those infections and to planning for we have to once we come screen the infections, we have to plan for monitoring and follow up and to consult the patients and to for prognosis. We have to screen, madam, for infections during pregnancy.
Okay. Yeah, you are very right that we need to screen for infections. Dr. Mangala, ma'am, will you please tell us what infections
routinely? Hello?
Yeah, I think Sri Lakshmi has had a connection.
Hello?
Hello, ma'am.
Good morning, madam. Hello, madam.
Yeah,
Good morning.
Do you want to enlighten us about what infections do you want to routinely screen for?
Yeah, routinely we screen for HPSAG, HIV and syphilis, VDRL test, and some cases HCV and any risk factor, associated risk factor, torch and tuberculosis also.
Yes. Yes. Yes, you are very right. We do screen for certain important infections. May I ask Dr. Sushma, what do we do when,
why do you think, Dr. Sushma, why do you think, Dr. Sushma, we screen for HIV infections?
Mainly to prevent maternal to child transmission. Parent launched in 2001 to children because when we die,
of the pregnant transmission rate and start.
Sorry, I mean, Dr. Sushma, I think voice is not clear. Is it only for me or is everybody having the same problem?
Yeah, all of us are not able to hear.
I think your voice is not very clear, Dr. Sushma.
How about now?
Yeah, thank you.
Because mainly to prevent the parent to child transmission, because when woman is suffering from HIV, she is not on any ARV, the transmission rate is 30 to 45%. But when we start her on 3 ARVs along with breastfeed, the incidence reduces almost to 2%. So knowing the status of the mother as early as possible, antenatal period reduces the rate of transmission to child.
Right. So I think it's important that we screen everybody for HIV. I mean, if possible, even in the preconception period. So if you find that she's HIV negative, which most of our population are going to be, what would you recommend to that lady, Dr. Sushma?
Ma'am?
If she's found to be HIV negative, are you going to put in any extra measures?
If she is HIV negative, we will categorize her whether she belongs to high-risk group. If she is high-risk group, then we will counsel the patient and we will do repeat screening for HIV, ma'am, in high-risk group.
So if she is low risk, we don't have to. But if we think she belongs to a high-risk group, then we might have to think in terms of a repeat screening. So thank you. And moving on, if we do find that she's HIV positive, what would be the next steps, Dr. Shubha?
Hello, good morning, everyone. Once the diagnosis is confirmed, the patient needs to be counseled well. The main aim of treatment will be prevention of parent-to-child transmission and prevent transmission to the partner as well as the healthcare worker. The vertical transmission occurs predominantly in the 3rd trimester, intrapartum and through breastfeeding. In India, currently, there is no recommendation for LSES and breastfeeding is allowed, and ARV has to be considered for the baby. So the preferred ART regimen is TLD regimen, which consists of tenofovir 300 mg, lamivudine 300 mg, and dolutegravir 50 mg. This comes as a fixed dose combination. It is a one pill which can be given orally once daily. And it has to be given to all women with HIV-1, HIV-2, and women exposed to single-dose NVP in the past, as well as those co-infected with tuberculosis or hepatitis. The pregnant women with HIV should be educated about the benefits and risks of the drugs, and which will help them for the informed choice.
Thank you very much. So basically, HART regimen is very, very important. And the latest recommendation is dolutegravir. Though there are some concerns about urinary defects, but it seems to be very effective. And of course, as you rightly said, in Indian scenarios, we do allow them to have a normal delivery and we do allow them to breastfeed, but it might be different if it is in the West. And of course, ARV for the baby dependent upon the risk factors which we have found and how long she has been on HART. So, moving on.
Yeah, Dr. Anita, having known about HIV, will you please tell us about syphilis? Do you think it is important to screen for it?
Good morning, ma'am. Yes, ma'am. Screening for syphilis is important because it is one of the important causes of the congenital malformations like pigmentary retinopathy, chorioretinitis, glaucoma, cataract, etc. And definitely, we have a very effective, affordable treatment that is benzathine penicillin. And the syphilis screening also fits in the criteria of a screen, which is an ideal screening modality. So, yes, we want to screen for syphilis in pregnancy.
Okay. So, Mangala ma'am, will you please tell us what to do next if VDRL or RPR, that is rapid region test, comes positive?
So, once VDRL is positive, so we need to start treatment with benzathine penicillin, ma'am.
Okay. Let me just elaborate about what next when VDRL comes positive. This is the Royal College talk, the treatment. Once VDRL, that is antibody, is positive, we need to do an antigen test, that is a confirmatory test. Yes, Mangalam. This is a Treponema pallidum hemagglutination test. Once antigen test is positive, then go for a treatment, that is benzathine penicillin. The
Thank you.
dose and the duration and the number of doses depend upon the stage of the syphilis and the trimester of the pregnancy. And it is also important to do a postnatal scans as well as the scans during further pregnancy and also postnatal follow-up. I just want to emphasize that in syphilis in pregnancy, when we are giving penicillin, there may be a mixed reaction. Patient may need admission, and we need to be alert with this. Also, it is important to know that if they are allergic to penicillin, we need to offer cephalosporin, or if severe allergy, we have to offer vancomycin. So if we know this much, it is enough. So shall we go to the next one?
Okay, Dr. Jyoti, and as we had spoken about the routine screening, we do screen for hepatitis B. So in your daily practice, Dr. Jyoti, if somebody is hepatitis B negative, do you recommend vaccination if they have not been vaccinated previously? What is your take on vaccination in pregnancy?
Well, if a patient is negative for hepatitis B during pregnancy, no need of giving vaccination, but only in high-risk cases, if she is family is there, and if husband is hepatitis B positive, then we have to consider the vaccination during pregnancy. As such, hepatitis B is a recombinant vaccination. It's considered safe during pregnancy, but still it is a category C vaccination, but only it should be given in the high-risk women of acquiring hepatitis B. And for people who started the vaccination series before getting pregnancy, then that can be completed during pregnancy, madam. And
yeah. So basically, because it's a subunit vaccine, recombinant vaccine, you're pretty okay to give it in pregnancy if it is needed. So if you find that she is hepatitis B positive, what would be your next steps?
If a pregnant woman is hepatitis B positive, then we should know what is the viral load and the LFT liver function test and ultrasound findings, and what is the antigen status. Because if a woman is positive along with hepatitis E antigen status, then chances of infecting the fetus is also vertical transmission is high. So we have to do all this. Viral load is very important, madam. If a woman, pregnant woman comes with positive, and if viral load is more, then we have to give that hepatitis next. Okay. Then antiviral drug therapy is very important if viral load is more during pregnancy.
See, basically, viral load is the recommendation, but we could also use E antigen as a surrogate, because some communities we may not be able to easily afford a viral load. If that is the case, WHO does recommend just doing an E antigen status. Looking at it would be enough, because that shows that they are highly infected. And of course, having a hepatic hepatology input is always helpful to have an MDT. Okay, so moving on, Dr. Sushma. So as Dr. Jyoti rightly said, we are going to do the viral load, liver functions and everything. So then what are you going to do with her? She also spoke about vertical transmission. So what steps are you going to take in order to prevent the transmission to the fetus?
We have to vaccine the baby routinely with hepatitis B vaccine within 12 hours, along with hepatitis B immunoglobulin, which has to be administered to the baby within 12 hours. And if she's only HBsAg positive and HBeAg negative, then the transmission rate is only 10 to 20%. But if she is positive for HBeAg, then she is highly infective and transmission rate increases to 70 to 80%. Then we have to check for viral load. If the viral load is more than 1 lakh milli international unit per ml, then we have to start her on antiretroviral therapy, that is on tenofovir. If possible,
viral TDF, it's basically 2 into 10 power 5 units, they say. So usually 10 power 6 copies is what we are looking at. Yeah.
Along with that, we have to counsel the family, and also we have to check the partner for the status of the HBsAg. And also, if we suspect her viral load is high, then we can start her from the 3rd trimester itself on TDF.
Yes. So because there is lots of evidence to say giving antenatal prophylaxis, TDF 300 milligram once a day from 28 weeks does help in decreasing the transmission. So there are various guidelines, and this is a SMFM recent guideline which speaks about hepatitis B vaccination. And as was rightly told by Dr. Sushma, based upon the viral load, we would want to think in terms of maternal antiviral therapy so as to decrease the risk of intrauterine infection for the fetus. And of course, we need to think in terms of vaccination as well as immunoglobulin prophylaxis. Thank you, Dr. Sushma. So moving on, Dr. Shubha, what do you think about, I know Mangla ma'am was telling, some cases we might do rubella and HCV. So what is your take on it? Do you think we need to do it, and do you routinely do that in your practice, Dr. Shubha?
No, madam, we don't routinely do it. It is an opportunistic screening. Here, the prevention is not possible, but steps can be taken postnatally. The pre-pregnancy screening is ideal for rubella and HCV. The preventive strategy for rubella will be the MR vaccine, which will be ideally given at 11 to 13 weeks. Once the vaccine is given, the IgG antibodies are for lifetime. But if the vaccine is given during the childbearing period, then pregnancy has to be postponed for 4 to 6 weeks. And for hepatitis C, there is no effective vaccine available because the virus has got many strains and genotypes. So best is if the woman, if she's not immunized for hepatitis B and A, she should be offered the vaccine. And the direct acting antiviral medication is not recommended in pregnancy for HCV.
True, very true. But it's because they have now recently found that hepatitis C incidence seems to be increasing. So basically, they're thinking in terms of using it as an opportunity to at least screen women so that we can always counsel them and think about, obviously, them in the postnatal. Dr. Sri Lakshmi? Okay. So, Dr. Jyoti, what is your take on rubella screening?
Yes, madam. Rubella screening, we don't do rubella screening routinely, madam. But in areas where there is a poor uptake of vaccination and where vaccination is not widely available, that time we'll do universal screening. If a patient...
Yes, because most of us would have received two
Yes.
vaccines. But generally speaking, yeah, Dr. Sri Lakshmi, I can carry on.
Yeah, maybe, sorry for the interruption, network issue. So in areas where there was a poor uptake of vaccination or is not widely available, you can go for that. Or else, but what I want to emphasize is there is no need for termination of pregnancy if patient becomes pregnant inadvertently or accidentally if rubella is vaccinated. This is a very important take-home message. Yeah.
If patient is negative, madam, if while doing screening, patient is negative, screening negative, we can do give rubella vaccination pre-pregnancy, at least 3 months prior to pregnant, and then she should not become pregnant for 3 months after taking vaccination, and it can be given postnatally also if woman comes out rubella screening negative, vaccination not taken, and if a patient has taken a rubella vaccination during pregnancy, it is not an indication for pregnancy, but still it is since the rubella vaccine is a live vaccine and it contains low dose of live viral virus. But we cannot recommend during pregnancy, but it is as such, it is not an indication for a pregnancy termination.
Actually, there are recommendations vary. Even 1 month is enough, is what they say. Once you have
But 3 months, some studies they have given 3 months, madam. 1 month.
Some guidelines do recommend 3 months, but 1 month is equally enough.
So it is anywhere between 4 weeks and 12 weeks. But we can give, that is the criteria that we can follow. But what we need to know is don't ask for a termination of pregnancy if accidentally become pregnant. That's it. So can I ask Dr. Anita, please answer this. So how do you suspect rubella infection in pregnancy and what to do next?
So basically, we are worried of the rubella infection in the first trimester of the pregnancy because here the vertical transmission is highest. So if we are, routinely if we are screening, we'll just go for IgG screening. And if it turns out to be negative, then if it is the titers are less than 10 international units per ml, then you can plan for her immunization after the pregnancy. If we are suspecting a rubella infection, like she has a history of contact or she has fever with arthralgia, with rash, or she's having severe fetal malformations, then we can go for IgG and IgM's investigation. So if IgM is negative and IgG is negative, she is a susceptible woman. We have to repeat the investigations again, titers 4 weeks after the exposure or 7 days after the onset of symptoms. If she is IgM negative and IgG positive, again there may be a chances of reinfection, or she is previously immunized or previously infected, and if she has been exposed and if she has symptoms, then again repeat the IgG and IgM titers 4 weeks after the exposure or 7 days after the onset of symptoms. If she is both IgM and IgG positive, then she is infected. Repeat the investigation titers after 2 to 3 weeks, so that we know that titers, and also do the avidity index. Finally, if she is IgM positive and IgG negative, repeat this serology. If there is no seroconversion, she can be immunized after pregnancy. If there is seroconversion, then it is a possible infection. So why we are worried about this rubella infection in the pregnancy is the transmission rates in the first trimester are highest. That is, vertical transmission is highest, that is 80 to 90%. After from 13 to 19 weeks, the vertical transmission falls to 54%, and after 20 weeks, it is only 25%. Most 90% of the women who are infected in the first trimester deliver the baby with serious congenital malformation, again like hepatosplenomegaly, cataract, glaucoma. So there is no known treatment, and if detected early and confirmed, termination of pregnancy is a better option.
Yeah. So to summarize the busy slide and the flow chart is the best scenario is having both IgG and IgM. That means they are already immune. And the worst scenario is both IgG and IgM are negative. That is they are susceptible. So avidity index is nothing but the rise in IgG titers. So this is just a summary of what Anita has told. Thank you very much for that. Next one.
1 second.
Yeah.
Yeah. So, Dr. Mangla, ma'am,
Yes.
why do you think, I mean, I know we discussed about HCV. If we want to screen for HCV, I think we briefly touched upon it, but maybe if you want to highlight about the importance of HCV screening in pregnancy.
Yes, madam. It is nowadays it's important because it has various just very less prevalence is there. Vertical transmission rate is very less, 5 to 10% compared to express with the highest rate in co-infected with HIV. It can cause severe morbidity. That's all. So in pregnant women, such as intrahepatic cholestasis, in the rate is 20 times higher than non-HCV women. So also the risk of transmission to HCW is more, madam. So HCV, so wherever possible, we can better to screen this.
Sure, ma'am. Sure. Because at least we would know what is happening, so that we can take precautions at least to save us. And of course, obviously the risk to the baby, though not very high, 5 to 10%. And sometimes women can have severe complications. And mainly because we can counsel the women so that postnatally she can take a DAA, because it's a short course of 6 to 12 months. And many a time they are able to seroconvert. So we avoid chronic infections and chronic morbidity for the lady. So that is the reason we can use it as an opportunistic screening during pregnancy. Thank you, ma'am.
Thank you, ma'am.
Yeah. Dr. Sukshma, having known so many screening tests, do you think we need to do any other screening tests? And if so, why?
Dr. Sushma, you're muted.
Yes, ma'am. In high-risk groups, we are supposed to screen the woman for group B streptococcal infection, and also for asymptomatic bacteria, either with E. coli or group B streptococcal infection, and also for bacterial vaginosis. Because if the woman is suffering from group B streptococcal infection, or the organism is colonized in her vagina, then the baby will suffer from early onset neonatal sepsis. And if especially it is more prone if it is preterm delivery. and also to avoid pyelonephritis in women with pregnancy, because they are easily prone for pyelonephritis. And if we find out that she is having urinary tract infection, we can avoid it, and we can also treatment is very easy once we diagnose her if she is suffering from pyelonephritis. And also, if the woman had previous history of baby with neonatal sepsis, then we can put her antepartum antimicrobial prophylaxis to avoid group B streptococcal infection to the current pregnancy.
Yeah. Yes, right, Sushma, you are right in telling about urinary tract infection, group B streptococcus, and bacterial vaginosis. Yes, probably diabetes, high-risk pregnancy, recurrent pregnancy loss, we should be thinking about these 3 infections. It's worth doing screening. Yes. Let's go for the next one.
So now we have spoken about all the routine infections, so which we would commonly screen for in the general population. There are obviously loads and loads of infections, but we may not be screening them routinely. But of course, there could be special situations where you know that there is a contact with that infection, or if the patient is symptomatic, or if we have some concerns that the baby could be already infected. So one such example is having a potential contact. See, Dr. Shubha, you see a patient who's 8 weeks pregnant, and she says her first child has chickenpox. So are you going to be worried about this exposure?
Yes, madam, definitely. Because the woman is 8 weeks pregnant and she has got a close contact with varicella zoster patient. So first we have to ask for the history of chickenpox.
So she's basically living with a child, isn't it? So she's definitely
history of chickenpox is important, because if she already had it in future, there is no need to be worried, and just reassurance is required, and the routine antenatal care can be continued. But if the woman is uncertain, or if she didn't have a chickenpox in the past, or if she from the tropical or subtropical country, the blood has to be tested for varicella zoster virus antibody. And if the antibody is present, then no need to worry. She'll be safe. And if the varicella zoster antibody is not present, then she has to be administered with the varicella zoster immunoglobulin. That is within 4 days of the significant exposure to varicella.
And even up to 10 days, they say we can give it. So yes, it's very important, because this is a definite exposure, and you're really worried that the mother could be infected. And of course, then you're worried about the fetal infection, isn't it, Lord? So, Dr. Anita, you've taken all the precautions. Dr. Shubha did give her varicella zoster immunoglobulin, but unfortunately, she's now developed a rash. So, what are you going to do with her?
Once she has developed the rash, she herself is she's going to infect others. So first, her isolation is also important. So she is going to be susceptible for others for 8 to 28 days of the contact. So the first we have to discuss the prognosis of both mother and fetus with her. If she develops, despite of giving this, if she develops chickenpox, then symptomatic treatment and personal hygiene should be a must. Apart from that, if she is reporting us within 24 hours and less than more than 20 weeks of gestation, we have to consider a cyclover. If the infection is very serious, a tertiary care center with isolation and IV acyclovir should be considered. If she is reporting at less than 28 weeks of gestation, where vertical transmission chances are more and the fetal infection is more. So in such cases, we can get involved with the fetal medicine specialist and targeted screening and even amniocentesis for amniotic fluid, the varicella DNA. So this can be the plan of management.
Yeah. So, it is only less than 2% risk actually. Even if we take the worst case scenario that she has had the infection at less than 28 weeks, it's a very small risk, but I think we need to counsel them and we need to follow them up. And of course, you're more worried about the mother as well, especially if she belongs to high risk group, because we see more and more women who are obese. So they are at risk of complications. So as you rightly said, you might have to think in terms of hospitalization and even giving them IV acyclovir. So are you worried about the mother developing an infection in the peripartum period? We spoke about less than 28 weeks.
Yes, ma'am. Yes, the less than 5 days prior to delivery and within 48 hours postpartum, the highest chance of transmission from the mother to the neonate is there. If she's already in hospital, and if we can we have to at least avoid 7 days the delivery of the baby for 7 days since the rash has appeared.
Yes. So it is very helpful because you can then avoid obviously problems in the mother as well as for the baby. Of course, if it's not possible, then we'll have to take precautions. But you ideally would want to avoid a planned delivery during this period. Okay.
Yeah.
And of course, chickenpox vaccination, though not routinely given, you could consider in high-risk population, but not during the pregnancy. We can give it in the postnatal period.
Postnatal period.
Not a routine vaccination, one of the routine vaccinations. And as you said, we need to consider doing a scan, usually about 5 weeks after the infection. Okay.
It's just important to know that it is not chickenpox infection in pregnancy is not an indication for termination of pregnancy. Kindly don't do, and it is less than 1% that the fetus gets affected, and amniocentesis is not mandatory. It is just if required, we need to do it. So what is the role of TARCH infections screening? Do we have to do? If at all, if we have to do, how to do, and how to interpret. Dr. Jyoti, can you tell us?
Yes, madam. The screening for TARCH we won't advise, madam. Only if maternal pregnant woman with fever comes with fever, with the rashes and with the exanthesis illness, and if she is having a definitely contact with the patient, and ultrasound findings are strongly suggestive of any TARCH infection, then we'll advise for TARCH screening, madam. And if there is for a stillbirth evaluation, if there is a previous history of any stillbirth, then we can do TARCH screening. Routinely, we won't advise, and there is no role of screening for TARCH in recurrent pregnancy loss or BOH. And if, because this TARCH infection in pregnancy, it has got a very high fetal vertical transmission and got serious fetal malformations and congenital malformations in fetus. That's why it is advised only if a pregnant woman comes with fever with rashes, then better to go for TARCH screening, madam.
Yeah, stillbirth, I just wanted to re-emphasize, we do not do it with the past history of stillbirth. Only when the patient has a stillbirth at that point in time, you want to elucidate the reason you might want to do it. But if she comes in the next pregnancy or in the inter-pregnancy period, then doing a TARCH screening is not going to be helpful.
Yeah. So it's very important to know that there is no role to do a TARCH for recurrent pregnancy loss and bad obstetric history. Yes. So what tests and how do you interpret? Mangala ma'am, can you tell us?
I think Mangala
Yes.
ma'am is probably not there, is it? Ma'am,
Yeah.
you're muted, ma'am. Ma'am, you're muted. Yeah.
What is regarding what mean TARCH?
Yes. If at all, if it is indicated to do a TARCH infection, how to do it and how to interpret them.
Yeah, we usually will do it blood test only. TARCH, IgG and IgM assessment will do. Interpretation is really difficult with IgM. If IgM is persistently positive with toxoplasmosis and cytomegalovirus, then role of avidity test has lot of role, madam. It gives most of confusion also. So many times we'll get higher range of IgG also.
Yes, very true. So what is very important here is IgG, rise in IgG is called avidity test, and that is more significant than the IgM. And the best part is if both IgM and IgG are positive, it just indicates it is immune. It doesn't indicate an infection, active infection. So we need to repeat, and if IgG is rising, so that indicates an active infection. So proper interpretation of these tests are more important than just to do an IgM and IgG testing. So if both are negative, then it just indicates it is susceptible and doesn't indicate anything else. That's all. That's what we need to know about this busy slide.
So mainly one point I want to emphasize is low avidity and high avidity. Though we rely on it because low avidity indicates a possible recent infection, there could still be overlap. So that is a problem with CMV and toxoplasma. Even if it's low avidity, it may not always be equivalent to a recent infection. So this again creates confusion. So I think the take home is that please do it only when it is needed. Otherwise, we get into lots of muddle in terms of interpreting these results.
Yeah.
So, Dr. Sushma, I think ma'am did touch upon the risks for the baby. So, do you think if there is a maternal infection, the baby is going to be always affected?
Actually, it depends on two types of transmission, ma'am, whether antenatal or intrapartum. Antenatal, it can infect the placenta and then the baby, or it can directly transplacental transmission to the baby. So that can affect fetal liver and spleen. And if it is during the birth, it can enter through the vagina or through the cervix or directly in contact with the serum, and then it can infect the fetal lungs, stomach, skin, and eye. So when there is seroconversion or pair testing will reveal the maternal diagnosis. So counseling the parents about fetal infection has to be done, and fetal diagnosis is done by cardiocentesis showing elevated anti-CMV IgG or positive amniotic culture or PCR. Then you should consider MTP wherever appropriate, not in all cases.
Yeah, so that is one thing which I think we need to importantly take home. Maternal infection may not be always equal to fetal infection. It depends upon when the mother is infected and also the susceptibility. And of course, even if the fetus is infected, we not always have a manifestation. And very occasionally, we also need to be aware, even if there are no manifestations in utero, the baby could be affected subtly. We could have cataracts and other issues which we may not be able to pick up because of scans. So I think there is a spectrum of manifestations. I think it's very, very important for us to remember. And as you rightly said, most of them are intrapartum, but we do have infections like rubella, CMV, or syphilis, and there is a transplacental passage. So, and of course, we shouldn't be forgetting about the postnatal transmission, which could happen because of breastfeeding. So, all of these things are very, very important for us to remember when we see a mother with a potential torch infection in terms of how we are going to manage and counsel her.
Yeah. So what next, Dr. Shubha?
Madam, once the CMV is confirmed, the strict ultrasound monitoring is required. And in some cases, invasive testing may be required with PCR, checking for the PCR in the amniotic fluid. So IgG, IgM test has to be ideally performed early in the first trimester. If both are negative, then there is no serological evidence of prior infection. The risk happens only if the mother requires fresh infection during that pregnancy. So if the IgG is positive and IgM is negative, and the infection is occurred before 18 weeks of pregnancy, then there is the risk of transmission is 0. So if the infection occurs more than 18 weeks of pregnancy, then the chances of infection are high. So only if the IgM is positive, it doesn't indicate, it doesn't have any clinical relevance. The management will be as same as a IgM negative and IgG negative patient. And if both IgG and IgM are positive, it indicates that seroconversion has occurred, the infection acquired during the pregnancy, and fetus is at risk. So the treatment should be initiated, and amniocentesis needs to be done for the CMV culture and quantitative PCR 6 weeks after the positive serology, but it should not be done earlier than 20 to 21 weeks gestation. If the result is positive, then the chances of congenital infection are high. If the result is negative, then infection is unlikely.
Well done, Dr. Shubha. So what is very important to know in CMV is the difficulty in clinical situation is only 10% are symptomatic, and most of the manifestations are after 20 weeks of pregnancy, especially microcephaly is a third trimester diagnosis that puts us in difficulty in the clinical situation. And many times only hearing loss is the only problem which we cannot do by or detect by ultrasound. Yes.
Yeah. So I think most important point is again when you do the amniocentesis, because if you're doing it too early, as you rightly said, you may not be able to pick up because fetal urination becomes important. So ideally, you would want to wait for 6 weeks after the infection, and of course, definitely after 20 weeks. So this is something which we will need to keep in mind. See, we spoke about difficulties with CMV and toxo purely because of the problems with IgM. because the unique nature of IgM in these infections is that they persist for life. Unlike in other infections, because IgM equates an acute infection. And in CMV and toxo, we have those difficulties. So what about parvo then, Dr. Anita? Do you think it is the same or is it any bit better?
Ma'am, the IgM is always, the same thing, that it is an acute recent infection, and IgG is a past infection. If there is a susceptible exposure to the parvovirus, and the patient has the symptoms, then again we have to screen. If IgG is positive and IgM is negative, it's definitely a past infection which can just reassure. Again, if IgG and IgM both are negative, then again there is no infection and just counseling is enough. But if IgG is positive or negative and IgM turns out to be positive, then there is a possible recent infection. Here we have to look for USG Doppler for middle cerebral artery Doppler and look for hydrops or fetal anemia. If it is there, then plan for in utero transfusion, or if she is at term, you can plan for delivering her. If there is no hydrops, then weekly or once in 2 weeks, USG Doppler, middle cerebral artery Doppler can be done to again look if she is going for fetal anemia or hydrops, and treat accordingly. This monitoring should be continued for 12 weeks after the exposure.
Yes, thank you. So parvo is a bit more easy and straightforward to deal with, purely because A, you're able to easily diagnose. There's not much of a confusion about the IgM and IgG. IgM equates an acute infection, so you're worried. And here, of course, you don't have to bother about invasive testing, because the main problem with parvo is anemia. So as you said, we can monitor with MCA PSVs. And if you find that there is anemia or eye drops developing, we do have a treatment option of doing an in utero transfusion. So you would be able to manage these pregnancies better.
Sorry, ma'am. Srimati ma'am, 5 more minutes, please.
Yeah, sure. So I think shall we move on? We will leave this because we already spoke enough about this talk. So no.
Yeah. Ma'am, we can just go for a summary slide rather than any other thing. I think summary and conclusion.
Yeah, I think we'll just quickly run through this. I think most important thing is following up the baby also is important, as has been emphasized by the panelists. I think briefly we will touch upon symptomatic screening, and then we will go to the summary if it's okay. So if somebody has got a pregnancy, what would you be screening them for? Dr. Sushma, can you just briefly go through it?
Ma'am, fever is one of the most frequent reasons for emergency consultation during pregnancy. We have to balance so that we don't overdose her with antibiotics, and also we have to diagnose at the right time and give proper treatment. So based on the symptom, we have to screen the patient, whether she is having burning maturation or asymptomatic bacteria, then screen for UTI.
Yes, I think it depends upon what her symptoms are. So we might have to do all of these testings, isn't it? And you should also remember about surgical causes, and first of all, obstetric causes like chorioamnionitis.
Yes, ma'am.
So yeah, so I think we want to just highlight this point, Dr. Srilakshmi.
Yeah, this is tuberculosis. Yes, we do have tuberculosis. We need to think tuberculosis. Just to emphasize, just to share a case where there was an asymptomatic patient, and patient delivered a healthy baby, and baby had hepatomegaly. When after doing complete testing of why there was a hepatomegaly, came to know that it was a congenital tuberculosis. And when we went back, the patient was AFB sputum positive. So what I want to tell here is that tuberculosis in pregnancy doesn't have a typical or a classical symptoms of meaning rise of temperature, loss of weight, loss of height. So we need to be alert for subtle symptoms and signs as well. So infectious diseases in India, we need to think about tuberculosis, malaria, dengue, chikungunya as the first cause of fever rather than anything else.
So I think we really did want to speak about COVID, flu, everything, etc. But I think for want of time, we will skip through.
Yeah. We know very well since we are talking about COVID. Yeah.
Vaccination is very, very important, because COVID and flu, please think about vaccinating the pregnant population. And of course, think about the latest strain which is available and vaccinate them. Malaria, dengue, I think, as she rightly said, yeah. Yes. So, any take home from one take home from each of the panelists before we conclude?
Yeah.
We have to regularly update ourselves with the guidelines, ma'am, about treating treating a woman with infections in pregnancy.
Yes, evidence changes. That is very important. It's need to be updated.
Her risk status should always be categorized. If she is already at high risk with obesity, diabetes, elderly, gravida, susceptible patient, should be screened adequately and efficiently.
Yeah.
Whenever we are treating a patient with
Correct.
any infections, we need to have a high index of suspicion and to diagnose the disease properly.
Sepsis can be very subtle and can be missed, so you need to be careful.
Yes. So to summarize this whole panel, we have two people here, mother and the fetus. The mother, we need to be alert that there will be subtle signs and symptoms. They are not classical in pregnancy. And the risk factors, obesity, diabetes, elderly, gravida, they are the emerging endemics rather than even epidemics. Low socioeconomic status, avoid overcrowding and travel for pregnant women. For the fetus, we know that it may take 5 to 7 weeks for manifestation. There can be structural anomalies, there can be hydrops, placentomegaly, and fetal growth restriction. In any kind of infection, avoid hyperpyrexia, and this is the reason for IUD, intrauterine. Yes.
This is a bit different compared to non-pregnant population because there they may not be so worried about hyperpyrexia, but here the first trimester you're worried about teratogenicity and later on you're worried about IUFT. So I think it's very, very important, and of course they can go into preterm labor as well. So in conclusion, we definitely want to emphasize the fact that think about if that infection could be prevented, look about vaccine and preventable diseases, and of course look at specific measures, maybe avoiding contact, avoiding high-risk travel. Think about screening as routine screening, opportunistic screening, and screening in specific circumstances where they may be symptomatic. Most of them can be diagnosed and treated, but as we do have lots of diagnostic challenges as we discussed in the torch infection. We weren't able to speak about dengue or malaria, etc. But most of them, you treat them like outside in pregnancy, but there could be a few disease, and few diseases where you might need to modify the treatment because food drugs may not be safe, especially in the first trimester. So we need to be always having an infectious disease consult if you are in a difficult situation. Think about complications which the mother could have, especially in few diseases like chickenpox or in flu or COVID. Of course, think about fetal manifestations, but please remember the dictum, maternal infection is not always equivalent to fetal infection, is not always equivalent to fetal disease, and always not equivalent to long-term sequelae. So please do not always easily recommend a termination if you do find that the mother has got an infection. Look whether there could be any sequelae. So we thank the panelists. Sorry, we had to cut you short because we were running short of time. There was too much to cover in too little a time. But I thank my co-moderator and of course the organizers for having given us this opportunity.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you so much, ma'am. That was a wonderful and excellent actions and how to protect the child from and prevent and diagnose. So wonderful discussion and inputs from all the panelists. Now we move on to the next session. Session 5. We have 4 set of speakers for that, and I would like to invite our chairpersons for the session, Dr. Jyoti Sundaram and Dr. Selvarani, ma'am. Dr. Jyoti Sundaram, ma'am. She's a senior consultant, Mitra Hospital, Madurai. She's been president of Madurai OB-GYN Society. She's a member of MTP committee FOGSI. She's a UG and PG teacher for more than 20 years and also an examiner. She's won the award for best doctor 4 times from district collector and from IMA, and has presented many research articles, and her field of interest is high risk obstetrics. Currently, she is professor in the department. We welcome you, Jyoti ma'am. Dr. Selvarani ma'am, she is consultant Sri Amogam Hospital and St. Joseph Hospital. She's been a former medical superintendent at St. Joseph Hospital and honorable treasurer of DSOG. She's presented many papers and posters in district and national forums, and her special interest in high-risk obstetrics and infertility. She's done fellowship and postdoctoral fellowship in reproductive medicine, diploma in reproductive medicine and embryology from Germany, and diploma in operative gynecology and endoscopy in France, and also a diploma in cosmetic gynecology. We welcome Selvarani ma'am for the. We would like other chairpersons to introduce our esteemed speakers.
Thank you, Shruti, for your wonderful introduction. First of all, I wish to thank Sampath ma'am and Vidya ma'am for giving us this opportunity to be a part of this wonderful webinar. Today, in this session, we are having 4 young and energetic persons to talk about various topics. Vaginal delivery after cesarean, stepwise devascularization in cases of BPH and hypothyroidism in pregnancy, and obesity and its a complication in pregnancy. For that, I want to invite Dr. Raja Suganya. She is assistant professor in Government Training Medical College. She did her MBBS in Kanyakumari and MSOG in Thoothukudi. And she is here to deliver a talk on VBAC in contemporary obstetrics. I welcome you, Dam.
Jyoti madam, எல்லாரையும் அப்படியே welcome பண்ணுங்க நம்மளோட VB conference கொடைக்கானலுக்கு.
Yes, we are conducting a wonderful and VP conference at Kodaikanal in August 10th, 11th and 12th. I expect each and every one of you to be there to join us to celebrate this VP conference. I welcome you all. Rajesh Suganya.
Thank you for introducing, ma'am. And I thank TNFOG for giving this opportunity. So today my topic is VBAC in contemporary obstetrics. So VBAC it stands for vaginal birth after cesarean section.
Sorry, Dr. Rajasugna, ma'am. You can enlarge your screen. Go to slideshow if you don't mind.
Slideshow.
VBAC, it stands for vaginal birth after cesarean section. The overall success rate is around 60 to 80%. Though the term seems very successful, VBAC has its own risks and benefits. So looking about the history, in 1916, Dr. Cragen, he coined the phrase, once a cesarean, always a cesarean. Since then, there was always a repeat cesarean section following a previous cesarean. Then in 1960s, some clinical studies concluded that repeat cesarean was not always necessary. And in 1980, the NIH conference panel, they recommended both TOLAC and VBAC. Since the recommendation, there has been a significant rise in the number of attempted VBAC from 1980s through 1996. Then in the year 1996, a major turning point happened when a study published that VBAC was associated with increased maternal complications than elective section. Then in 1919, ACOG recommended VBAC can be attempted in institutions where physicians are immediately available for emergency care. And in 2010, both NIH and ACOG, they recommended VBAC as a safe and appropriate choice for women with one cesarean and can be considered even in some women with 2 previous cesareans. So about the recent trends in VBAC, in the United States, VBAC has been slowly rising over the years, and it is around 14.2% in 2021. Studies also show that the increase in success of VBAC is more in the age groups of 20s and 30s, and it also shows a 5 to 13% increase in births when VBAC is attempted after 38 weeks of gestation. So why VBAC? So why talking about VBAC is gaining importance? So the main aim of VBAC is to decrease the total cesarean rate and especially to avoid the complications which are associated with multiple cesarean deliveries. So VBAC, whether it's the bone or bane, though VBAC, it has all the benefits of vaginal delivery, such as faster recovery, lesser blood loss, no risk of abdominal surgery, lesser infection rate. Though it has all the benefits of vaginal delivery, it has the major significant complications such as uterine rupture, hysterectomy, and fetal demise. So VBAC or elective repeat cesarean section, which is better? So VBAC, it is associated with a maternal success outcome of 70 to 75%. And the risk of scar rupture in VBAC is around 0.5%, whereas the risk is about nil in elective repeat section. The recovery time is shorter in VBAC, whereas it is longer in elective repeat section. And the chance of future pregnancy is increased in VBAC, whereas in elective repeat section, there is increased risk of again a repeated section, which can lead to complications such as placenta previa, accreta, and adhesions, etc. The risk of maternal death is about 4 per 1 lakh in VBAC, whereas it is around 13 per 1 lakh in elective repeat section. So talking about the fetal outcome, the risk of transient respiratory morbidity is around 2 to 3% in VBAC, whereas it is around 4 to 5% in elective section. And also the risk of hypoxic-ischemic encephalopathy is around 0.08% in VBAC and less than 0.01% in elective section. And the VBAC is also associated with a 0.04% risk of delivery-related perinatal death. So once a cesarean, is it always a cesarean? The answer is no. Actually, a woman with previous cesarean can have two options. Either she can undergo an elective repeat cesarean section, or else she can undergo a trial of labor after cesarean section. When she undergoes a trial of labor, there are two possible outcomes. Either she can end in a possible outcome of VBAC, or the TOLAC can lead to failure, leading to an emergency cesarean section. Though the VBAC has much lesser or more successful rate or fewer complication than elective repeat section, the failed TOLAC or emergency section has the higher complication rate than the elective repeat section. So it is very important to select the suitable candidate for VBAC. These are some of the recommendations for selection of candidates. So the women should have one previous low transfer cesarean delivery. There should be clinical adequate pelvis, no other uterine scar or previous rupture, and physician should be available throughout labor, should be capable of monitoring and perform emergency cesarean delivery, and there should be availability of anesthesia and personnel for emergency cesarean delivery. So what are the contraindications for TOLAC? So previous history of uterine rupture, previous high vertical, classical or T-shaped uterine incision, 3 or more previous cesarean deliveries, contracted pelvis or CPD, previous history of or associated of any obstetric or medical complications, insufficient staffing or facilities, and refusal by women. So there are so many factors influencing the success of VBAC. So looking after the factors, the type of prior incision and prior uterine ruptures. So the prior classical cesarean section is associated with 2 to 9% increased risk of rupture, whereas low transverse incision is associated with 0.2 to 0.9% of rupture. The prior preterm cesarean delivery is associated with the increased twofold risk of uterine rupture. So prior uterine rupture in the lower segment is associated with 2 to 6% risk, whereas prior rupture in upper uterus is associated with 9 to 32% risk of rupture. So about the prior incision closure, studies show that there are no significant difference between the type of closure, whether it is a single layer or double layer closure. So the rate of ruptures remains similar in both the types of closure. About the number of prior uterine incision, as the number of prior uterine incision increases, there is an increase in the rate of rupture rate. The imaging of prior incision. So some studies show that imaging of the or ultrasound imaging of the thickness of the uterine incision or scar can help in predicting the success rate, but still the studies are limited and they are not routinely used. So about the interdelivery interval, studies show that if the interdelivery interval is more than 18 months, they show better outcome in VBAC. So about the prior vaginal delivery either before or after cesarean section is a very best predictor for a successful VBAC. And the previous indication for cesarean section, it also plays an important role while deciding or predicting the success of VBAC. If the previous indication is a non-recurring indication such as breech or a placenta previa or other indications, that it shows a 90% success rate, whereas fetal distress associated with 80% success rate, previous labor arrest is associated with 60% success rate, and in prior second stage cesarean delivery, the risk of uterine rupture is highly increased. So fetal size, so studies show that as the size of fetus increases, there is also increased risk of uterine rupture. And about multifetal gestation, the studies show that twin pregnancy does not increase the risk of uterine rupture. Women with twins and prior low transverse hysterectomy can safely undergo TOLAC. So about maternal obesity, actually maternal obesity decreases the success of VBAC. So there have been so many scoring systems which are helpful in predicting VBAC, and though these scoring systems are helpful, they are not predictive as to 100%. Some of the scoring systems are phlegm giga storing, Groban scale, etc. Now, talking about the labor and delivery considerations, TOLAC should be undertaken only in facilities with staff immediately available to provide emergency care. And the woman who undergoes TOLAC should be made aware about the risk and possible outcomes. An informed decision about the mode of delivery should be obtained by both the woman and family members. A risk assessment and appropriate selection of candidates are very much essential for a successful VBAC. And should be noted that labor induction is associated with higher failure rate rather than spontaneous onset of labor. And induction is with misoprostol is contraindicated as recommended by ACOG. And also mechanical methods of induction show lower rupture rates than induction by prostaglandins. And epidural analgesia can be safely used during TOLAC. And continuous electronic fetal monitoring is essential throughout the TOLAC to diagnose earlier signs of uterine rupture. And benefits of routine scar evaluation in asymptomatic women are unclear, but surgical correction is necessary if significant bleeding is encountered. Now, talking about the current status in India, a study shows that the cesarean section rate has increased over the last 10 years, but the rate of VBAC still remains low. So this is attributed to the causes such as increased awareness of patients about the risk of rupture, and there are more patients are refusing to give consent for TOLAC, and due to medical legal issues and due to unavailability of adequate resources, the rate of VBAC still remains low. And also the safety of the mother and fetus, they take precedence over completing a successful trial of VBAC. However, trial of labor remains a safe option in selected patients with appropriate monitoring. So to conclude, adequate patient education and counseling, in addition to appropriate patient selection for TOLAC, remains the cornerstone to achieving high VBAC success rate with minimal adverse outcomes. Thank you.
Thank you. Thank you so much. It was a wonderful talk. Very nice, very sweet. Of course, as you said, proper selection. Am I audible?
Yes, ma'am.
Proper selection of cases is very, very important in a successful TOLAC. And according to the Robinson's criteria, number 5, the cesarean section rate for a post-cesarean pregnancy, it should be less than 50%. And we have completely covered the scoring systems and all. So proper selection of cases, epidural analgesia, and continuous fetal monitoring and the compliance of the patient, these things plays a major role in the successful vaginal delivery after a cesarean section. Thank you, Rajasuganya.
Thank you.
Selvarani?
Yes, ma'am.
Want to add anything?
Yes. Nothing, ma'am. I want to thank Dr. Rajasuganya for this wonderful topic and discussion. Because the thought of once a cesarean is always a cesarean is replaced by a term called TOLAC. But it should be planned after correct and appropriate selection of even patients who are perfectly eligible and with an anesthetist and theatre and ready with standby. Even though we have to reduce cesarean rates, overall our aim is to reduce MMR. So definitely Dr. Rajasuganya has done a wonderful job. Thank you, ma'am.
So, next, I call upon Dr. Ravikant. He did his MBBS from Mysore Medical College. He did his post-graduation in Mirage Medical College in 2002, diploma in pelvic laparoscopic surgery in Paul Hospital, Cochin, and a diploma in advanced pelvic laparoscopic surgery in Sunrise Hospital, Cochin, and he is an executive member in Foxy Society, Mangalore from 2019 to 2021. Professor and Unit Chief of KVG Medical College, Sulia, and Honorary Secretary of IMA Sulia Branch, Karnataka from 2021 to 2023. He had published so many scientific papers in national and international journals and authored a chapter in OBG textbook, A Practical Guide to Third Trimester of Pregnancy and Puerperium, and he is the chairperson of Endoscopy Committee, KSOGA, in 2023. We welcome you and we are here to hear your talk. Welcome you, sir.
Thank you, madam. Thank you for those kind words. Good afternoon to all. Good afternoon to all. At the outset, I would like to thank TNFOG, Team Kasoga for giving me this opportunity to share my experience. And I congratulate them for giving for such a such a nice conference on a wide variety of topics that are of very good clinical importance. So let us begin with a stepwise devascularization of the uterus. Let me begin with a case scenario. The surgeon noticed that uterus was flabby and bleeding after the extraction of the baby. It continued to bleed even after administering oxytocin, methergine, and carboprost, along with the resuscitation of the patient in a primiparous woman who had AB negative blood group during a cesarean section. Let's keep this scenario. So these are the headlines under which I am going to discuss about a stepwise devascularization of the uterus. So let us know about it. What is this stepwise devascularization of the uterus? It is a conservative method of treating a postpartum hemorrhage by surgical method. It should be considered only after the medical method fails. That is, a resuscitation of the patient with the crystalloid or if colloids if necessary, oxytocin, methergine, carboprost, bimanual compression, and tamponade. If all these methods are exhausted, only then we should consider surgical methods. Hemorrhage, which is a leading cause of death both in developed and developing countries. In a developing countries, it is accounting for 2/3 of the deaths. And in developed world also, it is a 27% of patients are dying because of this hemorrhage. Even an alarming sign of emergency obstetric hysterectomy is rising trend by 8%, which is a recent report of 2018. O'Leary has demonstrated as early as 1952, where its extensive study over a period of 30 years has shown that postpartum hemorrhage can be arrested by doing a uterine artery ligation. Waters went on to tell that uterine artery ligation can be anatomically sound, physiologically rational, and surgically possible method for a postpartum hemorrhage. It is the pioneered work of Sala and Abrabdo with a detailed study on 103 patients have shown a 100% success. In their study, even placenta previa and accreta were also included. So why should we consider this technique? It has shown that subsequent fertility and pregnancy were not affected following a stepwise devascularization of the uterus. And there are no reports of any adverse reaction like adverse effects like uterine fibrosis or uterine necrosis, which have shown in the isolated cases in a B-Lynch brace. And the systematic data has shown that none of these three techniques are superior to one another. So it can be considered. And Surgical Manual of Postpartum Hemorrhage Management 2018 has shown that stepwise devascularization uterus should be the first approach to stop the bleeding in a surgical method. So what is this actual technique? It is based on the principle that uterus gets a blood supply by 90% from the uterine artery and 10% is from the ovarian artery and also a small percent from the cervical branch of vaginal artery. Suppose if you ligate the uterine artery where it enters into the uterus at the level of the isthmus, that is junction of the upper segment and the lower segment, which can be easily approached. That is seen during a cesarean section when we open the uterovesical fold of peritoneum. And what we can do is we can go for a unilateral uterine artery up segment ligation at this level. And also, if it is failed, then you can go ahead with the contralateral uterine artery ligation. Only if the unilateral stepwise uterine artery ligation fails, then only we can consider opposite uterine artery ligation. If this also fails, then you can go ahead with the uterine artery ligation at the lower segment, that is where cervical branch of the vaginal artery and the lower uterine artery also is ligated. And unilateral ovarian vessel is also ligated if these step 3 also fails. Then it is step 4. And if you ligate a contralateral ovarian artery, then it is called step 5. Let me consider with a video demonstration. We can, with a needle, in a avascular area, in a broad ligament near the uterine artery, prick from anterior to the posteriorly. We can use absorbable suture for this. And then once the needle is taken, prick it from posterior to the anteriorly, 2 centimeter medial to the margin of the myometrium, so that we don't prick the vessel. Once it is taken outside, then it can be ligated. We are using an absorbable suture for this, and uterine artery is not divided after tying the knot. So they have shown that it is canalized completely after the 4 to 6 weeks. And it has not affected the fertility of the uterus. Definitely, the bleeding has ceased in 7 to 8% of the patient in only one side uterine artery ligation with this technique. That is step 1 method of uterine artery ligation. Now we can, if the patient continues to bleed even with this technique, then you can go ahead doing a step 2, that is opposite uterine artery upper segment ligation. That means principle is same, anterior to posterior in a broad ligament in the avascular area, and then bring the needle from posterior to the anterior 2 centimeter medial to the margin. This is done only if the bleeding continues after a step 1, that is opposite side uterine artery ligation. The ligation with the step 2 has demonstrated that it has stopped the bleeding in 70 to 80% of the cases. So step 1 was nearly 7% of cases, whereas using the step 2, it has stopped the bleeding nearly 70 to 80% of the cases. If this step fails, only then we'll consider step 3. Step 3 is a bilateral procedure, but before doing a step 3, we should do a separation of the bladder from the lower segment, as we do during a cesarean section. Principle is same, from anterior to posterior in the avascular area in the broad ligament, and then bring back the needle from posterior to the anterior through the myometrium, but 3 centimeter medially. Step 1 and step 2 was 2 centimeter medial to the margin of the myometrium, whereas in the step 3, it is 3 centimeter medial, so that we include cervical branch of vaginal artery, which also has a significant blood supply. So you see, it definitely stopped the bleeding from the lower segment. Step 3, if it is considered, it should be done on either side. As step 1, it is done only on the one side, which is step 1. If it is done on the opposite, it is step 2. But if you are doing a step 3, it is bilateral. So again, a needle is taken from the avascular area, posterior to anterior, and a 3 centimeter medial to the margin of the myometrium, posterior to the anterior. It is taken and then it is ligated. Here, with this only technique, the isolatedly step 3 uterine artery ligation has reduced the bleeding in nearly 8% of the cases. Isolatedly, if we do a stepwise devasculation by step 3 method, it has arrested the bleeding alone by 7 to 8% percentage of patients, along with the step 2, which has stopped the bleeding nearly 70 to 80% of the cases. Step 4, if it is done, it is unilateral ovarian artery ligation, that is infundibulopelvic ligament. Only if the step 4 does not stop the bleeding, then only you can consider a step 4, that is unilateral ovarian ligament ligation. Principle is same, through the avascular area, anterior to the posterior, absorbable suture, and a knot is made. If the bleeding continues, only then we will go ahead and doing the opposite uterine artery ligation. That is step 5. When is it indicated? Whenever you are doing a cesarean section and patient develops a postpartum hemorrhage and the patient continues to bleed in spite of all the medical methods, only then we'll consider a surgical methods. As we mentioned in our case scenario in the beginning of the discussion, that is a case scenario where the first indication of stepwise devasculation of the uterus is considered, which is fastest, simplest, and very small learning curve. Anybody who is able to do a cesarean section can do this procedure and is very effective. It is shown that even in coagulation disorder patients and a procoagulant replacement has not stopped the bleeding from the uterus. In uterine artery ligation is a very minimal dissection is necessary when compared to other procedures like B-Lynch brace and internal iliac artery ligation. And it has shown that placenta previa after multi-point suture, and you can consider a stepwise uterine artery ligation if multi-point suture does not arrest the bleeding. Stepwise devasculation is a step 3, which is the ligation of the lower uterine artery, which stops the blood from the lower segment, can be used. What is the success rate? O'Leary has demonstrated a 96% efficacy in a series of 265 patients. FAMI has shown the effectiveness of nearly 80% of patients in 25 patients, and Abish and Hush have shown that 92% of success in a small series of 13 patients. But it is the pioneered work of Sala and Abrabdo which has shown 100% success in a 1 or 3 patient study. So what are the complications? So mainly if you prick a vessel in the broad ligament or in the myometrium, there can be hematoma formation. But if a care is taken, as explained in the procedure, hematoma formation can be nil. Bladder injury and ureteric injuries are possible if you are doing a step 3. But if you separate the bladder from the lower segment, then this injury also can be very well avoided. Infection. If a bleeding is more than 1.5 to 2 liter, then prophylactic antibiotic should be repeated. Or if a resuscitation measures last more than 3 to 4 hours, then also we should repeat the antibiotic so that infection can be prevented. So what are the failure rate that have been explained in the previous slides? A special things about is that it has shown that nearly 46% which were followed up in their studies, most of the patients had resumed menstruation once they stopped feeding. And then fertility was not affected in many of the patients. Many patients had developed a normal pregnancy, even normal vaginal deliveries were also there. One special thing about this technique is that those patients who had a stepwise uterine artery ligation, none of the patients had a postpartum hemorrhage in the successive deliveries. So there are some modifications. B-Lynch brace is considered following a normal vaginal delivery, and then we can go ahead with doing a stepwise uterine artery ligation, because stepwise uterine artery ligation is considered a first technique whenever we are doing a cesarean section and the PPS develops. But whenever PPS develops following a normal vaginal delivery, B-Lynch brace is considered first, and then stepwise uterine artery ligation can be done. And also, if you are worried that ovarian artery ligation in a step 4 and step 5, if it is hampering the blood supply to the ovary, you can consider ligating a ovarian ligament or round ligament. Let me show with a small video. Here, instead of ligating a infundibulopelvic ligament, you can consider ligating a ovarian ligament and round ligament so that blood supply to the ovary may not be hampered. This is some of the modification that has been used, which is equally effective when comparing to the ligation of the ovarian vessel. So what are the current recommendations of FIGO 2022, which is showing the manual for a postpartum hemorrhage management as a stasis approach. Stasis means S stands for shift. Shift the patient swiftly from labor room to the operation theater, because we should not continue to manage these patients in the labor room itself till a point of no return happens. And also consider tissue and trauma, and also a various method of tamponade when it is necessary. And apply bimanual compression or B-Lynch brace, which is necessary to arrest the bleeding. And then you can go ahead considering the stepwise uterine artery ligation. So if it fails, then if the facilities are available, you can go ahead doing an interventional radiology with the uterine artery embolization. And also finally, you should not hesitate to arrest the bleeding by hemostatic hysterectomy. So what do I emphasize is decision from a surgical approach should be considered swiftly while we're managing a patient with the labor room. And while shifting from labor room to the operation theater, you should not we should not stop resuscitation the patient, like continuous oxytocin infusion, crystallite infusion, and other methods of arresting the bleeding should be continued. While shifting from labor room to the operation theater, patient perfusion also should be maintained. And go ahead doing the compression suture when the patient is shifted from normal delivery to surgical approach. But if you're doing it directly following a cesarean section, if it develops, stepwise devasculation should be considered first. So we are considering a step 1, that is one side up uterine artery ligation. Step 2, if the bleeding does not stop, at the opposite side uterine artery ligation. If this also does not stop, then you can consider step 3, that is bilateral low uterine artery ligation. And the step 4 is unilateral ovarian vessel ligation. Step 5 is contralateral or bilateral ovarian vessel ligation. Modification of the technique is you can consider a stepwise devascularization following a B-Lynch brace, irrespective of the cases. That means you don't wait for the B-Lynch brace to stop the bleeding. After B-Lynch brace, you can go ahead and do the stepwise devascularization of the uterus. And modification, one more is, instead of ligating a infundibulous pelvic ligament, that is ovarian vessel, you can ligate the anastomotic vessel, that is in a round ligament and round ligament and ovarian ligament. Studies have shown that stepwise devascularization of the uterus has not affected the fertility, pregnancy, and delivery. And also it has shown that postpartum hemorrhage in a successive patient has very well prevented in their previous studies. So these were the references from which I prepared these slides. And I thank you for patient listening. And I thank team TNFOG and Kasoga for giving me this opportunity to share my experience once again.
Ma'am, Jyoti ma'am, please unmute yourself, ma'am.
Yes, thank you, Dr. Ravikant. It was a wonderful presentation. As you said, in this modern medical legal world, PPH is a nightmare to every obstetrician. And as O'Leary advocated this uterine artery ligation in 1952, the majority of the blood supply, that is 90% of the blood supply to the uterus, is only from the uterine vessels. So if you do a unilateral uterine artery ligation itself, 70% of the PPH will be controlled. So if you are doing the next steps, step 1, step 2, step 3, still she is bleeding, again, you have to revise your diagnosis, whether it is due to atonic or traumatic or some other cause. Thank you, sir. It was a wonderful presentation. Thank you so much.
Thank you, madam.
Next, I call upon, we'll move on to the next session by Dr. Nagasudha. He was a young and energetic person, very active person in Madurai Obstetrics Society. She is my assistant professor in Madurai Medical College, Madurai, did her PG in Stanley Medical College, and she was a consultant at Aishwarya Fertility Center, and she got Best Daughter Award from the District Collector in Madurai in 2021. She had published many papers in the international journals. Her field of interest is high-risk obstetrics, infertility, and laparoscopy. Nagasudha, we welcome you. Over to you.
Good afternoon, madam. Thank you for the kind introduction, madam. First of all, I thank the organizers, TNFOG, and our beloved chief, Jyoti Sundaram, madam, for giving me this opportunity. Thank you, madam. Let me share the screen. Is it visible, madam?
Yes, ma'am. Yes, you are visible, audible. Continue.
Thank you, madam. The topic is on hyperthyroidism in pregnancy. So the screening should be started in the first trimester itself. The TSH levels are measured in the first trimester as per the Tamil Nadu guidelines. We don't screen only high-risk mothers, we screen all the antenatal mothers, and we find if the TSH levels are less than 2.5 percentile or less than 0.1 milli-international unit per liter, we label them as hyperthyroid and we start treating them. If the TSH levels are 0.1 to 2.5 milli-international units per liter, no further workup is needed. If it is between 2.5 and 10 milli-international units per liter, they have to be screened for the antibodies and treated accordingly. If it is more than 10 milli-international units per liter, they are directly started on Eltroxin. This is the reference value for the first trimester, second trimester, and third trimester for the TSH, T3, and T4 values. Coming on to the normal physiology in pregnancy, The TSH levels, total thyroxine, and thyroid binding globulin levels, all of them will be elevated in case of pregnancy. So pregnancy itself is a hyperthyroid state. The thyroid gland also increases in size about 10% in countries with adequate iron stores and 20 to 40% in iodine deficient countries. The thyroid function in the fetuses will be the fetus will start production of its own thyroid hormone about 10 to 12 weeks, and it reaches an appreciable amount by 18 to 20 weeks. The fetus is heavily reliant on the maternal thyroid hormone, especially in the first trimester. The maternal TSH doesn't cross the placenta, while thyroxine and TSH receptor antibodies can cross the placenta. There will be an increased iodine demand in pregnancy, so that the iodine from the baby mother will be utilized by the baby also to produce the thyroxine hormone. Estrogen and HCG hormones together will act to increase the thyroid binding globulin levels by decreasing the half-life of TBG, so that high levels of TBG are maintained in the blood and iodine levels are maintained, so that the baby produces thyroxine in an adequate amount. Coming on to the topic proper, hyperthyroidism prevalence is about 0.2%, the commonest cause being the Graves' disease. It can be overt hyperthyroidism, maybe a suppressed level of TSH where it is less than 0.1 milli international unit per liter, or it can be undetectable, less than 0.01 milli international units per liter. The clinical features of the hyperthyroidism include heat intolerance, shortness of breath, insomnia, elevated pulse rate, decreased exercise tolerance, fatigue, muscle weakness, and thinning of hair and hair loss. Most of them mimic normal pregnancy changes. The signs include thyromegaly, diffuse goiter, exophthalmos, pretibial myxedema, increased cardiac output, systolic murmur, and the resting pulse rate, which is more than 100. Exophthalmos, which is an ominous sign which could not be missed. Goiter is almost always present in cases of Graves' disease. Can be either an intrinsic thyroid disease like a toxic adenoma, subacute thyroiditis, iatrogenic hyperthyroidism, or it may be gestational thyrotoxicosis, transient in pregnancy only. It can present with nausea and vomiting. They are more common in multigravida. Hyperemesis gravidorum clinches the diagnosis. It can be present in hydathiform wound. So the effects in pregnancy include miscarriage, preterm birth, preeclampsia, thyroid storm, low birth weight, stillbirth, placental abruption, congestive heart failure, and thyroid crisis. The maternal effects include congestive heart failure can occur, thyroid storm, preeclampsia, early pregnancy loss, preterm delivery, and infection. Coming on to the fetal risk, there will be IUGR, low birth weight, prematurity, stillbirth, hyperthyroidism in the fetus, hypothyroidism in the fetus, and increased perinatal morbidity and mortality. Coming on to diagnosis, we do free thyroxine levels, T4 levels, free T4 index level, which will be elevated in case of hyperthyroidism. TSH levels will be low. If both of them are normal, the T3 levels will be elevated in case of thyrotoxicosis. TSH receptor antibodies should also be measured if we have a diagnosis of hyperthyroidism. Thyroid peroxidase antibodies, thyroid antimicrosomal antibodies, TSH receptor antibodies are measured to identify the cause. In Graves' disease, these antibodies will be increased. All of these to be measured in first trimester itself, because in second and third trimester, due to immunosuppression, there will be decrease in the antibodies and it will be masked. There is a term called fetal hyperthyroidism, where the antibodies will cross the placenta and the fetus will also be suffering from the Graves' disease. When can we diagnose this? The thyroid stimulating immunoglobulin levels, if it is more than 35%, TSH receptor binding inhibitory immunoglobulin levels, if they are more than 40%, we have to think that the baby is prone to produce, go for fetal thyrotoxicosis. This can be diagnosed by fetal tachycardia and ultrasound goiter presentation of the fetus. The other features of the fetal thyrotoxicosis include IUGR, craniostenostosis, cardiac failure, premature skeletal maturation, and hydrops. Coming on to the treatment proper, the drugs, the first line of drug we use in the management of hyperthyroidism is thioamides. They will block the peroxidase, which will prevent the iodination, as well as they prevent the peripheral conversion of T4 to T3. So the drugs will start acting only after all the stores are depleted. That is 3 to 4 weeks after starting the therapy. The drugs are propylthiouracil, methimazole, and carbimazole. Methimazole, which is highly teratogenic, can cause cutaneous aplasia, choanal atresia, gastrointestinal and facial defects. So propylthiouracil is preferred in first trimester. This is cutaneous aplasia. The dosage of propylthiouracil is from 100 to 150 milligram 8th hourly. The methimazole is 20 milligram in divided doses. Carbimazole dose is 15 milligram in divided doses. These dosage are decided by the T4 levels. And we have to maintain the lowest possible dose to keep the T4 levels in high normal range, because these drugs are prone to cross the placenta and they can cause hypothyroidism in a normal fetus. And the drug monitoring should be done once in 3 to 4 weeks with the pulse rate, weight gain, thyroid size, and the hormone measurements of T4 and TSH. The target total thyroid levels should be 12 to 18 milligram per deciliter, and free T4 levels should be 2 to 2.5 nanogram per deciliter. TSH should be maintained between 0.1 to 0.4 microunits per liter. While the patient is on antithyroid drugs, the TSH receptor antibody testing is recommended in the patients to identify the fetal hypothyroid risk. The adverse effects of these drugs are pruritic rash, pruritus, drug fever, nausea, and agranulocytosis. Agranulocytosis warrants the stoppage of the drug, while transient leukopenia can be managed without stopping the drug. So all the patients who are started on antithyroid drugs should undergo a leukocyte count before initiation of therapy. Coming on to the other drugs, beta blockers, they are used as adjunctive to reduce the tachycardia, palpitation, and tremors. They are used transiently only because they can cause the small placenta, IUGR, neonatal distress, impaired response to anoxic stress, the postnatal bradycardia in the fetus, hypothermia, and hypoglycemia. To prevent all these complications, they are used only transiently to reduce the heart rate and palpitation. The drug of choice are propranolol 20 to 40 milligram, 8 to 12 hourly, or atenolol 50 to 100 milligram per day for the control of thyrotoxicosis. Once the thianamides start their action, these drugs can be withdrawn. Coming on to iodide, low dose iodide can cause fetal goiter, and this is not recommended in case of pregnancy. The next mode of treatment is the thyroidectomy surgery. Total or subtotal thyroidectomy can be planned if the antithyroid drug fail to control thyrotoxicosis, and this can be decided if the patient needs propylthiouracil more than 300 milligram or methimazole or carbimazole dose more than 40 milligram per day. And the appropriate time, as usual, is the second trimester for elective surgeries. Coming on to radioactive iodine therapy, which is contraindicated in pregnancy. And any person who is going radioactive iodine therapy should go for contraception for 3 months. There is no data for or against termination in case of inadvertent use of inadvertent exposure of radioactive iodine. So the ball is in our court. We have to decide whether to terminate or to continue the pregnancy. Coming on to subclinical hyperthyroidism, where the FT4 will be normal and low serum TSH levels. Compared to hypothyroidism, hyperthyroidism doesn't warrant any treatment because it will not cause any adverse effects for the fetus as well as the mother. The next is thyroid storm in pregnancy. It is a life-threatening exacerbation of thyrotoxicosis precipitated by stress, labor, infection, preeclampsia, or cesarean section. Most of the time, they will present with a fever, tachycardia, tremor, and changes in the mental stage, nausea, vomiting, diarrhea. So we will have a confusion of whether it is due to infection or due to thyrotoxicosis. We had a couple of cases in our GRH where we diagnosed thyroid storm and treated them. The complication of untreated thyroid storm will be shock, stupor, coma, and maternal heart failure can occur, which can result in mortality. Treatment of thyroid storm in pregnancy includes IV hydration with D5 cooling measures, cardiac monitoring, and O2 as needed. Propylthiouracil 1000 mg loading dose, then followed by 200 mg perorally can be given. Propranolol to control tachycardia, steroids to inhibit peripheral conversion, like dexamethasone 2 mg IV 6th hourly, or hydrocortisone 100 mg IV 8th hourly. Iodates are not used now. Coming on to the diagnosis of thyroid swelling or thyroid nodule, we have to go for an ultrasound where we can find a high suspicion in ultrasound or intermediate suspicion. If both of them are present, that is, we suspect highly, we can go for FNAC if it is more than 1 centimeter. Low suspicion, if it is there, we can recommend FNA at more than 1.5 centimeter. If very low suspicion is there, we can consider FNAC if it is more than 2 centimeter, or we can just observe and go. If it is found to be benign, there is no need for biopsy at all. Coming on to carcinoma in pregnancy. Papillary thyroid carcinoma detected in pregnancy, early pregnancy, can be monitored sonographically. If it grows substantially before 24 to 26 weeks of gestation, or if it is cytologically malignant node positive, then surgery should be considered. However, if it is benign and if the disease is stable, there is no increase in size, we can plan surgery after delivery. But the impact of the medullary carcinoma or anaplastic cancer is unknown. So we have to plan surgery immediately once we diagnose medullary carcinoma or anaplastic cancer. Pregnant women with thyroid cancer should be managed at the same as the TSH goal as determined pre-conception. TSH should be monitored every 4 weekly until 16 to 20 weeks of gestation, and at least once between 26 and 32 weeks of gestation. So, preconceptional counseling in a patient who is already hyperthyroid is always needed, and they should be rendered euthyroid before they go for conception. And all the modalities of treatment options like surgery, drugs, and radioactive iodine, which is contraindicated in pregnancy, should be discussed with the patient. Birth defects associated with the drug usage should be detailedly explained to the patient. The patients taking methimazole or propylthiouracil should be advised to contact the consultant once the pregnancy is confirmed. So, if the patient who is already Graves' disease, who is euthyroid, who is on low dose anti-thyroid drugs like propylthiouracil or methimazole becomes pregnant, that is, the propylthiouracil dose is less than 100 to 200, we can consider discontinuation of the drugs to avoid the teratogenic effects. Only if the patient is cooperative and only if everything is under control. The disease history, duration, thyroid function test, TSH receptor antibody measurements and clinical factors should be taken into consideration before stopping the drug. And they should be followed up in 1 to 2 weeks. And we can reconsider whether to start or discontinue the drug. If it is normal, 2 to 4 weekly review should be done in the 2nd and 3rd trimester. If we suspect that if we stop the drug, the patient will go for thyrotoxicosis, she is more prone to develop thyrotoxicosis, we have to continue the drug. Propylthiouracil is recommended when compared to methimazole because it can be less teratogenic. Methimazole can be switched over to propylthiouracil if possible in first trimester. The dose equivalence of 5 milligram of methimazole is equivalent to 100 milligram twice daily of propylthiouracil. Coming on to postpartum thyroiditis, patients with postpartum depression should be screened for thyroid function test, and they can be started on beta blockers at the lowest possible dose, propranolol 10 to 20 milligram. Antithyroid drugs are not recommended for thyrotoxic phase of postpartum thyroiditis, and the patient should be followed with a TSH 4 weeks later. If they are found to be hypothyroid, they can be started on thyroxine. Thank you, madam.
Selvarani?
Jyoti madam, Selvarani illa pola irukku. Neenga solluங்க.
It was a wonderful talk, Nagasudha. Thank you so much. And again, transient hyperthyroidism may be there in hyperemesis and in multiple gestation due to elevated HCG levels. And if you want to check thyroid antibodies along with the TSH, it should be checked only in first trimester. And once the patient is on thionamide, the transient leukopenia may be there, and they need not be put on serial blood counts. But once the patient develops sore throat or fever, you have to test the counts. And our goal is to treat with the lowest possible dose of thionamide to maintain normal TSH levels. And usually subtotal hysterectomy is not done during pregnancy, but it is very rarely indicated when the patient does not adhere to the common medical treatment or drug therapy proves to be toxic to these patients. Thank you so much, Nagasudha. We enjoyed your talk.
Thank you, madam.
Thank you so much. Next, shall we go to the next topic? Welcome, Dr. S.S. Gayatri, my close friend and a daughter of the Emeritus Professor Dr. Gauri from Madurai Medical College. She was the former HOD, Department of OG, Sivagangai Medical College, and she did undergraduate and postgraduate in Madurai Medical College, and she was a UG and a PG teacher for more than 20 years. Twice, she got the Best Doctor Award from the collector, and she was a faculty in UFOXI and the National AAC-OG conferences. Her field of interest, of course, high-risk obstetrics, and she had presented various papers at national conferences. Over to you, Gayatri.
Dr. Gayatri Illiya.
Lila, she is there.
Gayatri ma'am, are you there?
Yeah, she is here only.
She's with the Jyoti Sudhar madam கூட இருக்காங்க.
Okay.
Slides audible?
Yes, ma'am.
Dr.
Yes,
Gayatri
ma'am.
audible.
Please make it a slideshow, ma'am.
Thank you, KNFOG and KSOGA for giving me this opportunity. And thank you, Jyoti ma'am, for your very nice and kind words of introduction. My topic today is obesity in pregnancy. Obesity is of increasing incidence throughout the world. Okay, ma'am. 1 minute.
கீழ இருக்கும் பாருங்க அந்த கப்பு மாதிரி.
One, madam. Obesity is of an increasing incidence. This with body mass index criteria in various population. In the Asian Indian population, Overweight is considered to be the body mass index between 23 and 24.9, and anything of more than 25 body mass index is considered obese. The waist circumference in women should be more than 80 to consider them obese. This is Asian Indian compared to the international criteria, where body mass in more than 30 is considered, and women waist circumference more than 88 is considered. So we are in a scenario of epidemic that has raised the incidence of obesity from 20% to 31% in the last 1 decade. NIH definition of obesity is in 3 classes. Class 1, where the BMI is between 30 to 34.9. Class 2, the BMI between 35 and 39.9. And class 3, where the BMI is more than 40. Should allow 8 times increased risk of cesarean section, 6 times greater risk of gestational diabetes mellitus, 2 times greater risk of shoulder dystocia and associated complication, 2.2 times a risk for stillbirth. And this also decreases the incidence of VBAC in the case of previous cesarean by 50%. So what are we going to do? If we can get them in the pre-pregnancy state, we have to advise them weight and lifestyle modification in the preconceptional counseling. The weight and BMI should be measured to encourage women to optimize their weight before they go into pregnancy. Women of childbearing age with a BMI of 30 kg per meter square or greater should receive information as well as advice about the risks the obesity gives during pregnancy and childbirth, and they should be supported by their obstetrician, family physician, and of course the family to lose weight before conception and between pregnancies. So when we see a woman with BMI of 30 kg per meter square or more greater wishing to become pregnant, they should be also advised to take preconceptional folic acid at least 1 month prior to conception and continue during the first trimester of pregnancy. So why we give so much importance to obesity in pregnancy? Because of all these complications that occur in increased frequency in an obese pregnant woman. In preconceptional state, we have subfertility due to PCOS. In the antepartum period, there is increased incidence of miscarriage, congenital anomalies due to undiagnosed DM, GDM, preeclampsia, fetal macrosomia, obstructive sleep apnea, which gives a hypoxia to the mother and fetal growth restriction and difficulties in imaging ultrasound. During the intrapartum period, there is prolonged labor, shoulder dystocia, difficulty in anesthesia when there is an operative delivery, increased incidence of cesarean section and decreased VBAC, and also an increased incidence of post-term pregnancy and associated complication. In the postpartum period, there is an increased incidence of PPH, wound infection, wound resuturing, higher incidence of venous thromboembolism, and postnatal depression. Everyone in detail. Slide is not changing. Yes. No. So coming to obesity and miscarriage. An obese woman are at significantly risk of miscarriage. There is a 3-fold increased risk in recurrent miscarriage. So this is one of the single most modifiable risk factor for miscarriage. This occurs because adipose tissue produces inflammatory and prothrombotic agents like plasminogen activator inhibitor 1, which are thrombophilic and they lead to miscarriage. Metformin, the magic drugs, reduces this PA1 and it's beneficial in reducing miscarriage. Coming to obesity and gestational diabetes mellitus, they are directly proportional. More is the incidence of obesity, more is the incidence of GDM. Overweight or obese with increasing maternal age are risk factors for hyperglycemia in pregnancy. The damage caused by in utero exposure to hyperglycemia is not just limited to the neonatal period. It extends to the child's rest of the life, increasing the incidence of childhood obesity and the problem thereon. The hormones in pregnancy, namely estrogen, progesterone, cortisol, HPL, they block insulin and decrease insulin resistance. But however, women with pre-existing insulin resistance like obesity and PCOD, they are more prone to develop GDM. So hence, insulin is the first line of therapy which restores the placental endothelial function, which when damaged, we know leads to the increased incidence of preeclampsia. So pre-pregnant obesity or excessive weight gain during pregnancy both increase insulin resistance. They reduce the cytotrophoblast migration and uterine artery remodeling, thereby increasing the incidence of placental hypoxia and ischemia, resulting in release of soluble anti-angiogenic and inflammatory factors. So this increases the incidence of risk of preeclampsia in the pregnancy, which is associated with obesity. Hence, low-dose aspirin has to be supplemented to these women. So, obesity is causing venous thromboembolism is of an increased incidence because in pregnancy, there is increased fibrinogen, increased thrombin, increased plasminogen activator inhibitor, decreased protein S. Hence, it is a hypercoagulable state. But in obesity, there is chronic inflammation of blood vessels, impaired fibrinolysis, endothelial dysfunction, and platelet activation, which increases the incidence of thrombosis. So these two join hand in hand in increasing the incidence of venous thromboembolism, and it has to be tackled whenever a pregnant obese woman comes to you for antenatal care. Congenital anomalies are of threefold increase in preconceptional obesity, mainly the neural tube defects, cardiac anomalies, and diaphragmatic hernia. Is it easy for us to scan them? Again, obesity has its own difficulty in ultrasonography because adipose tissue is echogenic and the excess abdominal fat results in absorption of sound beam, which leads to marked attenuation and decreased image clarity. So how are we going to deal this patient who are coming to us with obesity and pregnancy, who are also prone to all the intrapartum complications we name in the book, namely prolonged labor, increased shoulder dystocia due to fetal macrosomia, increased operative vaginal deliveries, and therefore there is an increased primary section rate. So with the primary section audit going on throughout the state, we have to be all the more careful when we deal with obesity complicating pregnancy. And when we talk about obesity and surgery, there is always the problem of obstetric anesthesia. For an obese patient who is pregnant, combined spinal epidural technique represent the ideal anesthetic technique for cesarean delivery because spinal anesthesia gives a dense surgical blockade and epidural the potential prolongation of anesthesia in these women and making them ambulant early, decreasing the incidence of venous thromboembolism. The complications of general anesthesia is always there, where there is a difficulty in bowel and mask ventilation, failed intubation, gastric aspiration, and post-op atelectasis, which makes post-operative respiratory therapy mandatory. In the intraoperative complications, we have got longer operating time and more manpower to retract, increased risk of blood transfusion, increased risk of reintervention in the form of wound infection, resuturing, and of course, the need for special lengthy instruments to give proper retraction to us. So to name a few post-operative complications, sepsis is of an increased incidence in morbid obesity. That is wound infection, wound dehiscence, venous thromboembolism, which we saw already, and in later stages, giving rise to pulmonary embolism and sudden collapse of the mother in pregnancy, increased incidence of respiratory infections, and of course, atelectasis. So how are we going to deal with all these problems along with the long-term complications of the mother, which are coronary heart disease, type 2 DM, and malignancies? In the fetus, high risk of fetal loss, stillbirth, congenital anomaly, and of course, childhood obesity. So now comes the role of bariatric surgery. So how we can control obesity in pregnancy by making the patient non-obese prior to conception and antenatal period. So there are two types of bariatric surgeries we have, which are restrictive and malabsorptive. The restricted ones are adjustable gastric banding, sleeve gastrectomy, which is frequently practiced in the Indian scenario. The row and loop gastric bypass, mini gastric bypass, or biliopancreatic diversion with duodenal switch are advanced techniques which come under malabsorptive ones. So in the restrictive type of bariatric surgery, our aim is to reduce the calorie intake by reducing gastric capacity. So as I told you, it can be a laparoscopic adjustable gastric banding, which converts the stomach into a small pouch. However, the complications are there like gastric prolapse, stromal obstruction, pouch dilatation, and sleeve gastrectomy, which is commonly practiced in the Indian scenario, is an irreversible one where there is a long part of the stomach along the greater curvature is removed as a sleeve, leaving the stomach as a small pouch. Among the malabsorptive ones, which we have discussed, is the biliopancreatic diversion or a jejunal-ileal bypass, which is a long one, and Rowan loop gastric bypass, which combines both restriction and malabsorption. In the malabsorptive ones, we have to look for the deficiency of iron, calcium, folic acid, thiamine, etc. when the patient gets pregnant, and proper supplementation of these vitamins must and the minerals must be made in a mother with pregnancy after bariatric surgery. In Rowan loop bypass, we have got the dumping syndrome experienced by ingestion of large quantity of carbohydrates, which has to be dealt by the nutritionist so that the patient doesn't get into complications. So the ideal timing of conception following all these bariatric surgery is 1 year, because maximum amount of weight loss occurs only in those 1 year. 4 kgs in the first 1 month, followed by 2 kgs per month. So at least we have got a 10 to 15 kg weight loss in the 1 year period. So when she reaches the ideal weight, she can be allowed to go in for consumption. So, and also that is a period during which nutritional deficiencies and electrolyte imbalance can occur, which we can correct. So optimal gestational weight gain must be aimed. So this will be the predictor for birth weight, postpartum weight retention, and weight gain. And this also should be limited in such pregnancies. So the ideal gestational weight gain should be 7 to 11 kg in those patients with obese undergoing bariatric surgery. So management of pregnancy following bariatric surgery is again a rising field of obstetrics. So contraceptive counseling is mandatory in the preconceptional era to delay pregnancy up to 12 months. Adequate patient education is the key. So follow up with the nutritionist, dietitian to monitor nutritional status and weight gain is mandatory. Folic acid, vitamin B12, calcium, and iron supplementation must be given to these patients, because in few cases of malabsorption, higher supplementation will be needed, which has to be discussed with the nutritionist. The antenatal care, it should be in a multidisciplinary setting. So you keep the bariatric surgeon in the loop to follow up on these patients. Early antenatal consultation is important, and emotional support is important, because these patients will be afraid of weight gain during pregnancy. So you have to counsel them properly, and you have to determine the baseline nutritional status and monitor their adherence to the nutritional supplementation. Regular blood tests may be required following malabsorptive bariatric surgeries, and we have to check for micronutrient deficiencies. Weight of the individual at every visit should be monitored to monitor the gestational weight gain for these patients. So you will have to take the fasting and 2-hour postprandial glucose monitoring for a week to detect GDM as a standard, because GTT can induce dumping syndrome. Screen for neurotubal defects and arrange serial ultrasound scans to focus on intrauterine growth restriction or malformations. Even if there is a slight suspicion of intestinal obstruction, we have to perform clinical examination and imaging studies, and surgical exploration may be needed in these patients, because there is a high risk of venous thromboembolism in these patients. Thromboprophylaxis is mandatory for them. Coming to the intrapartum monitoring, there is no medical reason that the pregnant woman post-bariatric surgery requires delivery via cesarean section. It is important to anticipate problems and effectively prepare equipment and personnel. Fetal scalp monitoring, if available, may be required. In the postpartum care, adequate pain control, early mobilization to prevent complication, thromboprophylaxis and physiotherapy is mandatory. We have to encourage breastfeeding, follow up with the nutritionist to ensure healthy diet and to guide further weight loss if required. Women considering body contouring surgery post-bariatric should wait until they have completed their family, as future pregnancies can reverse the effects of cosmetic surgery. So obesity on the rise with increased risk of antenatal, intranatal, and postpartum complications in the modern century, we can expect more patients to come to us for antenatal care and pregnancy care following bariatric surgery. So thank you for giving me this opportunity and a nice topic for discussion.
Thank you very much. Yes, ma'am, go ahead.
This video is not coming up. Anyway, it was a very talk, Dr. Gayatri. You have covered from the prenatal period, antenatal, intrapartum, postpartum, and everything. And regarding, and this one also, bariatric surgery also. Wonderful talk. Thank you so much. Once again, I take the opportunity of inviting you all for the Kodaikanal conference, which is to be scheduled on August 10th, 11th, and 12th. It is our VP conference, Dr. Sambat Madam's conference. I expect every one of you to be there. Welcome you all to Kodaikanal. It was a great cultural as well as academic extravaganza. So I expect every one of you to be there to join with us and to celebrate this VP conference. Thank you so much. Thank you, Sambat Madam, for giving me this opportunity to be a part of this wonderful seminar. Thank you. Thank you so much.
Jyoti Madam. Thank you. Yes.
Thank you, madam. Yes, ma'am.
Radhika, next session.
Okay,
Madam. All wonderful speakers.
Thank you, Jyoti Madam.
Thank you.
And, thank you so much for the team. Now we are moving on to the next session, which is a panel discussion on clinical challenges in cesarean section. So the moderators are Dr. Chitra Madam and Dr. Chitra Madam again. So first I invite Dr. S. Chitra Madam, who is a consultant in Obs and Gynae, infertility specialist at Lalita Nursing Home, Shamala Nursing Home, and Janani Trichy Fertility Center. And she has been a past secretary, Trichy Obs and Gynae Society in 2014, organizing secretary in International Conference, Tech OG Trichy 2014, and she was also the organizing secretary, International Conference Endo Medcon OG Trichy 2016, past president of Trichy OG Society 2018. She has presented various national and international papers. Next, Dr. Chitra Tyagaraju Madam. She has done a DIPN-B, DGO, MNAMS, and FICOG, also MBA in Human Resource and fellowship in reproductive medicine, fellowship in minimal access surgery, MBA in hospital management, I'm sorry. So she is a professor and she has won numerous awards, Dr. Purnima Nadkarni Award for Best Paper, ISAR 2020, and many other awards.
Yes, ma'am. I think we can just start off, ma'am.
Okay, ma'am. Sorry. And next panelist is Dr. Durga Das, Kasturba Hospital, Tumkur. She is a treasurer in Kasoga 2020 to 22, past executive committee member, and past president is OG, associate professor in Sri Siddhartha Medical College, Tumkur, consultant in Kasturba Hospital, Tumkur. The next panelist is Dr. Priya Balal, professor and former head Department of OBG, KMC Mangalore, a constituent of Mahi, Manipur, managing partner and consultant Vijaya Group Hospitals, Mangalore. And she's been teacher, postgraduate, undergraduate teacher since 2000. She's received Dr. Patrick Pinto Best Teacher Award, KMC Mangalore. And she's received numerous awards and presented at national and international conferences. Her special interests are high-risk obstetrics as well as laparoscopic surgeries. Next, I invite Dr. R. Tillai Nachiyar, Madam, she has done MBBS DA and MD OG. And she's finished her MBBS in 2004 and Diploma in Anesthesia 2012, MD OG in 2018, and joined Tamil Nadu Government Service in 2005. So she worked in Omathurwar Medical College, and she's now is working in Kilpauk Medical College, Department of OG, as senior assistant professor, has presented numerous papers, and her field of interest is infertility, lap surgery, epidural obstetrics, and critical obstetrics. Next panelist is Dr. Archana Ambuja. She's a director and consultant OGCON and fertility specialist, Omega Fertility Center, Sundaram Arulraj Hospitals in Tuticorin, Tamil Nadu. And she's a gold medalist and best outgoing student in MSOG. She underwent infertility training at Women's Center in Coimbatore and advanced training in fertility at Kiel University, Germany. And she has started the first fully equipped fertility and test tube baby center at Tuticorin. The next panelist is our coordinator, Dr. Shruti Bhavi Patil, who is Associate Professor and Unit Chief, Department of Obs and Gynae, GIMS Gadag, Karnataka. She is also the President of IMA Women's Wing, Gadag in 2022 to 23, and president of the OBG Society as well, and 2022 to 23, and secretary in 2019 to 20. And she's site co-investigator for WHO Labor Care Guide and WHO STEPMAC trial, local nodal officer for Lakshya program. She has numerous national and international publications, also participated in RCOG World Congress 2021 and received the best oral paper and poster presentation. Awarded Foxy Dr. Kamini Rao Orator for the year 2021 South Zone. And Iconic Healthcare Leadership Award has been given to her. Golden AIM Conference, Veera Champion Award also has been awarded to her. And she also has received Appreciation Award as COVID Warrior from Chief Minister of Karnataka at GIMS Gadak. And she won second prize for consultant quiz at State OBG Conference. And the next participant is Dr. Shanta Sheikh, who is an MBBS MD OBG. She owns the Shanta Nursing Home, Shivamoga. She's been the organizing secretary as KSGOA in 2017, and her field of interest is high-risk pregnancy, infertility, and ultrasonography. All madams, you are welcome for the interesting panel discussion.
Thank you very much. And we welcome all the panelists. And I think we'll go ahead with the panel straight away. Chitra has her slides at her end, so she'll be focusing it.
Yes. Hello, everyone. I think I'm going to have a very nice panelists who are really experienced in the field of obstetrics and gynecology. So there'll be more like a discussion and take home messages for few people, not only for the practitioners, even for the PGs to know if at all they face with difficulty, how to come out with the solutions. Yes. So I welcome all the panelists, and today this is moderated by both Chitra Square from Tirchi and Pondicherry. So you're going to have a nice time. So as everyone knows, there is an cesarean birth is an unnatural method of natural event, yet there's another way to get on. So when I went to one of the slides, it shows there's increase in rate of cesarean section way back in 1995 to 2023. It is almost reached to 40%. I think so in UP or something, the court has put an audit for some of the government hospitals and private to audit why there's increased rate of cesarean section. So I like to ask Dr. Priya, please, can you tell us why there's increased trend towards LSCS is going up to 40%? Being our institution, still we have around 20 to 25%. So what do you think the reason there's increase in peak? Dr. Priya, can you hear me? Yeah.
Good morning, Dr. Good afternoon, Dr. Chitra and the rest of the panelists. Am I audible?
Yes, yes, yes. Yes, Priya.
Yeah. This is a very interesting and a very pertinent question. When WHO had initially set a cap to 19% as an optimal cesarean rate. But beyond that, there is a lot of change that has happened. And now I think with the Robson's classification and criteria, the for them. Why I'm saying so is a tertiary hospital like ours has an incidence of cesarean at 40 to 50% because we get most of the referred cases. The same cannot be a guideline for every institution or every hospital. So the increase, as you the incidence will be higher. Now, coming to your question of why there is an increase, because cesarean sections have become safer and because of the medico-legal issues, that the lesser use of instrumental delivery, it may be because of lack of skill, lack of training, or even a more safer or a better route of delivery in cesarean, especially in complicated cases. So nobody would want to find themselves in a soup. Third thing is, most of the patients we see now are elderly women beyond 35 years of age. So that itself becomes one high-risk criteria. Along with that, the number of patients who conceive after infertility, etc. And also women restrict their family to 1 or 2 children. And, nobody wants anything to go wrong. So in that situation, obstetricians are also in high pressure to make sure, they don't want to take the risk. So The most important thing is advances in technology, advances in diagnosis. So with the ultrasound, we identify more situations antenatally, growth restriction, etc., is monitored more carefully. And so to have a better perinatal outcome, probably the incidence of cesarean has also increased. So it's a contribution of everything. The medico-legal pressure, the incidence of high-risk factors going up in antenatal women, advances in technology, everything put together. So I think the best thing for oneself to do is to write out indications clearly or think about it before we plan a cesarean. What is the need for the cesarean? Is it required? Mother's point of view, yes. Baby's point of view, and take a call in a well-counseled patient.
Thank you, Priya.
Yeah.
Chitra, Pondicherry Chitra. I'm here. Okay. I think she was talking about even the preference the patients place in front of us, right? Now their demand for cesareans. That also is another big issue.
I just want to ask the other panel. Yeah.
That's what.
Yeah,
Of
ma'am. And also the increase in the
Cesarean on
non-communicable
demand.
diseases like hypertension, diabetes, the elderly pregnancies are also more.
That's
So
what
I think the rates.
Everybody has a high
about all that. She was
high
telling
risk
about the
factor.
maternal diseases and the age is a big factor. Obesity is another big factor, which is always, pushing us to that, not knowing what to do with all these obese women. All these things, of course. And the last but not the least is the patient's demand. Okay.
Correct.
I think, yes.
Chitra, we can't hear you.
Okay. I think the other Chitra.
Chitra, yes. Sorry. Okay. I think most important is there's a lack of vaginal like instrument delivery or the forceps delivery, especially in the PGs who are not being trained. They won't be able to take risks when they have to start a practice. So in those conditions, they really go for a cesarean section. So these are the few of the things which has increased rate of cesarean. Can you see my slides?
Yes.
Yeah. So one is then what we are discussing is a medical, what Dr. Priya has all called medical justified conditions. If you do, you are very safe as good as vaginal delivery. But when you go according to the patient preference or physician preference, cesarean section have known to have a more maternal morbidity and mortality than this vaginal delivery. So as already again Priya told, the achievement by 2015 WHO statement was at least 10 to 12%. They showed whenever you have cesarean section rate of 10 to 15%, it always shows there's a decrease in the maternal mortality and morbidity. But anywhere it is more, then you should be very cautious and you have to try to provide what you call a better cesarean section for only indicate cases rather than achieving a specific rate. So to have this cesarean section, you need a better anesthetic technique, better antibiotics, availability of blood transfusion, improved surgical techniques. So as we know, there are a lot of indications for elective and emergency sections. I'd like to ask Dr. Thillai, what are the most common indications for LSCs? Dr. Thillai is here. Okay, Dr. Archana, Dr. Shruti, you can please tell.
Yes, ma'am. I'm Dr. Thillai Nachar.
Oh, Thillai. Okay, please.
Yes, ma'am. We are doing for cephalopelvic disproportions and big baby. Head is not descending for periods. We expected periods and mostly and for thick MSL, patient is going for bradycardia and severe attack.
So fetal heart rate forms the most important component for any patient for LSCs.
Really compromised.
Yes.
And we prayer itself elective cesarean section we are planning for severe major CPD. That is we planned early itself.
Yeah. So most common what in the literature is a previous LSCs is the most common indication for LSCs. That can be second to fetal distress, cephalopelvic disproportion. But according to the category 1 and 2, which is a must, you have to do cesarean within 30 minutes is a fetal distress. That is the most thing. So you know various types, and Dr. Shruti, have you come across any cesarean hysterectomy done? I mean, classical cesarean section. Anytime you have come in your practice where you have did classical cesarean section?
Classical cesarean, I have not come across, ma'am, but definitely with the increase, we have seen increase in the placenta previas nowadays. And I mean, we are going for most of the times peripartum hysterectomy because so that kind of difficulties are always there when taking the incision over the uterus. But as such, we are not doing
adherent placenta.
So
yeah,
anyone has
all the
come across doing
placentas.
classical in this era? I just wanted to know, because we have various indications. Anyone's faced this and gone for classical rather than the well-versed. Dr. Priya?
Yeah, I have used the classical in one or two instances. One was a situation where there was a placenta adherence syndrome, an accreta placenta in the lower uterine segment, where we would, an anterior, where we wouldn't want to disturb the placenta. Even though we've planned for a peripartum hysterectomy, we rather much not disturb the placenta and not have too much bleeding. So I did a classical cesarean in one of that situation. Another one was a very large fibroid in the anterior part of the lower uterine segment, where it was more than a 20 centimeter fibroid. So we had to go for a midline and a classical cesarean. Another probably an indication for a classical cesarean is also a transverse lie with a back lower down. Yes, that situation also a classical cesarean is indicated. And sometimes when you have cervical cancer and pregnancy, then also. So I have used classical cesarean
I think
in a few
according to know what I've
instances.
seen is your first indication. Whenever you have a placenta accreta spectrum, you don't have to disturb, you do the classical cesarean. So,
and I don't know, but in our center, we are seeing the incidence of placenta adherence syndrome going up by the day.
True.
We're seeing more and more of adherent placenta.
It was not only patient with previous LSCs, even patient who had got recurrent pregnancy loss, have a curate age. Those patients also we have seen the adherence is increased. Though many people will tell, yes, this is a 30 minutes procedure, we can do it fast, it's simple, it's alternative, but still we have difficulties with cesarean section. Yeah, it is a lot of difficulties. So can I have Dr. Shruti is there? I'm sorry,
Yes,
Dr.
ma'am.
Shanta?
Yeah, I'm here.
Yes, ma'am. Please, can you tell me what are the difficulties you encountered during LSCS?
The difficulties are mainly if the patient is with previous LSCS, we have difficulty in separation of the bladder sometimes. Also, if the lower segment is not well formed, then sometimes we difficulty opening up the lower segment and we go a bit higher up. Otherwise, if there is anything like placenta vessels there, then opening the patient and we have to.
Ma'am, your voice is breaking.
Yes. Now you can hear me?
Yeah, yes, ma'am.
Most of the time, if the patient is having previous LSCS, then we have adhesions to the anterior abdominal wall, and also there are adhesions to the bladder. And if the lower segment is not well formed, when we do it in a patient with premature baby, or if there is any mass in the lower uterine segment like fibroid, like Dr. Priya told us, or if it is a placenta previa central and we see lot of blood vessels, then we have difficulty in these patients.
So it is not only primary cesarean section, it's not a previous LSCs, even the primary sections will also have a lot of problems when you deal with the placenta previa. So there is various abdominal issues will be there, and you have a very difficult access to getting into the lower uterine segment, or you might, sometimes you have uterine malformation. Again, it will be difficult in delivering, giving of the infusions, and especially malpositioned baby with any associated risk factor like PROM or a what you call uterine anomaly. Placenta. So these are the various risk factors. So let us start with each one risk factor. If you are faced, how we are going to sort it out. So I go over to Dr. Chitra. Ma'am, you can.
Yes. Next slide. So we all know life is full of difficulties. and we have to meet them, we have to greet them and defeat them. Only then you are successful. So difficult situations in cesareans are, as we enumerated, it can be a difficult access to the abdominal cavity itself, difficulty with the uterine incision and closing the uterine incision, difficulty in delivering the babies, difficulty in getting the placenta out, or difficulty in controlling the bleeding after delivery, and difficulty in closure of the abdomen. So I'm sure all of us have encountered all these things. What do you do when you have a difficult abdominal access? When you're not able to reach on, or it's a thick abdominal wall, you have to make a good incision. What incision would you like to make, and how will you plan your cesarean section? There's a previous scar. What will you do? You have Priya, Dr. Priya. Dr. Priya is not there.
I'm here.
Okay.
I'm here.
Okay. Okay, thank you.
Sorry, but I couldn't get your question. Your voice is breaking.
Oh my God. See, I said thick abdominal wall, previous cesarean, you have a bad abdominal wall as such. So you have to reach on, you have to make a good incision. What incision will you choose, and why do you choose that? When you want to do a section.
Okay, so difficult entry into the abdominal wall is something where we need to take care. Yes, something that we need to take care. If there is already a fan and steel incision, I'd like to excise the scar and get into the same incision and excise the scar well enough so that the fibrosis and puckering does not prevent or restrict our space availability. Next, as we go lower down into the abdomen, we find additions of the anterior abdominal wall. So very carefully, layer by layer dissection, and most importantly, to identify a free area on the peritoneum. Follow all our basic principles of surgery, pick up the peritoneum carefully, and make sure the bladder entry is not there. And if at all there is, identify those. It is possible that you end up injuring the bladder sometimes when you open such difficult abdomens. Another abdomen that will give you difficulty is a very obese patient with a paniculus.
Yeah,
that is another situation where identify.
Yeah, we do. Priya, we do have one case on morbid obese patient.
Something.
Can you hear me?
Yes.
Priya?
Yes.
Yeah, if this case is given, if this case comes to you, if this case comes to you, how you are going to plan the incision for this patient?
Which case? Morbid
No, see the picture right there. The abdominal wall has one
midline vertical scar with a.
Yeah, I can see it here. Let me see. Oh, yes. All right. Since she already has a midline vertical scar, I think I'll go with that only, because
you'll go straight into the scar, or
too many scars on the abdomen is not.
What do the other panelists feel? Everyone can tell what they feel about an incision to be made.
You're breaking up. I'm not able to hear you.
Oh. The others also can give their opinion on the scar that they would make on the skin.
Shanta ma'am, you can give your opinion if this.
If this patient has got any previous records of her, then I can go through that. Otherwise, if it looks very adherent, I can take a fan and steel incision. I can, or else I can take muscle cutting incision and then go inside the uterus. Then there is no need to go for a midline incision, I feel.
But actually in this case, it is quite puckered scar is there, and she is obese, and going fancy incision, this won't be advisable, ma'am, until unless you have to get a knock of lower uterine segment, because she already has. So what we did was we had to put an elliptical incision was put. So along with the scar, we removed other tissues also. Then then we for any defect was that we took the crisscross incision. So and we entered into the cavity. But we could have prevented all those things by the thing if we had kept some momentum between the, because most of the cases which we are referred to as, when we open, we feel that uterus is densely under into the anterior abdominal. It was very difficult. So one way what you can do, anyway, can you tell how can we prevent these adhesions of uterus to the anterior abdominal wall?
One thing is
Yeah,
carefully
please
we
go
have
on.
to follow the surgical principles when we open the patient, and also if there is adhesions, to prevent adhesions, the surgical technique is very important, as well as the patient habitus also matters in these patients.
Shruti,
So
yeah, thank you, ma'am. Shruti, can you tell me out of this various incision, which is the incision? Do you plan your incisions according to the case, or how is it? What are the various type of incisions? We know each has its advantage, disadvantage. So do you do Fanistel for all the patients, or do you plan different incisions, or how you do?
Mostly it will be Fanistel or Joel Cohen incision, but like you said, it also depends on the patient. The previous patient which you showed, the puckered scar and the obese patient. In that we need to plan a little, because we'll expect adhesions with those kind of patients, and we need to be careful when we are opening, and there will be bowel or bladder so coming in the way. So we have to carefully choose the,
I think
excise the scar and then go about.
Yes, because it is not a Fanistel incision for all. It's not the midline for all. It depends on the condition. Even by chance you put Fanistel, introp you are not able to adjust, you can go for Maillard incisions. Okay.
Yeah, Maillard incision.
Yes, you can cut the muscle then and there. This is what we'll require for an obese individual when there is a panniculus there, hanging there down. So at that time, what will we do? When you have a very obese woman with this, abdomen hanging down there. Now, how will you manage and how will you do the section then? Hello.
Please, one more, Dr. Tilley. Dr. Tilley, are you there?
That's what. Are you there?
Who is this question? Yes, I'm here.
Directed to.
Can you on the video, because we want the panelists to be on screen, or it's really difficult for us to know who is there, who is not. Yeah.
Actually, I need more helping hands to hold the belly. So right side, left
Actually,
side.
Okay, what you do? Okay, you will take extra hands. You'll ask the assistant to hold the belly.
I asked my pages to hold here and the both sides, because of
abdomen.
this kind of
pull the abdomen up.
I think.
Yeah, upper abdomen, you have to pull. We can see by the lower uterine segment how we can see the we can palpate the fetal position parts. Then we can, if it is okay, this abdomen can pulled upside. Okay, we can put financial incision. We can deliver by layer. We can identify each layer, and we can deliver by even until the closure of all the layers. We need
those two hands,
some
extra hands.
Because we used to have a severe hand pain, neck pain because of this obesity. So with help of more assisting people, two persons at least, we need to hold the belly of the abdomen. We can easily deliver by baby. I think so.
Priya, Dr. Priya, Shruti, you have any difference of opinion? You take assistance or?
Yeah, ma'am. Just like madam told, I actually did encounter a case like this, where we took a Fanistel after we just cleared the abdomen, like by pulling, and then we could take the incision at the proper site after palpating the fetal head. So, and that went on fine. I mean, there was no problem with the scar later on also. So I think that would be only good for such cases.
Chitra ma'am?
There are, I think there are two ways in which this can be approached. Even when you pull a traction and pull the panniculus up, the groin fold has to be avoided because it is a site of infection.
Yes.
And probably an incision slightly higher to the groin fold would be ideal. The second way is probably to do a surface marking when you do an ultrasound and identify the lower, the level of the lower uterine segment on the ultrasound, and sometimes incision as high as just a sub-umbilical incision sometimes will have to be done. And it is mentioned in, I haven't done one, but it is mentioned in most of the textbooks and a few case reports where sometimes even a supraumbilical incision is given. You know, when the panniculus is so large that it's almost hanging down halfway to the thigh, then you can't really lift it off and put it. So a very high abdominal incision is also advocated in very obese patients.
Yes, agreed. Agreed.
Now, the things are like what Dr. Priya also told, no? The things are changing. It's not like you hold it to 3-4%. Yes, when there's a panniculitis, what happens? The whole of the abdomen, the umbilicus is below the level of lower uterine segment. Okay, so this is one picture which one study was done, which shows that, can you see that the transverse incision is given supraumbilically? And they've gone for they had an easy access to the lower uterine segment, and the C section was done.
Okay. That's what. This is how it was when they went into it. Into the abdomen.
So
obese ones.
Yes, that the studies also was done, no, ma'am, that they showed the transverse incision is always about the panniculus. It goes to easy access, and it's better when patient is when uterine segment is not formed in preterm LSCS. So always this is to be. I think we should start using it. Even what Dr. Tillai told, the same thing we are also doing. We'll pull it, we'll hold it with the straps. We'll give it we'll put the Alice forceps, hold as the assistant. But I think this studies, which are, I think there are series of studies, they have shown that yes, you can give a supraumbilical incision where it meets that of the low uterine segment, and you can access. So next time we need to try and take a higher consent from the patient to do this. Okay.
Okay.
Yeah, ma'am.
Okay. Now what did you do? Difficulties that you encountered during uterine incisions. So what will you do when you can't really reach the lower uterine segment? That's what it means. That's what we were talking earlier also about the dense intraperitoneal adhesions. So we have seen, and we are seeing every time, these intraperitoneal adhesions, because sometimes, you know, the previous cesarean patients have, I don't know, I feel so, they have no closure of the perirectal peritoneum at all. So it just gets stuck to the anterior abdominal wall, and all of us have no window to really reach. So we struggle to reach the window. So what we do when we encounter such a patient? Madam, please. Anyone of you?
Shanta madam is answering.
Shanta.
Yes.
Okay, Shanta madam.
Okay, we need to be careful because a lot of bowel adhesions will be there in these patients. So slowly the adhesions have to be released. And if we find intraoperative that we have either opened the bladder or the bowel, anytime we can take surgical assistance, carry on with our procedure, extract the baby, and then deal with the situations as they arise.
Okay. And Dr. Priya, what you tell the PGs when you're doing cesarean section previous LSCS, yes, you don't have to injure. What is the most important tip you're going to give to them? Unmute, please.
Yes.
So the first thing I'd like to tell them is careful dissection of the lower uterine segment, the UV fold, and push down the bladder.
No, before you go into the UV fold, you are still in the
able to give a
anterior-abdominal wall.
You just open the rectus, see there's a dense peritoneal adhesion, you can't even approach.
Anterior-abdominal wall.
Yeah.
What will you look for?
First of all, you look for where the round ligament is, set your anatomy right, and then, you know, trace, because the upper abdomen is relatively free. And from there onwards, it's easier to identify.
Make a window there.
Correct.
Yes, make a window. And
now open the peritoneum as high as possible.
Downwards and push the bladder well.
That's what. Open it right. We should always try to open the abdomen as high as possible.
I had mentioned it earlier, so I didn't get into that.
Okay.
So
that's what.
Yep.
So all these things
as high as possible, and then start identifying a window, and then sharp, careful dissection.
That's very
Make
important.
sure that the catheter is in place and draining well. Most important. And yeah, sometimes I think when you have especially accreta and an adherent peritoneum, that's the most difficult situation, or a fibroid there. Very rarely.
Yeah, I think we'll come to it. We'll come to it. We'll come to fibroid.
Yeah.
So
okay.
we'll just okay.
Okay.
Shruti, can you
And,
take up a second? If it is a bladder is adherent, how do you go about it? How do you prevent bladder injury?
Yeah, ma'am. Bladder, most of the times we are doing sections for previous cesareans. And so most of the times the bladder will be adherent in the lower uterine segment, but carefully with the sharp dissection, with the tip of the scissor pointed towards the uterus always, we need to take out the UV fold, loosen up the UV fold, and then with the sharp dissection, we need to push the bladder down. And if at all it is totally adherent, then I would like to take the incision a little higher up, 2 to 3 centimeter higher than the bladder extent.
If the bladder is adherent to the fundus of the uterus,
Ma'am, we can just, with the sharp dissection towards the uterus only, we can, go on dissecting and push the bladder down as much
do
as
you use
possible.
methylene blue? Do you use methylene blue dye when you
We
have
use,
such
ma'am. We use
cases?
methylene blue. Yes, we do use methylene blue.
I
And
think,
in case,
yes, whenever it is densely adherent, when you're doing sharp dissections, it's better you instill with the methylene blue so you know where to go. That is,
yes.
that is one of the precautionary method to prevent bladder injury.
Right.
That's what
Right.
we knowing the extent of the bladder so that we can limit our dissection. Yes. Previous classical cesarean scar, again, it will all be adherent there, that place.
Yeah. What if a patient comes with a previous classical season section? What do you plan this time? What will do?
Oh.
Ma'am, Shanta ma'am, you might be experienced so much. If at all you have, what you'll do?
Yeah.
You go again with the classical season section, or you take.
There is no need that we have to go through the classical cesarean section. If the bladder is definitely, we can easily separate the bladder. We can go through the lower uterine segment and deliver the baby.
Agree. Yes, if it is a classical, this thing.
Okay. When you see uterine anomalies, bicornuate uterus.
Uterine anomalies, we have to be
unicornuate uterus.
Unicornuate, bicornuate, rudimentary horn. So what are the precautions you take when you do the LSCS? Like suddenly you have two uterus, two babies, or one unicornuate uterus with a rudimentary horn. You have difficulties in extraction sometimes. So what you'll do?
First, the repositioning of the uterus has to be done. We have to see whether where the lower uterine segment is, and carefully separate the bladder and then take an incision. Sometimes we have to take J-shaped incision to extract the baby. And if it is a transverse lie, definitely sometimes we have problems when we extract the baby.
Any other opinion? Any other people have come across this facing difficulty in uterine anomaly surgeries?
Uterine anomalies, baby delivery of unicornuate, bicornuate will not be that much difficult, but the placenta deliveries is very difficult.
Yeah, that is very important point. I wanted you people, because when you deliver this side, sometimes placenta will be in the other thing. So
other unicornuate carnua, very difficult to remove the placenta. It may stuck inside the, that one carnua. We have to pick it up by small bits or something, or sometimes retained placenta may be in situ.
Yeah. So it's always good.
You can't wait for spontaneous separation
and wash, or just do the mop curettage
the cavity like that. Yes, true. When there's a fibroid in the lower uterine segment, again, we have difficulties to make an incision. So Priya was telling about that even earlier. She was telling if it's a large fibroid, you have to even make an incision above that. Sometimes you have to go high up. Or if it is on the way, it's very difficult. If you can go below it, yes, fine. If you have to go above it, you have to decide that. Probably we can plan myomectomy and other things after we deliver the baby, but not.
Anyone has did the cesarean myomectomy? Some patients can be done. Which patients have you did? Like, I feel
subserous myomas too we will do, ma'am. Subserous myomas, but like ma'am said, if there are intramurals, it's always better to extract the baby and then go ahead.
Go ahead and do.
Anytime, have you put a classical incision for all lower uterine segment fibroid? No, have you done? No. So what you do?
No.
You do the myoma excision, and you put the this thing, or you try to push myoma one side and do the lower segment incision.
Yes. Try to push the myoma one side and then deliver the baby. Then try to do the myoma.
Yeah. So whatever, it all depends on our intro, the experience and the way the fibroid appears.
You have to make the decision on the table.
Yeah.
There the placenta is. Only your hands will feel the fibroid and tell you the extent. Whatever the ultrasound says, whatever mapping you have, Nothing gives you an answer. It's only there on the table and your vision on that day.
True.
Okay, carcinoma cervix, we know that our incision should be higher and not into the lower segment because we are very close to the cervix. So we'll move on to the next.
This is what already we discussed, how to open the peritoneum, open as high as possible. And this is a bladder injury. You should be extra careful because 95% of the bladder injury occurs when you're opening the peritoneum, and that are the doom. And these are the various causes and how you reflect the bladder flaps. And when you find a bladder injury, I think we as an obstetrician, we should start learning how to suture the bladder. Okay, so instead of calling the urologist, small rent with let's say 3 centimeter, yes. But if it's near the dome, always you should call the urologist because you need to put the uterine stents. And madam already
for
told
people like you who are in institutions, you know, for people like you who are in institutions, you have the luxury of always calling in immediately somebody to help you. But then practitioners like us, you know, we are deemed to learn it. We have to do it, because we have no other choice. We can't wait till the other person comes in. So we are learning it and doing it. Yes, uterine anomalies. Yes, here it is.
Chitra, Dr. Vasanti want to give some opinion. Dr. Vasanti, who is she is a panelist?
No.
No, ma'am.
No.
Then you proceed. Go along.
No.
Okay.
When you see this, that's what Dr. Chitra was telling about this as well. About the, you can see that fibroid there. And then you can make an incision below that, deliver the baby, then get onto the fibroid. And if you see the baby in one horn and the placenta in the other horn, that's one way. Otherwise, you know, you have 2 babies in 2 horns. Yes, it's going to be difficult, but we have to be worried about the extent of the incision when we do it on a bicoordinate uterus. The lateral angles, you have to be very, very careful. Okay, move on to the next.
Yes. Now, I think if you meet up with a torsion of the uterus when you're doing, how will you proceed? Yes, Dr. Priya, when you have come across it, when you have a torsion, it depends on 90-degree torsion, 180-degree, 360-degree, sometimes very difficult.
Yes.
Yeah. A picture like this, yes, it's easy to make out. So what you do?
The most recent time that I had encountered this was during COVID, in a COVID positive patient with endometriosis and fibroid uterus who had undergone a previous myomectomy. And because of the additions, I think there was a torsion. Yes. And and also the baby was in a transverse lie. So all this put together,
everything you got a bonanza of
an idea that this could be what I'm going to get into. And yes, yes, it was like a jackpot. So it was a tough one, but luckily I could detort the uterus and I managed to do an anterior, but not always we are so lucky. So when we call a rotation, it should be more than 45 degrees. And more often than not, inadvertently or by design, we end up doing a posterior hysterotomy and delivering the baby. Sometimes without realizing, and sometimes because we cannot rotate the uterus, no matter how much we try to get the anterior. So again, what I would say is when we find, as we open, the head necks are right in front of us, or the large vessels in front of us, we need to realize that there could be a torsion, either a 90-degree, 180-degree torsion. 360-degree torsions have been reported, but I haven't encountered something like that. But yeah, I think like Dr. Chitra pointed out initially, also looking for the round ligaments every time we open the uterus is a good way to sort the anatomy before we start proceeding to this. Another time where we get a clue is the UV fold, which otherwise stares at us, is not available there. It happens when there is torsion. It also happens in situations like a rudimentary horn, non-communicating, etc. So when we don't find the UV fold where we're supposed to find it, that's what tells us that there's something wrong. Yeah.
So and as you tell, no, if you're able to displacement, you can do it. If not, means as you tell, we have to go for a posterior hysterotomy. Then you can close it and you have to document properly. So the next is all directly for the LSCs.
Next person.
Now it is coming to the delivering the difficult babies. This is the most important.
Won't give you signs of scar.
So each one can tell me, how do you deliver the floating head?
Sorry for the interruption, madam. Time, we are running short of time. Can you please make it quicker?
Floating head. Please, each one can give opinion.
When we have a patient with floating head, you release the amniotic fluid slowly so that the baby settles down, and we can as well deliver with vacuum. I am used to delivering the babies with vacuum. Even a few of them, they use forceps, but I am used to vacuum extraction, or else once the baby settles down, we can flex the baby and deliver.
Yeah. Priya? Yes. Shanti, who is there? Shruti?
Or else if it is a highly floating head, ma'am, you can just pull the limbs and then you can take it out. You
Yes,
can
you
do an
can let
internal
us
version
breach.
and take the baby out. Or
Like
else went to
there
the
should be
forceps
enough.
is fine.
There should be enough LICA for us to do that.
Yeah.
So if the
Yes.
LICA
Most
is all
important
drained
is
out,
Yeah,
we need to
like
start
before the
uterine-
liquor is drained out, we
hello?
can do that.
Yeah, we need to start a uterine contraction, initiate the uterine contractions so that you get a grip of the baby, then give an incision. Don't allow all the liquor to drain away. So when the liquor is away, try to apply and ask them to give fundal pressure and push it. One. Second one is you can apply the forceps. So I first posterior followed by anterior. Any other forceps designed for delivering the floating head?
Single arm thing.
Single blade.
Vectis
That is Vectis can be used. There's one called Barton's forceps. I think it is. I think only institutions might be having it. This is having a hinge, so it will helps to apply onto the fetal head, elevate it, and it easy for the extraction. And very important, it's very easy to use your vacuum delivery during the labor everywhere, but during the cesarean section, it's very difficult to create a vacuum and the forming a chigna. So the new thing has come that kiwi. I think many people might be using that kiwi where you have to apply. So your point of application is also very important because you want the shortest diameter to come out. If you are going to apply in a wrong position, it might be again difficult. It can go to the excision. So these are the things you have to remember.
Similar to a vaginal delivery. Okay.
Yes. So again, point on Shanta ma'am, please can you tell me how you deliver a deeply engaged head?
Deeply engaged head, we have to, first of all, we have to take an incision a bit on the upper side in the lower uterine segment. Because if we take very low down, it will go inside the cervix as well as in the vagina. So probably first is the incision, what we have to take. Gently, we have to find out where is the head, means the shoulder. And then gently push the head between the head and the lower uterine segment if that is possible. If that is not possible, when we see the shoulders, we can do a Patwardhan technique. If it is a very deeply engaged head, and we can do Patwardhan technique. I have done in couple of patients, both the proper Patwardhan technique as well as modified Patwardhan technique. And few of the patients, we ask our assistant to flex the head and push it up so that easily we can deliver the head. But whatever is said and done, deeply engaged head sometimes can cause problems when we are extracting the baby. Here, expertise as well as senior person staying there is very important.
Yeah, I think most of them are using the Patwardhan. So Patwardhan is mostly used when it is an occipito anterior. It's easy. You take the shoulders first, then the trunk, then the buttocks. What do you do if it is an posterior, if it's occipito posterior?
It is a modified Patwardhan technique. When we incise the lower uterine segment above, we see the one shoulder in these patients. Gently extract that shoulder, and then the assistant has to rotate the baby to other side so that we extract the other hand, and then and you pull the two legs apart, or
it is like
one arm,
reverse breech
and then
extraction.
one leg, other leg, and then other arm. And gently extract the baby.
Last comes the head.
Yeah, so it is like a reverse breech extraction. But when it is in deep transverse arrest, you have and where you have to remove first the shoulders, then give a traction on, pull the shoulders, then you get a leg, then the other leg, then the other
and
shoulder,
then other
the
shoulder.
head. Okay. So first, what they told in literature, like you found ERR, like elevate, rotate, and reduce the thing. If this is not applicable, then you go for the one position. This position is a Whitmore position, which shows that the thighs are abducted and flexed to approximately 135 degrees. So when this is happened, there is a pressure on the acetabulum and it opens up the pelvic inlet. So which will allow us to push the baby from below and helps in breaking the vacuum and also help in the delivery. So this is one Patpadan video I'm not able to put, and this is the shoulder what we have discussed, and this is of other reverse modified technique and breech extraction, which we all discussed. Now, when there is a difference between push and pull technique, it's very difficult. We should not advocate pushing from below because it causes more injury to the fetus,
lacerations,
to the genital tract. So it's better always try to pull from above. And these are the blades, Vectis blade and Murray's head extractor, which have been used to this. And one I saw in literature was, this is a new device which has not come to India. I don't think so. Someone can tell. It is known as folding plate, which can be kept to the scalp of the baby from vaginally and push the pressure 60 ml normal saline, which will help to break the vacuum, lift the baby, or you can use a snorkel and put the gas, and that will create the break the vacuum and help in delivery. These are the things. So anyone has seen a bandle string? If you expect a bandle string, where do you give an incision? I think because Radhika, I'm going next. I'm going to call Dr. Radhika. Okay, yeah. Shruti, Shanta ma'am, I think Priya is not there.
No.
Priya ma'am, yeah, please.
Bandle string, I don't have any experience.
Yeah, Shruti, have you come across? Because this usually nowadays we are taking early decisions for LSCS, we are not facing it. But in some settings where you are being a tertiary care, your patient have been referred. So when you have there, you are always supposed to give midline vertical incision so that the ring you are supposed to break it and cause a easy delivery. Or else if you are going to give in the lower segment, it's very difficult to deliver the baby. And already Chitra ma'am has told that corporexis occurs, how you are going to manage. If there's an extension, when you do all this procedure, what happens? There's an extension. What you do?
To prevent, like to identify, it's always better in a very much deeply engaged head or a second stage section. Always better you just keep a stay suture.
Yeah, this is a very
before
important.
we take a incision,
Try
so that
to
we
keep a stay
identify. Even
suture.
if there is a colporexis, the lower segment we can very well identify and hold it and then start suturing it.
So if it's not able, then you are supposed to do the interalec ligation, or you can open the thing.
Yes.
Now coming to the most important, the transverse line. How you are going to deliver? If you are going a section transverse line, what you are going to do? I think Shanta ma'am, where is Dr.
Transverse line, once we dissect the bladder, just carefully, if the patient is elective patient, then usually we do a scan and then we plan how the baby is and what we are going to do. On the table, we have to feel whether the back is anterior or the back is posterior.
Which is easy to deliver? Which is easy to deliver? Which is tough to deliver?
Back posterior will be tough to deliver, I think.
Back posterior. Back inferior is tough to deliver. Back superior is easy to deliver because you have the legs hanging down. So easy to extraction. Yes, correct, ma'am. Yes.
Pull the legs.
So whatever, it always important. See, this is a dorsal inferior. It's very difficult. Legs will be high above. You have to rotate the baby. So these are the things you would follow. If it's a preterm labor, yes, you go for upper segment incision because lower segment is not formed. It's a full term. Yes, you can go lower segment, but you have to do the breech extraction. Obstetrical labor, always give a vertical incision and it can extend to upwards. If a baby is dead, yes, you can go for a lower segment incision. Yeah, breech delivery. Ma'am Chitra ma'am, breech delivery.
Yes, that's what. So you have to decide on, find out whether the footling presentation or it is the extended breech. Extended breech is the most easiest to deliver. So you deliver very easily, but you have to be careful about the aftercoming head. And again, when you come to flexed breech, when you just feel the footling, you catch hold of one foot and then you extract the baby fully out. That's how we do for all those things.
I think, there is not much difference in what we are doing in vaginal delivery.
Vaginal delivery as well as
that's what.
Only I think so.
We have to keep the back always up, and then the after coming in, you have to be careful. These two things, if we learn, we can deliver breech vaginally or by section. That's not a deal.
Multiple pregnancy, I'll skip it because not many people have done. Well, I don't think so even conjoint is many people have encountered now because termination. So coming to the most important.
Cutting through the placenta during the cesarean section, placenta previa anterior. Placenta previa anterior. No one's here. And Radhika is at just catching us by the nose.
I'm here, yeah. Sorry,
Good.
I had some bad internet connection. I got logged off, so I just
Okay,
came back.
placenta previa, that to anterior low-lying placenta, you have a section to do.
Yes, if we find it's again a lower segment incision only. If we find the space between the margin of the placenta and the uterus, that would be great. If we don't, we need to cut through the incision. It will be a bloody field. But what happens with this placenta is the head is always a little high floating because it doesn't come down. And that may pose a problem for delivery. And I usually use a forceps for that.
So always to keep the forceps by side when you're doing placenta previa section.
Yes. And probably a quick uterine artery ligation when we've cut through the placenta.
Do you take prophylactically or you will do uterine ligation after the delivery of the baby? What do you prefer?
After the delivery of the baby, of course.
Yeah. Some people try to do prophylactically before giving incision. That also I have seen it.
No. After the delivery of the baby, after we've cut the placenta and delivered the baby, then I would do it before the placental extraction sometimes.
Yes. That is also a good option.
Yeah. And sometimes there is a mention of a lower segment vertical incision and a placenta previa if the placenta previa is on to one side, but I have never tried this.
Yeah, even we have never. Better to go with a well-versed incision than trying something new and land up in a more problem, especially in these scenarios. So this, if at all placenta face to separate, is better you leave behind the placenta, these things cut near the cord and you come out and later you can give methotrexate, whatever. Now, more important, placenta previa, in case of previous LSAs, if placenta previa is there, we are more afraid, the more the number of LSAs, the more the incidence.
More the chances.
And more the incidence of placenta previa, more the chances of the
adherence.
So how do you go about it? How will you see? What are the precautions you take whenever you have a placenta previous LSAs with placenta previa?
Table and ready.
Shruti?
Yeah, beforehand, we need to know the adherence from MRI before we take up for cesarean to see the
extent
whether
of
it is a percreta, increta, and then we have to decide. And if at all there is a facility of urinary embolization or after that if we need, or else the safe option is always plan for a peripartum hysterectomy and go ahead.
Any other thing you will do? Will you have any role of MRI before doing it, or you have to speak to intervention radiologist, the role of uterine embolization? If for the patient you want to have a fertility preserving, you cannot do cesarean step for all patients.
She did mention about them.
Okay.
She said about MRI, she told about uterine embolization.
Yeah, ma'am.
We should be prepared for all that. Yes.
So I think so for the focal adherence, everything, I think we can leave behind. Focal adherence, take a figure of it and you can leave behind. Only if you have dense adhesions like this percreta or increta, then I think so there's a, you have to, if it's a patient is a nulliparous primary or something, you have to go for uterine embolization. If not, means you have to go for a cesarean sectomy. But most of the time what we have did is we go for like what Dr. Priya told beginning, we go for a classical leave in situ and do the hysterectomy after telling if it is risking the mother. Okay. Now, when you have there's a most common, there's a lot of blood loss in a cesarean section, especially previous LSAs, because of all these factors. What are the strategies you take to prevent blood loss during cesarean section? Shanta ma'am?
Initially, what we can give this pause injection for these patients. For all the cesareans which we are doing electively or emergency, we give 1 gram of tranexamic acid for them. If patient is not in labor, we can start syntocinon for them on the table. And then we should extract the baby and not be very fast in delivering the placenta. Just take time for the placenta to separate and then do a controlled cord traction. And if the patient is with this, if the patient is okay, it is okay.
Hello. Sorry to interrupt.
I have only 2 slides, only 2 more.
Yes.
We want 2 minutes.
Can you please wind up?
Yes.
Yes. We can just go ahead with the slides and finish off, please.
Yes. So just studies what already madam I'm told. If you all have a placenta blood bleeding, give a pressure, take figure of 8 sutures, or if you have a local placenta adherence here, you can leave behind and take a suture. You can go stepwise devascularization. I think everyone knows it. Stepwise devasculation, already talk in depth previous by the previous speakers. And etonicity, go for B-Lynch, Chow stage, Heyman stage. And at the end, before doing hysterectomy, you can try always internal ligation.
Sorry, madam. Thank you so much.
Ma'am, conclusions. This is very important. Yes. So, in conclusion, we'll tell that access to abdominal cavity has to be planned ahead in consulting the patient. And inaccessible lower segment is not an end of the world. You always try upper segment is not dedicated only for peripartum. Floating head, yes, already we told allow the liquor to drain, deeply engaged, put in position, obvious woman. Yeah. Thank you so much, ma'am. Thank you, the panelists, for giving us an opportunity. And
thank you.
Thank you very much,
the
ma'am.
panelists.
Dr. Shanta.
Thank you. Thank you so much.
And all the organizers for the opportunity. Thank you.
Thank you, the organizers.
Yeah, please, one important, please train your residents to face all these problems. That's the only thing, last thing, take home message.
You're right.
Thank you.
Thank you.
Thank you, Chitra.
Both Chitra madam, thank you. I think Dr. Pondicherry Chitra had lot of problems. In spite of that, she has logged in.
You are telling if I don't know, gone case. That's the reason. Thank you so much, ma'am.
Thank you, ma'am. Sorry for that.
Thank you very much. It was a good opportunity.
Thank you. We'll move on to the next session. Sorry for the interruption. Cesarean section on maternal request. There is a debate on that. And I introduce Dr. Sampath madam will be our judge. She needs no introduction.
Radhika, you proceed with that Deepa and Reshmi.
Okay, ma'am. We have Dr. Deepa Tangamani, who is going to argue for cesarean section on maternal request. She is a consultant in Apollo First Med Hospitals in Chennai, consultant Tamarai Fertility Solutions, and she in Chennai, and current post she holds joint secretary of ATN RCOG and Chennai Menopause Society advisory. She's also in the advisory committee of OGCON 2023.
Thanks, Rathika. If the time constraint, we'll move on to the next.
Okay, thank you so much. And the next person is Dr. Rashmi Aji. She is a senior assistant professor, Kanyakumari Government Medical College and Hospital, secretary, Nagarkoil Obstetrics and Gynecology Society. So we can start the debate, ma'am.
Deepa, you have 10 minutes and Reshmi will be having 10 minutes. And after Reshmi, you will be having again 2 minutes.
Oh, okay. Okay, madam. Thank you for the opportunity. Thanks, Sampath madam. And my topic is CDMR is the way forward. Okay, so I'm arguing for the FAR. So CDMR is always not equivalent to elective LSES. It is a tip of iceberg. If you say, if they are telling that maternal request is the most common indication, no, it's not like that. So if there is a very few component of the mother coming out of the pool of antenatal, coming and asking you that for the cesarean section, but most of the elective is by the physician sister, and the true number is difficult. 2 to 8%, which is too low. You see this CDMR from about the rate of primary cesarean is very less. So where it all started? It's all started in 1985 in the New England Journal. They introduced the term prophylactic cesarean section. They say it is safe, it is reduces the stillbirths, and 5 to 10 babies are safe for each one excess maternal mortality. And they say the specific things. If cesarean section rate is more than 27%, currently we are more than 40%. Elective cesareans are also more safer than the vaginal birth. Evidence should be discussed with all the patients. And this is the historical evaluations, like 1990 to 2004. What happened? Initially, there is a rise, and FIGO opposes there is an ethical dilemma. And 2004 NEGM are ethically permissible to accept the request. And 2004 ACOG till now the ACOG has you analyze the risk and informed consent, and patient autonomy has to be respected. And 2006 the consensus, the CDMR is slightly in the last 20 years it's slowly increasing, but there is no randomized controlled trial to show it is increasing. And the risk always they find to come to the conclusions, if not 39 weeks, if they are completed 39 weeks, then it is individualized, assess the risk benefit analysis, and you can recommend it. Absolutely not recommended with obesity if they go for a large intended family size. So it is a reasonable alternative. So I will prefer to use the word maternal choice cesarean section rather than the demand cesarean section. So I'm not using this word, it is a choice. The woman is bringing with a choice. So why the woman is asking me, why don't doctor trust us? The answer turns out to be quite simple. You do, I'm asking for a choice, you do it. They don't really know about us. You all read about this Gabriella Jackson's Pain and Prejudice books. It's about endometriosis, chronic pelvic pain, and how the woman is going through the pain after delivery. Okay, so having said labor is no misnomer. Labor is the word is exactly, it is a laborious process. You see in the second stage when the head is compressing, squeezing the bladder and rectum and all the pudendal nerve neuromuscular damage to the pelvic floor. Sometimes it will be permanent. So I love to people tell, I love to pregnant, I love to lactate, but I want an apple follow from the trees. Okay, so that's how. Oh, that's how they wanted it, but it is not that easy. So how normal is normal birth? The Canadian Journal Joint Policy Statement said normal childbirth is natural and normal. That is two way of natural is like no intervention. But most of the times we don't have a natural, we have a normal. Normal, what is normal? They said induction, augmentation, monitoring, everything included it. So when you considered everything, is it a natural or normal? May also not considered as a natural or normal. So what are the components? It's a one-in-one support, no routine intervention, base pain management, use of fetal surveillance only by intermittent auscultation, spontaneous pushing in the woman's preferred position, continuous labor companion, and freedom of movement during labor, and wait for the spontaneous onset of labor. Don't induce, don't augment. Okay, are you guaranteed that the delivery will be normal? No, most of the times they ended up in forceps, vacuum, which many people are very poor, and ended up in cesarean 15% of times. So this is the scenario you will be seeing in the normal. Woman will be in stirrups, position, draped, and in this position in the second stage, 2 hours of pushing, 3 hours of pushing. Finally, they will be ended up in having a delivery, but we are removing all the physiological anatomy. Okay, see the cesarean section, though IV line will be there in the normal delivery. In cesarean deliveries, the patient is fully makeup and full happy with the baby, and the baby is also coming out very happily. So having said, we are worried about the ideal cesarean section rate. Is there any ideal cesarean section? I would say no. Why? Because the police would say, cesarean police say, despite the influence of increasing maternal age at first pregnancy, increasing prevalence of obesity, be reluctant to deliver by the vacuum or forceps, very few do, and decreasing self-confidence with the operative vaginal deliveries, cesarean section being that by default is the most elective, most commonly performed elective. One of my female colleagues have a cesarean sections recently. When I asked her about it, she said it's because I don't want to damage my perineum, bladder, and I'm worried about my sex life, and after that baby, I'm worried about the baby. She is finished an OG, and around 29-30 years, she is planning her pregnancy, delivering. So episiotomy is also not much fine. It's a scar will be rigid. If it is a tear, if it is a rigid scar and tight scar, first time sex will be horrible. See the glories of fun and still, though after having the previous sessions, but yet to have the fun and stills is without any problems, it will go because you have been using it for the last 40 years. So they can do exercises 6 weeks, they do whatever, and they can handle the baby within. So what does the evidence says? What is the benefits of risk of normal delivery rather than benefits of doing a cesarean? First and foremost is a stillbirth risk. So we all know the babies run out of the gas after 38 weeks. So, and if it is in a black or Asian peoples, it's all the more common that after reaching a 38 weeks, you will be run out of the gas. Baby will be suffering. So that is the reason we are arrayed trial. We are inducing at 39 weeks. If you are planning to induce, why not CDMR? The same falls the price of the neonatal death. And the silent epidemic is a pelvic stress urinary incontinence. Though the evidence says it is first years, but no, they will irreversibly serve for having a silently suffering these people for a longer years. See the elective cesarean sections, it reduces it, but for the vaginal delivery, it's almost high. So it is a quality issue. So by doing a CDMR, we get 1 in 9 women will benefit. Though the benefit lost at menopause, they will be, if they delivered at 20 years, they will be at 30 years of benefit. If delivered at 30 years, at least they will be having a quality of life for the next 20 years. So the second is a fecal and flatal incontinence. The anal sphincter is actually, we cannot be reproduced by engineered the anal sphincter because it is only one distinguished as a gas and fluid. What happened after the vaginal delivery? 60 to 70% of times there will be a flatulence. When they fought, there will be a leak of watery stools will be leak. And coming to the prolapse. Prolapse Luckily, these kind of generation of people, when I am in a PG in 20 years back or UG, I'm seeing so many cases now because of the rising cesarean section. We are not seeing much of prolapse, complicated prolapse or prolapse. Our PG, the first PG's case will be the prolapse, but it is not the scenario anymore. Cesarean silently decreases the risk of having a pelvic organ prolapse, though the number needed to treat is high, but our grandmothers are suffered, but no more the future generation is going to have this kind of prolapse. And finally, the sex matters. Cesarean sections, they will have a pain will be less. 1 in 8 will be having a normal. So with this background, I say my cesarean as a natural, magical one. And what are the risks? They say the length of the hospital stay is very high, especially true for emergency, high labored cesarean sections. But for elective, one of my seniors 15 years back have done elective cesarean sections. On the same day, she went home. So it's no more, if it a planned cesarean, there is no more, it's like a daycare. Even the vaginal delivery, induced delivery, operative vaginal delivery stay longer. So, and they argue for the placental accreta. If you limit their pregnancy, then that is not an issue. If you discounted the urinary data, accept the data related to the risk count of morbid adherence. And what is the obstetrician choice of delivery? These are the studies in 1996 by 282 obstetric consultation. 17% of obstetricians would choose an elective cesarean section for themselves. 31% female obstetrician and 8% male obstetrician for the wife because of all the things. And 68% preferred a cesarean section for a cephalic if the baby weight is more, and 39% baby weight between 4 to 4.5 kg. This is a survey taken in the conference in 2000. Out of 117%, 46.2% prefer. When the doctors themselves are preferring, the president at that time, women's right to participate in the decision and to choose a delivery her child will be respected. And this is a systemic review of 34 articles. Again, they all say the same things. Even the OGCON themselves have a personal choice of 24.2% of having a elective cesarean sections, demand cesarean section. What does that New Zealand finally this guideline says? After full discussions, request for the cesarean, the obstetrician may agree to perform a cesarean sections, providing the patient is understand the risk and benefit, or decline to perform cesarean section in that if you feel that it is a health concerns or more, or the patient appear to not understand, but send them to another obstetrician for a second opinion. This is a mom's frustrations. When you have a woman have a right to choose not to have a pregnancy, not to continue the pregnancy, to deliver at home, even scar at the uterus, to have epidural, not to have an operative vaginal deliveries. When I ask for cesarean, why I am asked you put into the mental health status assessment? Why you telling me that I'm anxious? Why I'm having a fear now? So what if you without moral arguments, if you say no, then I will swap pregnancy for surrogacy. This is what the mom's frustration. Those who are especially asking the tip of icebergs, very few people are coming and asking. To cut the shortcut to the conclusions, previous cesarean sections, though we know that the 60 to 80% of these women would deliver vaginally, as a society, we don't compel those women for a repeat cesarean section. And same with the breech vaginal. The art of 19th century of breech vaginal, which failed to survive in this 21st century. So when they requested, don't say no, acknowledge the legitimacy of the request, and expected family size needs to be taken into account. Any decision need to be taken into account according to the local jurisdictional factors. According to Indian jurisdictions or Tamil Nadu state government, we have to take that into account and act. The legend Julius Caesarean want this way. So autonomy is a positive right. There is the patient's woman choice is a positive. If you say yes, then if someone asking different, requesting something different, you have to provide. Request to CDMS only if the risk benefit analysis is favorable. If you say no, there is two way of approaches. So if not, you go for an artificial womb. Ecto-life.
C-sections will be a thing of the past. Ecto-life is designed to help countries that are suffering from severe population.
Thank you. So the right, the one in the left, one on the left is a normal delivery, having a HA grade 2, coming out of my cooling therapy. The other one is a safe elective delivery. Thank you.
Thank you, Dr. Deepa. Wonderful discussion. Now we will listen to Reshmi. She will be in a position to answer your questions. Dr. Reshmi.
Sorry.
Where is Dr. Reshmi? Radhika, Reshmi illa?
Reshmi இங்க இதுல இல்ல மேம் டாக்டர்னு ஒரு இது இருக்கு
இருந்தாங்களே மேம் 5 minutes முன்னாடி ஒரு நிமிஷம் call back and call her.
Priya,
ரேஷ்மி அதோ இருக்காங்க. ரேஷ்மி இஸ் தேர். டாக்டர் ரேஷ்மி அவ அன்மியூட் பண்ணிருக்கா, மியூட் பண்ணிருக்கா. ராதிகா அவ கால் பண்ண, அவ இருக்கா. ரேஷ்மி,
Yes, madam.
ரீநேம் யுவர் நேம். எல்லாரும் டாக்டர்னே இருக்கீங்க. ரீநேம் இட்.
Okay, madam.
So, Reshmi, you have 10 minutes to tell that CDMR at request is to be done or not.
Can I just
Please clarify Deepa's doubts.
Yes, madam. Good afternoon, respected Judge Dr. Sambat Kumari, my co-debater Dr. Deepa, my
slideshow, Papa. Slideshow.
Yeah.
It's echoing, ma'am. Can you please log in one device, ma'am?
Okay.
Yes, Reshmi, yes.
Yeah. Yes, madam. I'm Dr. Reshmi, Assistant Professor, Kanyakumari Medical College, and I do hereby stand against the motion of demand cesarean. I do completely agree with Deepa. There are a lot of advantages, and it is a woman's right to have she has every right over her body and independence to choose her delivery. We have no right to interfere with her freedom and her rights. But as healthcare profession, it is our prime duty to ensure that the patient receives appropriate counseling and support, which facilitates her to take a correct decision. It is our duty to make sure the patient makes a correct choice of a cesarean section or a normal delivery, and for that we need to have an extensive counseling. So I would like to give more importance to counseling. To start with, what is the definition of cesarean section? Cesarean section on maternal request is defined as a primary cesarean delivery on maternal request in absence of any maternal or fetal indications. Now we can go to the NICE guidelines. The NICE guidelines also reluctantly says if a vaginal birth is still not acceptable option after discussion of benefit and risk and offer up support. So they want us to discuss the benefit, risk, offer support, which includes perinatal health, perinatal mental health, support if appropriate, and offer a planned cesarean section only for women requesting cesarean section in spite of this. So as obstetricians, we should explore in detail why women request cesarean birth and provide effective counseling in order to decrease cesarean birth on demand. Now, counseling in CDMR is a bioethical debate which struggles to balance an autonomy with the duty of the obstetrician to uphold the principles and the patient autonomy. We have to, it is our duty to uphold the principles of beneficence, non-malignance, and justice. Are we justified to fall in for the patient's demand of CDMR? We should aim at maximizing the patient's understanding the issues and focus on the individual needs, medical risk, and physiological concerns. No non-directive counseling which incorporates the women's values, cultural context with sensitivity to her concerns. Now, before I think already Dr. Deepa has said, the incidence of CDMR has gone high up to from 0.2 to 24%. CDMR is silently gathering its place in top of indications of cesarean section. Why do we need cesarean section audits if CDMR was a choice? Why isn't the WHO promoting CDMR? Ignoring intrapartum CDMR would give a considerable setback to the worldwide efforts of reducing cesarean section rates. It is likely to change the entire perception of childcare process. It has been found that developing countries like China, Australia, and the US and India, the rates are as high as 16 to 20%, whereas US, Sweden, Hungary, Canada, the rates are as less as 2 to 3%. What is there in those countries where the women prefer vaginal birth rather than cesarean section? Probably it's the counseling. Are we giving enough importance to counseling and addressing the needs of the patients? So let us see what are some of the influencing factors for CDMR. One is tocophobia or fear of childbirth and pain during childbirth.
So obstetrician should, it comes to around 30 to 60%, one of the most common causes influencing CDMR. Obstetrician should explore the fear because the fear of pain cannot be managed by cesarean section. Can we guarantee a post-cesarean period is pain-free? And it has been found out the common causes of fear is depression, anxiety, which may even worsen after a cesarean section. And some of the other causes, around 6 to 10% influencing factor is a previous bad experience with childbirth and inadequate analgesia, inadequate pain control, dystocia, injury to the baby. Some previous bad experiences like this make the woman go for a choice of CDMR. So this was a study conducted in Norway, which we can see the different the reasons why a woman chose a cesarean section. She had to undergo previous cesarean section, an instrumental delivery, excessive bleeding. Can we guarantee there is no excessive bleeding in a cesarean section? Retained placenta, serious maternal infection, thrombosis. A demand cesarean section may not be the recommendation for dealing with most of these problems. And many women have a positive attitude towards cesarean section. Probably the misconception based on friends, social media, society, Facebook, etc. They feel that it is safe for both mother and baby, but whereas the studies indicate otherwise, where the complications of cesarean is much more than normal vaginal delivery. Fibroids can be concurrently treated safely. That is a question. Where again, one of the major issues we face is superstitious beliefs of auspicious dates and a strong ideology in females. Then CDMR has a strong advantage in these women. Then maintaining, as we have already, Dr. Deepa had said, maintaining the integrity of the pelvic floor. But I think we've had 2 to 3 years of intense training during our postgraduate degree and so many years of experience. Can't we just do a pelvic examination and decide which are the women which are eligible for a normal delivery and which are not eligible, and probably take them for cesarean? But that will not come under CDMR. It is under CPD. Then fear of pelvic organ prolapse. Institutional delivery, how many pelvic organ prolapse can you see? Then preserving the sexual function. Studies have shown that there is no difference in sexual functioning between a vaginal and a cesarean delivery. So it is the duty of the obstetrician to clarify any misunderstanding, misbeliefs, and misconceptions regarding a normal delivery. Then you should also be discussing the other disadvantages like anesthetic complications, high level of anesthesia blocks, risk of bladder, urethral injury, intestinal injury. Cesarean is more popular than vaginal delivery with regards to postpartum pain. Is it really so? Then why, like we were asked a question, why induce, why not CPD? Then why do we need cesarean section audits? Why is the whole world behind us to reduce our cesarean section rates? And there's also longer hospital stay. Insurance companies are not happy with cesarean sections. There's risk of wound infection, subsequent placenta previa, uterine rupture, higher risk of purpural febrile morbidity, and risk of venous thromboembolism. And the neonatal outcome, we all know there's transient activity of newborn, respiratory distress, persistent pulmonary hypertension, hypothermia, etc. Now, why do the WHO recommend a positive childbirth experience? How can we as obstetricians provide perinatal support to the child to make childbearing a positive experience? WHO has issued a guidelines for positive childbearing experience, which the first few points are dedicated to focus on giving respectful maternal care, which refers to organized to allow women in a manner that maintains dignity, privacy, and confidentiality, effective communication between maternity care providers and women in labor. A companion of choice is recommended for all women. Midwife-led community of care models, support in women in antenatal, intrapartum, and postpartum continuing. Now, my closing arguments, I don't have much to argue. Maternal morbidity with planned cesarean is the same as that with vaginal delivery. And the cost of cesarean section on demand are higher than those incurred in vaginal delivery. Are we justified in doing a cesarean section to someone who actually can give birth normally? Labor is a hard work. I do agree, but women are strong and nature helps make the hard work possible. Why do we need to go against nature? And here we obstetricians, we have a pressure of reducing a cesarean and a pressure on CDMR. How do we balance both? If I think the counseling is the best way, and at least one patient, if you can convince them from a normal delivery, probably it's a victory for us. A conscious effort on the part of the obstetrician to curb the alarming rise of the incidence of cesarean has to be made, or I fear a day will soon come where CDMR will top the list of our CS audits. It doesn't matter when, where, or how you give birth. What matters is how you cherish every moment after. Thank you.
Thank you, Rashmi. I think you have given a wonderful points. Dr. Deepa?
Yes, ma'am.
Do you want to
see CDMR?
2 minutes.
CDMR is a one thing we have to convince the woman.
Rashmi, 1 minute, Deepa. Rashmi,
Yeah.
you can stop your sharing.
Okay, I'm not sharing anything. It's okay, madam. So ignoring intrapartum, we are not allowing the woman to decide. Whatever they have to decide before the labor starts. So if they are very strong in not going into the labor, not established labor, and we have to respect the view, that's mine. And if you use the word like depression, anxiety, fear of labor, it's very, 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 we in a subtle way, we have to put it out, and they will snap you out that I know that they now is going for a Google, they know the risk and benefits of cesareans, and if they understand everything and if an informed choice, then probably we have to go.
Madam, again, that is what I meant, an informed choice, not from Google. It should
That's
come
why
from
my
Google.
talk.
Yeah.
Okay, allow me to talk, right? Okay, sorry. Bleeding is actually more common in a prolonged vaginal deliveries and induced compared to the planned elective cesarean section, which was scheduled at the daytime. And thrombosis, we have now typical TVT protocols where we are using a heparin, and with that probably we can reduce it. And the pelvic examination, as I say, it's very difficult. And epidural, labor analgesia itself, we are using epidural. And if you use a intrathecal morphine and good spinal with post-op paracetamol, IV paracetamol is within 24 hours, it's a wonderful analgesic. Patient doesn't need even analgesic if you use an intrathecal morphine for spinal anesthesia. And very, very rarely we are seeing in the anesthetic related complications. So my choice is, even though if the patient asks, despite you counsel everything, don't deny. That's it. Thank you, ma'am.
Thank you, Deepa. Rashmi, you want to tell anything? 1 minute for
No,
you.
madam, even I am of the opinion, but counseling is important and trying to get them out of it.
Okay. So we will come to the final conclusion. As Deepa was for CDMR at request, and Rashmi is not for CDMR at request. See, with both of you had done a good job. See, Deepa was talking all points in favor that we should do cesarean when a patient is asking. But Rashmi was also good, and she was talking we should not do cesarean whenever the patient is asking. As a health worker, we have to give counseling, and we have to tell what is good and what is bad. So finally, on the topic given, both of you have done a good justice. Both of your talk was fantastic, and congrats to Deepa and Rashmi. But practically, as a point, see, when there is a one natural thing is there, why we want to prevent that natural things? Nowadays, the generation is changing. They don't want normal labor. They want to go for surrogacy. Like that, things are going. So we should have some protocols. So as far as the judgment, if you are going to yield to the cesarean section at request, as Rashmi told, and in the Robson's criteria, it will be the number one. Because no one nowadays, they don't want to undergo the pain. So what is natural should be natural. Sorry, Deepa. Okay. So always avoid.
That's why I said, madam, see, most of the maternal request, we are deciding in the labor. Don't do it labor.
So if we are not doing in the labor, means lower segment will not have also been formed, no. Yeah. So nature will be nature. That is God's gift. So let it go by the nature. But Deepa's points is taken out. Again, there are a lot of litigation with the medico-legal issues. If a patient done at request, she is going for PPH and hysterectomy, you are answerable for that. So always try to go with the nature. Thank you, Deepa and
Thank you,
Rashmi,
ma'am.
for the wonderful.
Thank you, madam. Thank you for
Thanks,
the opportunity.
Rashmi. Thank you, Rashmi.
And hi, Deepa.
Thank you, thank you. So once again, I request all of you to join the VP conference of high risk pregnancy, HRPCon at Kodaikanal, August 11th to 13th. Welcome you all. Radhika, go
Yes,
to the
ma'am.
next.
Sure, ma'am.
Dr. Basanti wanted to tell something with the previous panel. Dr. Basanti, are you there? I saw some message.
Yes, ma'am. In the chat
I don't
box,
know. She was not there. Yes, we will go to the next
Yes, ma'am.
panel. The people are waiting.
Yes, ma'am.
Radhika, introduce the moderator and the panelists. Let them go straight to the
Yeah,
panel.
ma'am, I'm here. Radhika ma'am is into the panel as well.
Panel.
Yes,
Yeah.
I'm one
Shruti,
of the
you can
panelists. Shruti
introduce.
is
Yeah.
here. Yes, ma'am.
Shruti,
Yes,
you
yes.
can introduce the
That was
moderator.
wonderful debate, ma'am. Cesarean section, we can go on and on till evening, whether it is indications or it is difficulty in cesarean. So we'll move on to the next session. It is a panel discussion again on HDP, that is hypertensive disorders in pregnancy. And we have our chairpersons, Dr. Jayamala and Dr. Shanmuga Vadivu, madam. We welcome both of you, ma'am. Dr. Jayamala, she's a consultant obstetrician gynecologist and infertility and gynae laparoscopy surgeon and assistant managing director, Rainbow Hospital, Salem. She's president OBGYN Society, Salem, and she has done academics. She's excelled in academic field. She has worked in Republic of Ireland from 2000 to 2009. Had special training in gynae laparoscopy under Madam Magos at Royal Free Hospital, London, and ultrasound training at fetal medicine unit at Royal Free Hospital, London. And she is a consultant at SKS Hospital, Salem, and she has organized various conferences, and she was also a co-chairperson UA Foxy South Zone 22. We welcome you, ma'am.
Thank you. Thank you for the nice introduction.
Yeah. Next is we have Professor Shanmuga with Divu, ma'am. She is Professor, Department of Obstetrics and Gynecology, Government Mohan Kumaramangalam Medical College, Salem, and she has 16 years of experience and teaching experience for both undergraduates and postgraduates, and she has many publications to her credit, and her special interest is in gynae endoscopy and high-risk obstetrics. We welcome you also, ma'am.
Thank you.
Now,
Thank you,
our
ma'am.
panelists our senior member, Dr. Professor Asha Nervi, ma'am. She is HOD OBGYN Society, SDM Medical College, Dharwad. She is an experienced PG and UG teacher as well. She was a past president of Hubli Dharwad OBGYN Society. And her areas of interest: high-risk obstetrics, diabetes in pregnancy, vaginal surgeries, myomas, and adolescent PCOS.
Good afternoon, everyone. Thank you, Shruti.
Yeah, we welcome, ma'am. Dr. Uma Deshmukh, our next panelist. She is HOD OBGYN in Bidar Medical College, advisory committee member of PCPNDT Bidar District, nodal officer for maternal mortality Bidar District in 2007, and she is trainee of trainers for PPIUCD, EMCH, and CAC programs. And she was vice president. She is the vice president for the year 22-23, and as well as president of Bidar Society. She has received Best Doctor Award from Endanger NGO Bengaluru, and also received Sarvottam Seva Prashasti Award from Government of Karnataka in 2020. She has received Sri Shakti Prashasti in 2020 from Sharana Basava University, Kalaburgi, and also received Aspiring Women Award 2021 from Vega NGO Bidar. And she has an appreciation certification from Rotary Club of Bidar New Century in 2022. Too many awards, ma'am. We welcome you. Thank you. Dr. Deepa, yes, and she is undergraduate from SSMC Tumkur, and DNB she is completed from Sri Gokulam Medical College, Thiruvananthapuram. She has got trained in advanced ART from Milan, Bengaluru, and presently working as assistant professor, Sri Chamundeshwari Medical College, Channapatna. She is joint secretary of Mandya OBGYN Society, and her special interests are in high-risk pregnancy, infertility, and gynecological malignancies. Our coordinator, Dr. Radhika Gauri, ma'am. She is a specialist consultant in OBG and clinical lead in ESI Hospital, Tirunelveli, Tamil Nadu. And she is an alumni of Tanjore and MMC Chennai. She has completed MRCOG in UK and has 10 years of UK experience as registrar. She has 20 years of clinical experience in OBG field, and she is member of FOGSI, RCOG, IMA, and OGSI. Clinical lead in ESI Hospital, and her interesting in fields in high-risk pregnancies, adolescent obesity, and laparoscopy. We welcome all the panelists. And one more panelist, Dr. Ambika Patil. She has finished her MBBS and MS from SDM Medical College, Dharwad, a gold medalist. She has been awarded as an outstanding postgraduate student. She is currently working in Department of OBG, Al-Amin Medical College as an associate professor. And she was the past joint secretary for Bijapur OBGYN Society, and her special interests are in high-risk pregnancy, infertility, and laparoscopy, fetal medicine.
Thank you, ma'am. Thank you.
Yeah. Another panelist, Dr. E. Shanti, madam. She is a professor in Department of OBGYN in Savita Medical College and Hospital, Chennai, Tamil Nadu. She is trained in ultrasound in OBGYN FOGSI training course in advanced infertility and advanced laparoscopy, and also a provider and instructor. She has teaching experiences and many publications and research papers to her credit. We welcome all the panelists, ma'am. We welcome you.
Thank you.
Jayamala and
Yes, ma'am. We'll start sharing.
45 minutes, ma. Start.
Yes, ma'am.
Nache.
Okay, 1 minute, ma'am. We'll start. Able to see the screen, ma'am?
இல்ல மேம் உங்க இரண்டு அழகுகள் தான் தெரிகிறது பல பலன்னு.
Jayamala ma'am, are you sharing your screen?
Yeah, just a minute.
Yes.
I'm just where did it go?
Presentation minimize பண்ணிக்கோமா.
Yes, ma'am, I minimized it.
அப்புறம் share screen போடு.
இல்ல என்னோட Zoom on ஆகுது. Yeah. Share screen. Yes.
இப்ப தெரியுதா மேம் ஸ்கிரீன்?
தெரியுது. ஸ்லைட் ஷோ போயிடு.
ஸ்லைட்
கீழ அந்த கப்பு மாதிரி இருக்குல்ல அதுல போடு. Yes, that's all. Okay.
Ma'am, thanks for the opportunity given, ma'am. I have Dr. Shanmugadi also with me, so we'll co-moderate the session, ma'am. Yeah.
We'll start, ma'am. Thank you, ma'am. Thank you, Sambat Kumari, ma'am, for the opportunity. Hypertensive disorders in pregnancy is a spectrum of disorders ranging from already existing chronic hypertension, index pregnancy, to complex multi-system disorders like preeclampsia, eclampsia, HELLP syndrome, acute renal failure, pulmonary edema, stroke, and left ventricular failure. And severe preeclampsia and these complications are the major causes of maternal and perinatal morbidity and mortality. And it accounts to 19% of deaths are due to hypertension in pregnancy. And incidence of preeclampsia is around 10.3%, and eclampsia is around 1.9%, and out of which 50% of cases are antepartum and 13% of cases are postpartum eclampsia. And eclampsia attributes 4 to 6% of mortality. And coming to the classification of hypertensive disorders of pregnancy, we have gestational hypertension, that's BP more than or equal to 140/90 millimeter of mercury, detected beyond 20 weeks of gestation, and BP returns to normal within 42nd postpartum day, and it is not associated with any features of preeclampsia. And chronic hypertension, the evidence of hypertension or a case of hypertension detected before 20 weeks of gestation in the absence of trophoblastic disease. And preeclampsia, it is a multi-system inflammatory disorder beyond 20 weeks of pregnancy with significant proteinuria characterized by Day-1 onset of hypertension of more than 140/90. And atypical variant includes neurological, hematological, hepatic, renal manifestations or fetal growth restrictions in the absence of proteinuria. And eclampsia, occurrence of seizures in association with preeclampsia. It can also occur as atypical eclampsia. And superimposed preeclampsia, it's occurrence of preeclampsia in women with chronic hypertension. With this short introduction, we will go for a case discussion. We have 4 cases for discussion.
Yes, ma'am. Dear panelists, we are going to have only clinical scenarios in our day-to-day practice, nothing big. So our first case is Mrs. CS. She's a 28-year-old with a BMI of 25. She's a para-1 live one present to antenatal clinic at 12 weeks of gestation. Her past obstetric history, she had a normal delivery at 37 weeks of a birth weight of 2.8 kilos 2 years ago. During pregnancy, she had high blood pressure from 35 weeks and was on antihypertensives. She has family history as mother who is a diabetic and hypertensive. Otherwise, she's a healthy lady. Now she's scared about high blood pressure in this pregnancy. She has come to you at 12 weeks. Okay. She wants to know her risk of having high blood pressure in this pregnancy. So we will discuss one by one the screening. First, we'll go with the how do you recognize whether she's at high risk by history. So one of my panelists, Dr. Asha, can you take this question?
Yeah, good afternoon and thanks for the opportunity. Definitely, she has in her history, she has a late onset hypertension, like after gestational age of 35 weeks in previous pregnancy. That is a high risk factor. And there is a family history of also high blood pressure. Mother is having a hypertension. So there is definitely 15 to 20% risk of having again hypertension in this pregnancy. So she has to undergo a screening, and first thing we'll screen is for a uterine at a Doppler at 12 weeks. And again, we can do a biochemical markers
we will go into that detail later.
Yes.
Yeah, so by history, how else do you, any patient for that matter, how do you assess her risk for preeclampsia?
Yeah. There is our very own gestosis score is also there, and there are some risk factors by NICE and ACOG, and definitely if his risk factor is the score is very high 3 if it is a ART pregnancy, or if she has previous history of preeclampsia, the risk directly goes 3 to her. And she's BMI is normal, so she doesn't have a risk factor. That BMI is not BMI more than 25, age more than 35. These are all high risk factors for having a preeclampsia in this pregnancy.
Actually, that is what I wanted to highlight. The gestosis score. I think in our clinic, like even the staff knows, in every antenatal record, we have this gestosis score, and they'll just tick it and score it at booking, and again at 16 weeks, and then again at 3rd trimester. As we all know, screening test facilitates early diagnosis, target the surveillance, and timely delivery, thus reducing the maternal mortality and morbidity. So that's the whole point of us doing the screening. And of course, as you said, we all know about the gestational scoring. And every antenatal woman should have, at booking, should have a gestosis scoring done, and should have this, should have the gestosis score assessed. So as you said, ascertain the gestosis score. Yeah. And after that, what do you do? Dr. Uma.
All right.
Yeah, so we have ascertained the gestosis score. And what else do we do for screening the for risk, to determine her risk for preeclampsia? Is Dr. Uma there? Any of my panelists can take the question.
Yeah, definitely.
Okay. Can I speak now?
Yes, anybody.
Yeah, that's what, ma'am. As you told, at booking and at 16 weeks and in 3rd trimester, we go through this gestosis score, assess a score for her. And along with that, because she gets a score of 2 because of her previous history of gestational hypertensive disorder. So she falls, if the score is 3, we consider as at risk for preeclampsia, but she comes to a score of 2, which should give us a more, which should alarm us, and which should initiate us to do a more detailed investigation for her, because the history was in the first visit only. So at 11 to 14 weeks, we'll go through the uterine artery Doppler, as ma'am told. We'll see for the pulsatility index in the uterine arteries, and if it is more than the 95th percentile, then definitely it is considered as abnormal. If it is more than around 2.35, then it is considered abnormal. Then, so
yeah, that's excellent. That is the, yes, ultrasound screening for preeclampsia. That's very good. Yeah, and yeah, at 12 weeks you have done this. What I mean, you have to map the patient's blood pressure also, right? Mean arterial BP.
Mean arterial blood pressure.
Yeah.
Mean arterial BP.
And what are the other modalities like biochemical markers that we can use to predict preeclampsia?
Biochemical markers like soluble forms of tyrosine 1 and endoglin 1, placental growth factor, and PAP-A, maternal alpha fetoprotein. Then all these things, so many markers have come up, but nowadays the most accepted is you can go for maternal alpha fetoprotein, then uterine artery combined with uterine artery Dopplers, then PAP-A, and the placental inhibitory, placental growth factor is very important. And the best predictor for early onset preeclampsia, there is a endoglin 1 with soluble forms of tyrosine divided by placental growth factor. If we do and take a cutoff, it has been considered nowadays as the best predictor for early onset preeclampsia before 34 weeks.
Yeah, as you rightly said, yes. Yeah, all these, like when you do a 12th week, we always do this first trimester screening, combined screening for trisomy. So with that, you get the low, PAP-A and inhibit B, all those we are getting. So you have to include this placental growth factor also. Like we have started doing, at first trimester, we're doing PLGF also. So these are the, as you said, these are the ones that predict preterm preeclampsia, that it early onset preeclampsia by 82%. But we need to be aware that this doesn't predict the term preeclampsia or the late onset. Okay. So as this is just the algorithm at 11 to 13 plus weeks, we do check the medical history and calculate her risk by gestosis score, go for the ultrasound markers and then biochemical markers. So if the risk is low, yeah, you give routine antenatal care. But if the risk is high, they need to be under surveillance, and you can start around low dose aspirin. Okay, yeah. So if the gestosis score is more than 3, what intervention would you recommend?
So we would.
Yes, Dr. Radhika?
Yeah, we would start her on low dose aspirin, 150 milligram per day.
Very good.
And then we can give her the usual, the folic acid, and then she will need a anomaly scan as usual. And then we have to plan a growth scan every 3 weeks. And we should have a close monitoring on her, blood pressure. And I would repeat the bloods for the pH, predicting pH, including liver function tests, and starting from 28 weeks, and also clinical examination. Actually, look for pedal edema, the increased blood pressure, and also the signs and symptoms. I will inquire at every visit, and also warn her that she is at high risk. That is the main thing. Actually, we have to advise her that she is at slightly higher risk of preeclampsia or increased blood pressure throughout the pregnancy. And the signs and symptoms, every time we should tell them that the headache, she has a headache, or those signs, facial puffiness, sudden increase of weight, and pedal edema, and diminished fetal movements. So those symptoms I would counsel her even from the first visit, so that they remember that there is a high risk pregnancy, and they will come for antenatal checkup regularly.
Very good, excellent. Yes.
Can I Can I add, madam? Just one
yes,
point.
yes.
That's all. Apart from aspirin, I would I'll ask her to have some dietary modifications like no extra salt, and she should do little breathing exercises and yoga, simple yoga, so that that will help her to not worsen the disease.
Even capsule Evian also helps for that.
Other things we don't have any good robust evidence by using antioxidants or all those things, but definitely excess salt we should avoid, extra calcium 2 grams, and breathing, relax, she should relax and not to take a lot of stress, and breathing exercises like simple pranayama and yoga definitely are way forward to prevent the worsening of the preeclampsia, reducing its complications, I think.
Yes, ma'am. Well taken. I think, as you mentioned, rightly mentioned, yeah, she knows that her gestation score is more than 3, and then we have done all this high risk scoring, and we have put her on the high risk for getting preeclampsia. So she should be definitely warned about her signs and signals, signs, and then you have to tell her that she needs to be under radar for surveillance. And as you said, we have to check her BP, urine albumin every visit. Yes, once the BP starts shooting up, we have to intervene properly. I think we'll go ahead with the next case. That in that case, we will discuss about the management of preeclampsia. So as madam said, yes, low dose aspirin 150 milligram and calcium 1 gram to 1.5 gram to be started before 12 weeks.
Yes.
Like that.
Yeah. So with that, we'll go on to the next case.
We'll move on to the case 2. She's Mrs. Pravina, 29-year-old primey. She's married for 7 years and her gestational age is 32 weeks. And she has a history of bilateral pedal edema for 2 months and complaints of headache, blurring of vision for 1 week. And there is no associated epigastric pain, vomiting or oliguria. And she's having regular menstrual cycles. And she conceived, married since 7 years and conceived after IUI. And she's a known hypothyroid and L-troxin 50 microgram for 2 years. On examination, she's not paler and she's having pedal edema, and uterus was 30 weeks and head mobile, and there is abdominal edema, and the BP is 170, 110. And investigation shows the hemoglobin is 11.2 and the platelet is 1.5 lakhs and creatinine is 1.2 and bilirubin was normal, SGOT, SGPT and albumin globulin was within normal limits, and urine albumin was 3+, and the spot protein creatinine ratio was 3.5, and LDH was 750 units per liter, and ultrasound shows single live intrauterine gestation with 30 weeks and amniotic fluid index of 7 centimeter and estimated fetal weight within 5th centile, and umbilical artery Doppler shows reduced end diastolic flow. Dr. Deepa, what's the probable diagnosis for this case?
We diagnosed her as a primary gravida with 32 weeks of gestation with high risk for with preeclampsia, severe preeclampsia.
Yeah, she's having preeclampsia.
Blood pressure recording is more than 160,
170, 110, and urine albumin is 3+.
Yes, urine albumin 3+.
And she's having also intrauterine growth retardation. So the diagnosis is preeclampsia with severe features.
Yes.
Next, how you go? What's the plan of treatment? What will you plan?
Plan of treatment for severe preeclampsia is ultimately the delivery. But the initial management would be the control of hypertension and prevention of eclampsia.
Okay. So you want?
So antihypertensives along with magnesium sulfate prophylaxis would be the ideal thing, and ultimately it should be as there is associated fetal growth restriction with the AFI7, we may have to deliver the baby.
Okay. Well taken. So we have to admit the patient, and this admission should be in the HD unit. And you should get a DIL and inform the consent about the prognosis for the mother as well as the prognosis for the fetus. and you send all the investigations which was stated above. And the antihypertensives, you go with, since the BP is 170, 110. In order to control the immediate control of BP, you go with the IV intravenous levetiracetam. So you start with 10 to 20 milligram IV stat, and it is followed by you can increase the dose, incremental doses of 20, 40, and 80, and every 20 to 30 minutes. So the maximum dose goes of 300 milligram, or you can give a levetiracetam infusion of 1 to 2 milligram per minute, or you can go with oral nifedipine. So you can start with 10 to 30 milligram start, and you can repeat every 30 to 45 minutes, and the maximum dose of 120 milligram. So after giving the antihypertensive, you monitor the BP for every 15 to 30 minutes. So till the BP is less than 160, 110, and then you can monitor every 4th hourly. So as you said, you have controlled the hypertension, and the anticonvulsant, that the magnesium sulfate prophylaxis is very important. And you go with the Maxwell regimen. Either you can give the IM regimen or Pritchard's regimen or Suspan regimen, you can go. And since she is 32 weeks, you give corticosteroids for lung maturity. And since he is having severe preeclampsia, you do a fundoscopy to rule out the hypertensive retinopathy, grade the hypertensive retinopathy. And also you do echocardiogram to rule out she is having any cardiac failure. And since she's 32 weeks, she's having a precious pregnancy, I think we can go for conservative line of management. And since the patient is very anxious, creatinine is 1.1,
1.2.
Sorry, 1.2. And her LDH is more than 700.
I think
750.
we should terminate in a unit where
After the short
NICU. Yes. Once
after
we stabilize,
steroiding her,
we can terminate after a course of steroids.
Of course, yes.
Yeah, but if
And
the creatinine is
even nowadays, because with the surfactant, I think babies after 28 weeks do well. Especially with this precious pregnancy, I'll go for delivery once we stabilize. Especially in a unit with NICU, proper NICU, tertiary unit will be better.
Yeah, I do agree. Yes,
yes,
with
madam.
such a severe pregnancy, we don't wait for lung maturity, steroids to act. And of course, we give a steroid, shot of steroid.
Exactly.
1-2 hours, it's okay.
Exactly.
That helps for the baby. Yeah, mother is the priority.
Yeah, I think mothers for the maternal indication.
Absolutely, the renal parameters are really.
If the renal parameters is less, the creatinine is less than 1.1. And if the LFT is normal, I can go on a conservative line of management. And the one point is we need not repeat the proteinuria testing, because once you diagnose proteinuria, the severity of proteinuria is not taken as a criteria nowadays. And you do a daily NST and you repeat Doppler once in 3 days.
One point, madams, the point.
No, this case we are not going to wait, ma'am. If the creatinine is less, so for I am going for the discussion's sake, if the creatinine is less than 1.1 and the LDH is normal. So if you want a conservative management, these all the things has to be done.
Yes, excuse me, ma'am. The creatinine actually should be 0.9.
0.9.
If this 1.1 is severe only, ma'am. I am not, for this case, we are going to terminate.
But normally it should be in the upper, normal pregnancy, it should be in the lower limit of the creatinine levels for non-pregnant women. So if it is even 0.9, we should think of, monitoring her closely and even terminating once we have steroids. That is my, usually in pregnancy.
So if the blood pressure is well controlled and there is no fetal indications or no imminent symptoms and there is no deterioration in lab parameters, we will deliver at 34 weeks.
Yes,
but whenever the blood pressure is not controlled with 3 antihypertensives with appropriate doses, or there is persistent imminent symptoms, or there is deterioration in RFT or LFT, and there is placental abruption or non-reassuring reassuring NST or reverse end-diastolic flow, you go for the termination. So once you have decided for termination, so how will you monitor during labor, Dr. Radhika?
Yeah, during labor, we have to first we continue monitor her blood pressure.
every half an hour because she really has very high blood pressure. So the temperature vitals monitoring is very important. We have to instruct the nurse. Actually, 1-to-1 basis, she should be in the HDU, and her right from the temperature, pulse, blood pressure, respiratory rate, and she should be watched closely for any acute symptoms. So vitals continuous monitoring we can do. The blood pressure every 15 minutes to half an hour. In the first stage, every hour should be okay. But during the second stage, we have to monitor every 5 minutes. And then the urine output should be closely monitored. We can put in a catheter, and we should actually put in a catheter to monitor because she is on max self. And the urine output should be minimum of 40 ml per hour. Then we have to keep a close eye. If she's and the reflexes should be monitored once she's on max self. The 4 things: the respiratory rate, the reflexes, the clonus, and if she's on max self, the diminished reflex also should be monitored. And the urine output, I said.
Okay.
Fetal monitoring.
Fetal monitoring is a continuous CTG.
So
Yes,
we will
absolutely. Continuous CTG, and as
Yes,
you
ma'am.
mentioned, fluid overload should be. We should keep an eye on the fluid overload. 80 ml
And
per
prolonged, prolonged labor should be avoided. I think
Avoided.
we should try to take a decision little early compared to other patients.
Yes.
Okay, ma'am. Your point is well taken, ma'am. We'll actually, for this high risk, it's a high risk pregnancy and it's high risk delivery. You coordinate with your anesthetist and the neonatology team. And since the baby is less than 30, it's around 32 weeks with IUGR, and you closely monitor the BP, pulse rate, and SpO2 every 15 minutes, and a continuous fetal monitoring should be done. And even this antihypertensives and this Maxel should be continued during the delivery also. Magnesium sulfate, even if you are given in the before delivery, it should be continued throughout the delivery, and also 24 hours after delivery also it has to be continued to avoid convulsion. And after checking on the coagulation profile and the platelet count, you can opt for epidural analgesia for labor. And fluid overload should be avoided to avoid pulmonary edema. And this should be restricted to 75 to 80 ml per hour. And you can consider cut short the second stage with the outlet forceps. And since these patients have the they are more prone for postpartum hemorrhage, this preeclampsia patients. So you should follow active management of third stage of labor. They have hemoconcentration, and even minimal blood loss will be more dangerous in these patients. So you should be more cautious about postpartum hemorrhage. And this cesarean section is only for obstetric indication. And after delivery, this postnatal follow-up is very, very important. Dr. Ambika, can you go up with this postnatal follow-up?
Yes, ma'am. Immediately after delivery, if she was priorly on any antihypertensive like methydopa, it has to be stopped within 48 hours of delivery. And we have to monitor her blood pressure for next 48 hours, 4th hourly. And followed by that, every day, we have to at least keep the patient for 10 days in the department of OBG in the ward, so that we can monitor her blood pressure regularly, and we can switch over to the other antihypertensives. For if she is continued with the labetalol, then we have to continue with the labetalol, or if it is controlled, we will continue with the same for next 10 days, or if it is not controlled, we will consider for the other drugs also. And we have to vigilantly monitor for the features of imminent eclampsia and eclampsia. Postpartum eclampsia is also very common to happen within first 48 hours following delivery. So we have to monitor for those. And if there is no signs and symptoms, it's fine. Or if it is there of imminent features, then we have to start for the magnesium sulfate and continue for 24 hours. And then we can discharge, and after 10 days, once the blood pressure is settled, then we can call her after 15 days for a follow-up for monitoring of the blood pressure, ma'am.
Okay.
Thromboprophylaxis.
Thank you. It's we'll check the BP 4 times a day when the patient is in inpatient.
Hello.
And after that, every day for at least 2 weeks. Generally, in our medical college, we keep at least for 14 days. And this target BP should be less than 130/80. And this antihypertensive, actually, it's a long-acting drug. Generally, we continue with the lebitalol, but it's a AC inhibitor like elanapril or long-acting calcium channel blocker like amlodipine. So it is preferably given. And after 2 weeks, these patients can be transferred to community care. That's in our setup, it's the primary health care. And until the woman is off treatment and has no hypertension. So these antihypertensives, generally we continue till 6 weeks, till 42 days, we continue the antihypertensives. And this patient should be informed. We have a high risk group here, including the private practitioners as well as the community health nurses. So we generally post these cases in the group, and these cases will be followed by the village health nurse, and the BP will be checked at their home regularly. And they check whether the antihypertensives are taken regularly. And while on admission, you repeat the complete blood count, renal function test and liver function test after 48 hours, because there is a chance of postnatal, the chance of HELLP syndrome even in the postnatal period. So you check all this. Once in 48 hours, if everything is normal, then you need not worry. And if the patient is having, since this patient is having massive proteinuria, so you do a repeat proteinuria testing at 6 to 8 weeks. And if this proteinuria is persistent even after 3 months after delivery, so she should be referred to the nephrologist to rule out the nephrotic syndrome. And if the hypertension is persistent even after 6 weeks, the patient has to be referred to a general physician.
Thromboprophylaxis.
Any other points, any panelists you want to add to this?
Yeah, thromboprophylaxis because
I have forgotten that, ma'am. We have to give thromboprophylaxis. It is 0.1 milligram per kg body weight. You can give low molecular weight heparin.
Okay, and
1 milligram per kg. Sorry, 1 milligram per kg.
1 milligram per kg. And we should alarm her that she may develop hypertension after age of 40. So again, lifestyle modification and risk of having complications, we should explain to her.
So these patients are more prone for long-term complications like
coronary artery diseases,
cardiovascular complications like myocardial infarction and chronic hypertension. And these patients should be advised lifestyle modifications, and they should avoid obesity. All this they should be taken care of.
Yes.
We'll go to the next case, ma'am.
Yes. Yes, my dear panelists. This is Mrs. Nimi, who's 28-year-old primary, married for 4 years. She's a housewife. She's 36 weeks currently, and she was brought by her attendants with a history of one episode of sudden involuntary movements involving all 4 limbs with frothing of mouth, uprolling of eyeballs with loss of consciousness for 3 minutes, occurred 30 minutes before. She has bilateral pedal edema for past 15 days. She was, this you don't need. There's a history of newly diagnosed gestational hypertension 3 weeks before, and she was on labetalol 100 milligram OD. On examination, she's on post-ictal confusion state. She's afebrile, no pallor, bilateral pedal edema plus, CVSRS normal. And her uterus is 36 weeks and not acting, head mobile, and BP was 150/110. Pulse rate was 96, SpO2 99%, and respiratory rate 16 per minute. Our blood investigations are hemoglobin of 9 grams, platelet 3.76, RFTs normal, LFTs, normal, LDH is 988, and urine albumin 4+. So you got the scenario, right?
Yes.
So what's the probable diagnosis here? Dr. Shanti?
Yeah, probable diagnosis is women with hypertension throwing seizures is eclampsia until otherwise proved.
Very good.
So,
antepartum.
Antepartum eclampsia.
Yes, ma'am. So you are working in a resource poor setting.
Resource.
Okay, she is brought to you, so how are you going to manage this patient?
Resource poor is anyway in the, you mean to say the primary health care center?
Yes, something like that. Yes.
So So definitely there will be at least an ANM or VHN around. So we should be calling for help, okay, for assistance, and admit her immediately and give her catheterize the patient. Then IV lines, 2 IV lines to be started. Then bloods to be withdrawn. Then antenatal examination should be done. Railings should be applied, and head to be turned towards one side. Oxygen should connect her with pulse oximeter if it is available over there.
Okay.
And prevent aspiration to apply a mouth gag. And if oxygen is available, to be kept.
Very good.
So meantime, FH should be monitored, and an obstetric examination should be done if she is in labor.
Okay.
If there is facility for and simultaneously after you take the bloods, magnesium sulfate to be started irrespective of blood values.
Reports.
We already have the reports anyway.
Loading dose.
Yeah, loading dose as well as first initially the loading dose.
Okay. And what else did you do? After that, you had given magnesium sulfate. Yeah, you started around magnesium sulfate. You have done the ABC and all. Okay. What else do you do after that?
Antihypertensive. Obstetric examination should be done, madam, immediately.
She's not in labor.
Okay. If there is facility for delivery, yes, we may continue. Like if we have the medical officer there, then we can continue the care there. Otherwise, with every we have to refer her to the tertiary care center with the VHN or ANM accompanying her along with the back self and prophylaxis if the patient throws seizures. Along with oxygen.
I mean, that is what I wanted to highlight here. Yes, you do the ABC, give her magnesium sulfate, give her antihypertensives, give her steroids, not to waste the time, because by the time she reaches there, she may be in a position that we have to deliver. So I think it's better to give that, take that opportunity, give a steroid and transfer, as you rightly said. That is what I wanted to highlight here. Transfer with attendance and monitoring with eclampsia kit, and inform the receiving center. So before you transfer the patient, please inform wherever you are sending, even if it is a private center, not necessarily a PHC, even a resource poor private setup. Wherever we are referring or wherever the patient wants to go, it's better to call the center and inform them that such a mother is coming, so that they'll be having everything ready to receive her. So that is very vital here. Okay, Dr. Radhika. Yeah, now this patient has been referred and you are in the tertiary center. So how do you manage her?
So yeah, we have to first stabilize the patient.
Very good.
We stabilize the patient, and then if she has given the loading dose of Maxel, then continue with the prophylaxis. Actually here it is the treatment because she is on, she threw fits already. So then we have to inform, it's a multidisciplinary team. So you have to inform the anesthetist.
Excellent. I like that word, multidisciplinary. Yes, we wanted that.
So anesthetist and including hematologist and pediatrician and the labor ward team, and immediately shipped her to ICU, obstetric ICU, and monitor the urine output, and we have to make arrangements for delivery after getting the blood results, especially the coagulation profile, platelet count, and the LDH, because she might go for HELLP syndrome. And her blood pressure needs to be taken care of. Yes, airway breathing and circulation.
Yeah, yes, I think in the primary setup, she has already told you have to do all these things, and she has done that, and she has put in an IV line. Catheterization has been done by her. Yeah, so what I want to know is when you receive her, you initiate the eclampsia management protocol. Yeah, so every unit should have a protocol, and everybody should have a drill more often to know how to manage such cases.
So the Pritchard's regimen usually I prefer here. And we give the 4 grams of 50% Maxel on every 4 hours on alternate buttocks. And we and once she's stabilized, we have to, and this should be continued up to 24 hours after delivery. And we have to, get a proper consent, very high risk consent, and deliver the baby. As she's already 36 weeks and we have given
Even
steroids.
before you deliver the baby, she threw up it again. What do? You have given her the loading dose.
And we have to give another dose of Maxilf.
2 grams.
Yeah, 2 grams, another 2 grams of Maxilf as an infusion. And we can take her to theater and deliver her. And then we have to monitor.
We didn't give her antihypertensives yet, right?
Yeah, we have to give labetalol, IV can be given as an infusion, like 10 to 20 milligram IV stat, followed by 20 to 80 milligram every 20 to 30 minutes. So maximum of 300. If she has asthma or any other contraindication, then we have to go for nifedipine, oral nifedipine. Hydralazine should be reserved as a last measure. Before giving hydralazine, we have to preload, which is also a risk for pulmonary edema. So we have to hold that for the last. And if nothing works out, obviously hydralazine 5 milligram followed by 10 milligram every 20 to 40 minutes. So we have to repeat every 3 hours. Probably because she is 36 weeks, once the blood pressure is settled, we will have to go for delivery, emergency delivery. And if vaginally, we can examine her clinically, and she is already, sometimes they are already progressing, labor is progressing quickly. So in that case, we can try vaginally. If not, we go for a cesarean section. And if the platelets are less than 50,000, then we have to discuss with the anesthetist and go for a GA section, again, which has its own risks. But if not, we can go for once she's stabilized, we can go for a cesarean section and a spinal.
Excellent. Yeah, we all mentioned about all these regimens. Yeah, so monitoring, okay. Now fluid management, yes.
Yes.
And yeah, the other doctor in PHC has already given steroids. Yes, you have delivered the mother. Oh, you have told all this. Yes, fine. Next, prevention of PPH in this woman. Yeah, we know that there is endothelial dysfunction, hypertension, and use of magnesium sulfate. All these make this mother more susceptible to PPH. What will be your drug of choice for third stage?
Syntocinon or carbitocin?
Carbitocin, yes.
Yes.
We have to do that active management of third stage of labor. That is a must. And definitely we should avoid methyl ergometrin. Carbitocin, yes, nowadays they are using it, but we don't have, it's only for prophylaxis. Okay.
Prevention.
Yeah. Misoprostol is very good in low resource setting. Sometimes even if she does no history of bronchial asthma, we can use PGF2 alpha also, IM. So first choice will be definitely syntocinon, 10 units at the time of delivery of anterior shoulder or after the delivery of the baby if you are doing a cesarean. Definitely IV syntocinon has got its own drawback. It can cause sudden hypotension.
Yes, sudden hypotension, that should, we should keep it in our mind. Yes, and carbitocin works better as well. So
better. We are you, yes.
And we should keep blood products ready.
Yes,
packed
that's
cell.
9 grams.
Platelets and packed cell.
Yes. So post-delivery management?
Magnesium sulfate to be continued.
Yes.
Patient to be continuously monitored because for the complications, she's not out of risk yet. So until 48 hours, she has to be under intense monitoring.
Monitoring.
Yeah.
Definitely, we should avoid NSAIDs. We don't prescribe diclofenac for them. And regular monitoring of blood pressure and watch for any imminent symptoms.
Yeah, as we already mentioned. Yeah,
yes, ma'am.
She's not just the seizures alone. She may develop DIC or HELP and renal acute kidney injury. So we need
kidney injuries
for the same. So at least until 48 hours.
Yes.
Repeat the parameters before she renal parameters, liver, and all the parameters.
After 48 hours.
48 hours before we discharge. And we also counsel her regarding the high risk of eclampsia if she becomes pregnant again. Eclampsia or hypertensive the next pregnancy.
Ma'am, like we all had a wonderful discussion. We were talking about screening, how we manage eclampsia, severe eclampsia, pre-eclampsia and eclampsia. Everything we are all wonderfully managing. But why is it still the leading cause for maternal mortality then? What are the interventions that we can do to improve? Yes, ma'am.
5 more minutes, Jayamala.
5 more minutes. Yes, ma'am. Ma'am, I want to include you in this discussion. We have done all these, but why are we still having this hypertension, pre-eclampsia as our, eclampsia as our leading cause for maternal mortality? Interventions that we should do from our side.
Universal screening is still not yet prevalent everywhere. So screening plus prevention, that is there. So
and awareness, creating awareness to the patients. On patient side, they do not come for regular follow-up and they come at the last minute.
And we are all doing in our clinic. We are all doing in our clinic by mass media. How can we do this?
See, Jayamala, only one point I will tell. If you see the mortality of a PAH, it is mainly with the rural rather than the urban.
Yes.
Because you people are monitoring.
Exactly.
See, it is sometimes what happens at the basic level, the BP, they do not monitoring. That is the basic things. If you see the antenatal cord, always it will be 120,
120,
18 to 20 weeks, there should be a fall. So unless the paramedical workers do the work in Pakka, we cannot reduce the complications.
So we have
that is the basic things.
Not just the patient, as you rightly said, the paramedical people should be involved in this care. And
5 more minutes, ma'am.
Ma'am, we have overshot the time.
Finished. I told already. Yes.
Thank you. Thank you. We'll go to the next case section.
Excellent panel. Excellent panel.
Chart history, ma'am. She's a third gravida, 26-year-old, previous to
normal. Can you conclude with the findings?
Because only 5
she has
minutes.
elevated, she complains of vomiting and epigastric pain for 2 days, and she had elevated liver parameters. SGOT and SGPT both are elevated, and LDH is also elevated, and peripheral smear shows microcytic hypochromia with the cystocytes, and the estimate gestation age of 32 weeks is normal Doppler study. So what will be the probable diagnosis? Dr. Asha, can you take this?
Yes, ma'am. This looks like a HELP syndrome, and she's 32 weeks, and definitely the investigations are already done, madam. But definitely, I would like to repeat them every 8 to 10 hours so that whether they are worsening or not. I'll steroid her, and definitely with the platelets ready, I would love to deliver her soon so that she doesn't go into the complications what you have put it on the slide, like renal.
So additionally, we will go for a coagulation profile with the fibrinogen D dimer and PT, APTT, INR. Also ultrasound screening for subcapsular hemorrhage in the liver, renal parenchymal changes, and associated ascites or pleural effusion as check. And as you said, we will deliver following corticosteroids, and you continue
magnesium sulfate
and also you terminate. And you said, like rightly said, you have to repeat this LFT and platelet count every 12 hours. And during the delivery, this platelet count should be maintained for vaginal delivery at least more than 40,000.
40,000.
Yeah, and for instrumental delivery and the cesarean section, it should be more than 50,000. And if you are planning for epidural analgesia or spinal anesthesia, it should be more than 70,000. But if it is less than that, you go for the general anesthesia.
Transfusion.
Yeah, general anesthesia. And before that, you can bring this platelet count to this value by platelet transfusion, or this single donor platelet will be ideal.
Yes,
if it is available.
Please conclude.
Yes, ma'am. We had a wonderful discussion and by the panelists, and I think we have covered most of the treatment part. And madam, you want to add anything? Any panelist or Sambat Kumari, madam, you want to add any points, ma'am?
No, only BP monitoring is very, very important. That's all. Other than that, nothing. We have 2 more panels that has to be discussed.
Yes, ma'am.
Thank you,
Thank you, Sambat Kumari, ma'am.
Wonderful panel discussion, ma'am.
Ma'am, only thing the community setup should be strengthened well.
Yes.
So I think we need to work on it, ma'am.
Hello, madam.
Thank you, ma'am.
Yeah.
Thank you everyone, all the panelists
Thank you
and
for
chairpersons for the wonderful discussion on hypertension in pregnancy, which is the most commonly encountered problem. We move on to the again one more important topic, another panel discussion on gestational diabetes mellitus.
Shruti, can you introduce the
ma'am.
moderator and the panel
Yes.
with their 5 minutes?
Yes, ma'am. Okay, ma'am.
Because let them have the discussions.
Yes, ma'am. Yeah, we have the moderators, Dr. Geetanjali and Dr. Suguna ma'am, very active Kasoga members, and experts would be Dr. Suman Gaddi madam. Can we have their introduction? Yes, Dr. Geetanjali Katkeri, she is a professor in Nijlingappa Medical College, Bagalkot, chairperson and in Clinical Research Committee, Kasoga, and she is involved in many WHO research projects, and she has many publications and presentations to her credit in national and international forums. We welcome you, ma'am. Dr. Suguna ma'am, she is a consultant Suguna Maternity Hospital, Vijaypur, and also she was a professor at Alamin Medical College, Vijaypur. She was past president Bijapur OBGYN Society. She was EC member at Kasoga in 2018-20, and right now she is scientific chairperson, State Conference Kasoga, Vijaypur. She is also faculty at various national and international conferences, and her field of interest is high-risk pregnancy and antenatal ultrasound. Dr. Suman Gaddi, madam, the expert for the panel. She is professor and HOD at WIMS Ballari. Again, she has many publications to her credit and presentations at national and state conferences. Organizing chairman of Kasoga 2019, and she was also a EC member Kasoga. Right now, she is the treasurer of Kasoga. We welcome you, ma'am.
Thank you. Thank you.
Thank you.
We welcome all the panelists. To begin with Dr. Meenakshi Devanmani ma'am. She is Professor, Unit Chief, Department of OBG, Mahadevappa Medical College, Kalburgi, and she is member of PCO, Menopause Society, IMA, and she is an experienced undergraduate and postgraduate teacher, and she was the president and treasurer of Kalburgi OBGYN Society, and also organizing secretary for Kasoga 2014. We welcome you, ma'am. Dr. Shobha Shavi, ma'am. She is a consultant Sanjeevani Hospital, Bagalkot, and she is also presented papers and posters in various national and international conferences. She is presently secretary of Bagalkot OBGYN Society, and she has won Mishra Prize at AICOG Lucknow, and also she has conducted many awareness programs, including cancer screening camps and anemia detection camps. Her areas of interest are critical care, obstetrics, recurrent pregnancy, loss, fetal medicine, NDVH. Welcome you, ma'am, Shobha, ma'am. Dr. S. Karpagam, madam. She is undergraduate from Stanley Medical College and postgraduate from the same. She is she was assistant professor and like in various, now she is under postgraduate teacher and guide. She is level 7. Okay, ma'am. We welcome Karpagam, ma'am. Dr. Kartika Prabhu, madam. She is professor, SRM Medical College Hospital Research Center, Potteri. She is both undergraduate and postgraduate teacher. She has won awards, Dr. A.V. Umuchigai Memorial Gold Medal, Asha Bakshi Award at the annual conference AIC RCOG 2016, and paper presentation prize at UA Foxy South 2011. She's also received a gold medal Research Day SRM 2020, and she has many publications for her credit. Welcome you, ma'am. Dr. Supriya Tile, she is presently Associate Professor, ESI Medical College, Kalburgi, and also she has won awards, second prize paper presentation at ICOG Foxy International Conference, third prize for paper presentation at Kasoga State Conference 2016. She is Executive Committee member for Reproductive Endocrine Committee, Kasoga 23. Welcome you, ma'am. Over to you, Suguna ma'am and Geetanjali ma'am.
Yes. Yes. Good afternoon, everyone. I think you can hear me. You can hear me?
Yes, ma'am. Go on.
Yeah.
You can share your slides, ma'am.
Slide. Dr. Geetanjali, please share the slide. At the outset, I thank the Tamil Nadu and the Karnataka OBG Society for inviting us for this panel discussion. Today, the panel discussion is on the diabetes, gestational diabetes mellitus. So our expert, we know Suman Gaddi, and my co-moderator is Geetanjali Katgeri. And I welcome all the panelists for this discussion. Next slide, please. So you all know that diabetes is, next slide, is diabetoketogenic. And the definition of diabetes, gestational diabetes is defined as any degree of impaired glucose tolerance with the onset or first recognition during pregnancy. And glucose metabolism in pregnancy, because of the insulin sensitivity, which is decreased and which is very progressive after 24 weeks of pregnancy, as well as because of the hormones of the placenta, like the HPL, placental growth hormone variant, cortisol, prolactin, estrogen, progesterone, there is increased insulin resistance and there is hyperglycemia of pregnancy. Next slide, please. Now, diabetes in the pregnancy is classified as the pre-existing diabetes, which can be type 1 and type 2, and the gestational diabetes, which can be diagnosed newly detected, or the true gestational diabetes mellitus, GDM. Next slide. Next slide, please.
Dr. Supriya, can I please request you to tell us whom do we screen? Are there any risk factors? How do we, make best use of our screening strategies?
Yes, ma'am. When we are screening, depending upon the risk factors, the main factors which we include as high risk, mainly the first and foremost would be the obesity, where the BMI of the patient is more than 25, and also previous history of gestational diabetes mellitus in the previous pregnancies, or there is a strong family history of diabetes mellitus in the family, particularly the type 2 diabetes, or the patient had a history of polycystic ovarian syndrome and conceived on infertility treatment, and patients with pre-existing impaired glucose tolerance test, and these will be the risk factors mainly, and especially we as Indians belonging to the Southeast Asian region, we are ethnically predisposed to be at a higher risk for gestational diabetes mellitus. So these all the risk factors we should be considered as high risk for gestational diabetes mellitus.
Yes, so that you make a very important point that even though there are several risk factors listed, we as an entire country fall under one of the high risk, and that is because of our race. And 50% of GDM cases actually do not even have any known risk factors. So it is good that our recommendations are that we screen everybody universally in India. So can you please tell us about the screening strategies? What do we use and how do we actually go about the test?
Yes, as you said that we belong to a high risk because of our racial predisposition and ethnic predisposition. We follow a universal screening method for the universal screening. That means we screen all the pregnant women for glucose intolerance at the first antenatal visit. As soon as the patient visits the antenatal care unit, we test her for impaired glucose tolerance, and if the screen is negative, then we go for the second testing at 24 to 28 weeks. We can follow a one-step method or a two-step method, but most of the guidelines like the IDPSG and the DIPSI guidelines and even the FOXI and WHO recommends two-step that is single-step method, that is 75 gram 2-hour glucose tolerance test, wherein we take the fasting blood sample after an overnight fasting of 8 hours, and then the patient is given a glucose load of 75 grams dissolved in 300 ml of water, and then the serial blood samples are drawn at 1 hour, 2 hours, and 1 hour and 2 hours.
So can you tell us about the more widely used test, and that is the one which is recommended, and that is the DIPSI guidelines? How is it done?
So in the DIPSI guidelines, here we do it as a single step where we do not want the patient to come fasting. So irrespective of the timing of a last meal, the patient is given a glucose load of 75 gram glucose, and then a blood sample is drawn after an interval of 2 hours. So this is more feasible and economically more relevant. And since it has been tested mainly on our Indian population, this becomes more appropriate for our Indian population. So DIPSI is the most commonly followed in our country. So here, yes.
Yes, ma'am, please continue.
So here after the 2-hour glucose challenge, the cutoff taken is 140. So any value above value of 140 or above is considered to be gestational diabetes mellitus.
Yes. And any value above 200 would be considered to be as pre-existing, and unfortunately we were not able to screen it at that time. And we also have another category, and that is in whom the glucose tolerance is impaired, and that is 120 to 140. And this sort of fits in with the HAPO study findings, which says that there is no absolute cutoff beyond which the outcomes are really bad. So anything which is raised above the normal would be considered as a risk factor for having the adverse outcomes of diabetes. And though these women are not labeled as diabetes, they would still be at all the risk for patient with diabetes and would need to be monitored for the same. And as you said, we definitely have guidelines for India because we have such a high prevalence of India, and depending on which part of the country we are in, there are variations, but it is definitely a big, our population is 11 times more at risk than the rest of the Caucasian population. Suguna ma'am?
Yes. Next slide, please. Okay, there's a case, Shudhara. A 25-year-old primate with BMI of 29.6 kg per meter undergoes the DIPSI test and at 25 weeks of pregnancy, and the value is 168 milligram per deciliter. Dr. Karthika, can you tell what is your inference about this?
The DIPSI test value is 168 milligram per deciliter. So value more than 140 milligram per deciliter will be considered as gestational diabetes. So she is having gestational diabetes. She's also having a risk factor of overweight. Her BMI is 29.6 kilogram per meter square.
Yes. Oh, what are the complications of this GDM in the mother and the fetus?
So the complications of GDM for the mother, she can have preterm delivery, recurrent urinary tract infections. She can have she's more at risk of developing preeclampsia, polyhydramnias, increased incidence of cesarean section, and there is also at the time of labor, she can have uterine, that is after delivery, she is at risk of having postpartum hemorrhage because of atonicity. And for the fetal complications, so sudden intrauterine death, stillbirth is common, and baby can be macrosomic, so she will be at risk of having shoulder dystocia. So this in turn can lead on to birth injuries. And in the immediate newborn period, the baby can have respiratory distress syndrome, which is also more predisposed to have neonatal hypoglycemia, hyperbilirubinemia, and hypocalcemia, and so on.
And the long-term side effect of this GDM?
So both mother and the fetus are at risk of long-term complication. So mother is at risk of developing diabetes later, and the fetus is also at risk of developing obesity, childhood obesity, and in turn it can also develop diabetes later. And especially
and also cardiovascular disease.
Cardiovascular disease, especially if she is a female child is at risk of developing gestational diabetes in the next
week, which is also common. Okay. The second case is 36-year-old Gravida 3 para 2 living 2 comes with urinary tract infection at 16 weeks of pregnancy with high-grade fever. Her urine protein test shows 2+ sugar, and her sugar is 226 milligram per deciliter. She doesn't have any diagnosis of GDM in the previous 2 pregnancy. Can I ask Dr. Karthika, what is the inference here? Karthika?
Yeah, ma'am. Actually, her sugar value is more than 200 milligram per deciliter. So that means she is already a case of a pre-existing diabetes. So any value more than 200 milligram per deciliter will be overt diabetic pregnancy.
And another pointer in this case is that at 16 weeks itself, she is having high blood sugar. So it's unlikely to be because of pregnancy. Most probably she is pre-existing diabetes, which was not detected before.
Earlier.
And Dr. Karthika, can you tell how this lady's condition is different from the previous case? What complications are expected more in this case?
The risk of congenital anomalies in the newborn is more common, and the patient can have vasculopathies. So baby can hypertension incidence is also more with this patient when compared to that of gestational diabetes. So intrauterine growth restriction may be one of the anticipated complication, and development of retinopathy and nephropathy. Those risks associated with pregnancy is also more common in this. And in the present scenario also, she gives history of recurrent urinary tract infection. So that is also one of the important complication which will be associated with overt diabetes.
And these women can actually even present with right in the beginning with diabetic ketoacidosis.
Yeah.
And because they were never diagnosed to be diabetic, that could be one of the diagnoses which you don't think of. So somebody coming with vomiting, pain abdomen, tachycardia, all these things, we may attribute it to so many other different complications in pregnancy, and we overlook diabetic ketoacidosis. So that's another thing which we need to keep in mind. Yes, ma'am.
Hello.
Yes, ma'am. Sugana, ma'am, we can hear you.
Can you hear me?
Yes,
Shall
ma'am.
I call upon Dr. Karpaga? Please tell, if this patient was diagnosed before pregnancy, what will be the preconception counseling you will do for her?
So we have most important is preconception counseling. The blood sugar has to be controlled. Her A1C should be less than 6. Till then, if it is more than 10, she is strongly advised against pregnancy itself, because the congenital anomalies will be very high. So planning is very important, and also she should be advised to take folic acid to prevent neural tube defects, and of course her maintenance of her weight and diet. So dietary plan and medications should be prescribed for her, and she should maintain euglycemia before proceeding with the pregnancy. Yes, ma'am.
Yes, ma'am. You are very correctly told about how we should counsel these women. So if diabetes is known before pregnancy, we should bring her to the optimum state of health before we plan a pregnancy, because definitely pregnancy will take a much greater toll on her health. All her diabetic complications will increase, and also we do not want the fetus to have any risk of having congenital anomalies. Any medications that she is on before the pregnancy should be switched, preferably to the ones which are acceptable during pregnancy. That could be another consideration. And also, because this patient is now outright at a risk for having preeclampsia, we need to know that during the pregnancy, she should be also put on aspirin prophylaxis.
And also folic acid prophylaxis.
Yes.
Yes. And the pre-existing retinopathy and nephropathy has to be ruled out, because she may be having some on drugs which should not be continued in pregnancy if she is on nephropathy.
And as Dr. Karthika correctly pointed out, a patient who is having vasculopathy already is now in fact at a high risk of developing a growth restricted fetus rather than having a macrosomic fetus. So that's another thing that we should be monitoring during pregnancy, and seeing that before the pregnancy, we bring her to the optimal health. Thank you, Dr. Karpagam. Can I call Dr. Shobha to ask about now we have got 2 patients. We've got one case who was gestational diabetes, another case who is most likely a case of pre-existing diabetes. So what would be our main management strategies in these kind of patients?
In a case of gestational diabetes mellitus, I can suggest lifestyle changes like physical exercise and medical nutrition therapy. and monitor her sugars. And if there is a very good response to these two measures, I can continue with that with the regular blood sugar monitoring. If there is no control of blood sugar with medical nutrition therapy and physical exercise, I would like to start her on oral hypoglycemic agents. And again, monitor them closely if they're well controlled or not, both with blood sugars and also with scan, looking for polyhydramnios and the AP measurements. And if it is well controlled, continue with the same. And if it is not controlled, switch over to insulin. But in a case of diabetic, maybe her blood sugars are already very high and she might directly need, she may be already on oral anti-hypoglycemic agents, oral hypoglycemic agents. So if she's on oral hypoglycemic agents, we should see to that they're safe for the baby. They don't cross the placenta and cause hypoglycemia in the baby, and better to switch over to glycomet or glyburide, which are acceptable in pregnancy, and monitor blood sugars carefully. If they're not controlled with that, it is better to shift to insulin. Any patient who is shifted to insulin should know how to monitor their blood sugars and how to manage hypoglycemia. They should be told about the signs and symptoms of hypoglycemia and its treatment. And they should also be told about fetal monitoring, which needs frequent ultrasound measurements compared to normal pregnancies. And the delivery should be planned properly in these patients, depending on their blood sugar levels and also associated complications like preeclampsia or any other renal issues or any other associated complications of over diabetes. Mainly, diabetes patients need a multidisciplinary approach compared to GM patients.
Correct. Yes, ma'am. So, ma'am, you have correctly highlighted that not only will we get the blood sugars under control, we also need to see that the maternal well-being is maintained and also that the fetus is not going into the complications that we want to avoid in this pregnancy. And of course, we have to ultimately plan for the most eventful part of the journey, and that is the delivery. So, we will discuss about all these points in detail.
Excuse me, Geetanjali, can you decrease the size of the screen? The whole screen is not visible. It is zoomed actually.
Ma'am, this is full screen for me, ma'am.
Yeah, for me it is zoomed. That's why I cannot see the screen full. Okay, next. Dr. Meenakshi, can you tell about the medical nutritional therapy?
Yes, madam. So once we diagnose a patient with GDM, first 2 weeks we try with the medical nutrition therapy. 75 to 80% of women with GDM, they achieve the normoglycemia with MNT and exercise. So the main goal of this MNT is to optimum nutrition of the mother and the fetal health. And we should at the same time achieve euglycemia and prevent the complications of GDM like macrosomia. So we should ask the patient for a proper diet and exercise plan. Exercise is at least 30 to 60 minutes per day, 5 days in a week. They have to go for moderate exercise. Walking is the best exercise. They can also go for moderate cardio, where they can be seated on a chair and they can use little weightlifting by the using the upper limbs. And also, the exercise should be of such moderate this thing that the patient should be able to talk comfortably with the others when they are, and their cardia should go for around 60 to 80% of which is recommended for that this thing. And along with that, swimming and cycling are also advised. They are also safe. Exercise is mainly contraindicated in those patients with vasculopathy with severe preeclampsia or a case of placenta previa. Otherwise, routinely, we can advise exercise for all the GDM cases so that it will bring the sugars under control, so that it will increase the insulin sensitivity at the muscular peripheral level and maintain the optimum blood glucose level, and so that we can prevent the complications. And as far as diet is concerned, we have to restrict the diet. The calorie distribution is very important. So this is depending upon the BMI of the patient. For underweight BMI, which is less than 18.5, we recommend a calorie requirement of 35 kilocalories per kg per day. And for those with a normal BMI, we can recommend 30 kilocalories per kg per day. And those overweight, more than from 25 to 29.9, we recommend around 22 to 25 kilocalories per kg per day. And for the morbidly obese, that is more than 40 kg per square meter, we advise 12 to 14 kilocalories. And this calorie distribution also is very important. 45% of the diet should contain carbohydrates and 30% should be proteins and around 25% the unsaturated fats. So, and the meal has to be divided into 3 major meals and 3 minor or meals, or like 2 to 4 snacks. And at each major meal, 2 to 3 servings of carbohydrates is recommended. So 1 serving of carbohydrate is around 15 grams of carbohydrate, which is going to give around 60 calories to the patient. And so in a major meal, we are including around 3 servings of carbohydrate, while in a minor, for a snack, it will be 1 to 2 servings. And it's very important, the carbohydrates, what we have to advise. It is a complex carbohydrate which have a low glycemic index. So the low glycemic index is the one where the glycemic index is less than 55. So the complex carbohydrates like the wheat, jawar, oats, bajra, and we can advise them to have nuts and also the high fiber consumption, so that this will delay the postprandial blood sugar, so which is going to cause the complications. And we have to ask them to avoid those which are having high glycemic index, like the cake, pastries, bread, and the juices, and the fruits which are like the watermelon, pineapple, potatoes. All these have to be avoided by the patient. So a diabetic plate should be containing, half the plate should be consisting of the starchy fibrous vegetables, and 1/4 of the plate should be of proteins, and 1/4 of the plate should contain the carbohydrates. So this is how we have to advise the patient. And also the weight gain has to be restricted. So the weight gain for a obese who is more than 30 BMI, we advise only 5 to 9 kgs, so that when we restrict both the things, we can have a better glycemic control. So our main goal of the MNT will be to maintain a mean blood glucose level of 100 milligrams per deciliter. The fasting should never go above 95, and the postprandial 2 hours should not go for 120. So this is tried for a period of 2 weeks. So then again we repeat the postprandial. So if it is well controlled, less than 120 milligrams per deciliter, we advise the patient to continue on the MNT. If it is then
shall we take it as a summary, ma'am? Yes. We'll take it as a summary. So as you very correctly said, our goal is to see that the overweight women consume less calories. This is sometimes a challenge when we want to prevent ketonuria, because there could be ketonuria because of the restriction of calories too much. Fasting ketonuria can occur. And the other thing, as you said, is about how our plate should be. So recently I was part of another discussion where it was told that this North Karnataka Halli Ota that we have, the kind of food that we have in our villages, in our part of the world, is actually the ideal kind of diet that anybody would recommend. Because here the possibility of having GDM, actually, if you see across the country, it varies, maybe like from 4% to about 16% the incidence is. And our part of the world, actually, our part of the country, the rural North Karnataka villages have got the least incidence of gestational diabetes. And that could be because by default, the population here consumes this kind of, the very ideal kind of meal that we would recommend in diabetes. So thank you, ma'am, for that good summary of what should be done in MNT. Dr. Supriya. Yes. Dr. Supriya, can you please summarize according to this chart? So this is from the National Health Mission guidelines for management of GDM. So can you please summarize
Yes,
how we should go about it here?
So whenever a woman is diagnosed with gestational diabetes mellitus on either the screening test, whichever we use, the first step in the management would be to start the patient on a medical nutritional therapy. That means counseling the patient for dietary modifications as well as the physical activity, which has been told as earlier. And the patient has to be followed these measures for at least 2 weeks. And after a period of 2 weeks, we again check the patient's fasting blood blood sugar levels and 2 hours postprandial sugar levels after the 2 hours after the breakfast, 2 hours after lunch, and 2 hours post dinner. So if the patient, all the values are within normal limits, that is, they are within the target values of the sugars. That means the fasting is less than 95 and the postprandial sugars, 2 hours postprandials are less than 120. The patient can be advised to continue the medical nutrition therapy with the regular monitoring of the blood sugar values. If the fasting blood sugar value or the postprandial values are well above the target values, that is fasting more than 95 and postprandials more than 120, then we change over to the next step of management, that is the pharmacological therapy, where depending upon the patient's blood sugar level, we either start with insulin or with the oral hypoglycemic agents like metformin or glyburide. And again, the patient has to be monitoring her blood sugar levels to achieve an optimal response.
Thank you, ma'am, for that nice summary. So what is important to remember that is in diabetes, it is basically the postprandial blood sugar which is predominantly high. If we have more of fasting blood sugars which are high, then we could think either that this patient is at very high risk of developing, having a persistent diabetes following the delivery, or she may be having even a pre-gestational diabetes. So postprandial blood sugar, especially when we're talking about monitoring at mass level and using it as guidelines for the country. So postprandial blood sugars are the ones which are taken as the cutoff, and 120, less than 120 is considered to be controlled, and more than 120, we have to go for another line of management. Subhana ma'am?
Yeah. So can Dr. Karthika explain what is the criteria to start insulin and medical line of management? Actually, it was told.
Yeah, is actually fasting blood sugar. If it is the target is fasting blood sugar should be less than 90 milligram per deciliter, and 2 hour postprandial value should be less than 120 milligram per deciliter. So if it is more than that, we have to, after 2 weeks of medical nutrition therapy, we have to start on pharmacological therapy. So either patient's compliance, it depends upon the patient's compliance, blood sugar values, and other coexisting conditions. Ideally, if the blood sugar values are high before 20 weeks, it is better to start insulin. So after 20 weeks, if the sugars are only slightly elevated, we can start them on metformin. And if it is not under control, then we can switch over to insulin. And if the sugars are well under control, we have to monitor the blood sugar levels once a month up to 28 weeks, then once in 2 weeks from 28 to 32 weeks, and once a week after 32 weeks, till the blood sugar levels are getting controlled. Suppose we are starting them on insulin, we have to repeat the sugars once in 3 days till the blood sugar levels are getting under control, coming under the target range.
And at least 4 times a day, self-monitoring of the blood sugar is recommended. 1 fasting and 3 postprandial. Dr. Shobha, we have been discussing about metformin and glyburide. Can you tell us what is the role of this oral hypoglycemic? Would we call them as oral hypoglycemic agents, or would they be better termed as anti-hyperglycemic drugs? Because though we use metformin right and left, they don't actually cause hypoglycemia, rather they would prevent hyperglycemia. So what is the role of these anti-hyperglycemic drugs in GDM?
In actual GDM patients, when medical nutrition therapy and physical exercise fail, the lifestyle changes, they fail to maintain the blood sugars, we first start them on anti-hyperglycemic agents. The most common being metformin, but glyburide or glibenclamide is also a drug we can really use. Glyburide is one of the first class of anti-hypoglycemic agents which was used, but we hardly use it, maybe because we are not very familiar with it. When used properly, only 20% of the patients will require additional insulin with this. The advantage is it doesn't cross placenta and outcomes are comparable with that of insulin. We can start with a dose of 2.5 milligrams per day and gradually increase depending upon the blood sugar control. The maximum dose that can be given is 20 mg per day. The next drug is metformin that we are using very commonly and all of us are very comfortable using with. Most 46% of the patients on metformin require insulin in the continuation of pregnancy. Though it crosses placenta, it doesn't cause neonatal hypoglycemia. and the outcomes are similar with insulin, but there is increased risk of preterm birth. Usually we start with a dose of 500 mg per day, the maximum dose being 2 to 2.5 grams divided over the day.
Yes, ma'am. Thank you for the very nice summary. So even patients were asked, patients who are on insulin and patients who are on drugs, would you prefer this kind of treatment in the subsequent pregnancy? So majority of the patients who were only on the oral drugs said that yes, they want this, and the ones who are on insulin said that no, they would prefer to have an oral drug. So maybe these are very attractive options for us to offer our patients. And most of these drugs are not used, as you said, because they cross the placenta and cause neonatal hypoglycemia. But glyburide and metformin are the ones which can be used during pregnancy, and majority of them will be sufficient to control the diabetes just by themselves. Very few of them will require insulin.
Madam, can I add one point?
Sure, ma'am.
Also, the MIG trial has showed by using the metformin, it will reduce the dose of the insulin which is required, and also it gives the maternal weight gain in control.
Yes.
And also thus it helps in preventing macrosomia, neonatal hypoglycemia.
Yes.
So metformin is better than glyburide. Glyburide is not able to reduce the neonatal hypoglycemia, but with metformin, it will help in a reduction of episodes of neonatal hypoglycemia also.
Okay, ma'am. And also because since we already have many patients who are on metformin before conception, like if they're coming to us for PCOS, then this drug can very well be continued into pregnancy and we get good outcomes with it.
In my hospital, madam, mostly 80% of GDM patients are managed with metformin only. Very few of them require insulin.
Yes, ma'am.
And
In fact, majority of them, yes, even medical nutrition therapy also may be sufficient for many, and oral hypoglycemics or anti-hypoglycemics.
Can you highlight on the insulin therapy?
Yes, madam. Always human insulin or analogs are used. Long-acting, intermediate-acting insulin are used. Short-acting are used mostly for postprandial control. Types of insulin are intermediate-acting, NPH, category B. Detimer, long-acting, category B. Lispro, also ultra-short-acting is category B. And Glargine Lantus is long-acting, belonging to category C. And the insulin dosing, 15% require insulin. Total dose usually ranges from 0.7 to 2 units per kg. And the starting dose usually is 0.7 up to 18 weeks. Then 18 to 26 weeks, it is 0.8 unit per kg. 0.9 unit per kg, 26 to 36. 1 unit for 36 weeks. In morbidly obese individuals, the doses required may be 1.5 to 2 units per kg. Traditionally, 2 injections per day of pre-mixed insulin, regular and NPH is given, 2/3 in the morning and 1/3 at night. Of each dose, 1/3 rapid and 2/3 intermediate acting, and it should be monitored with fasting and postprandial titer based on the response.
Yes, ma'am.
So whether you want to manage or you want to take a diabetologist opinion or endocrinologist opinion?
Definitely, madam. We require the help of our diabetologist in monitoring and treating these patients. The alternative physiological insulin dosing is also there. The total daily requirement of insulin is divided into 50% basal. The 50% basal is given. Yes, madam. Shall I continue?
Usually you use the mixed insulin with 30 and 70 combination form.
Yes.
That is the ideal insulin which has to be used.
Yes, madam. 50% bolus is divided into the 3 meals. So the basal insulin monitor mainly it is to control the bedtime insulin is to control the fasting blood sugar. If the average fasting blood sugar is more than 90, then we have to increase the basal insulin by 2 to 4 units. Similarly, for the postprandial control, we monitor 1 or 2 hours postprandial. So average 2 hour postprandial more than 120 and 1 hour more than 140, we have to again adjust the post insulin by 2 to 4 units and not more than 2 to 4. It is usually maintained within 2 to 4 units. So preferred regimen is 1 dose of basal insulin and 3 long acting and 3 doses of short acting. Gives physiological insulin control levels.
Yes, the argument against the 2 doses where there's 1/3 and 2/3 distribution as we used to traditionally use is that it doesn't mimic the physiological release of insulin in the body. So perhaps this is a better one where there is a basal insulin, which is long acting, can act for about 24 hours after one dose, and 3 short doses, 3 doses of short acting or ultra short acting insulin, just to cover the postprandial blood sugar rise after each meal. And again, to highlight that in GDM, exclusive GDM not pre-existing, the most predominant rise is postprandial. So this would give a better control of glucose than the one which we use traditionally.
And in type 1, fasting hypoglycemia is also more common. That's why you have to monitor the blood sugar at 3 a.m. to adjust the dose of the insulin.
Madam, one point, in those patients on insulin, it is the 7-point program blood sugar monitoring is better.
Yes, ma'am. If they are pre-existing,
to adjust the dose, you cannot keep on poking the patient.
If they are pre-existing, they are prone for both fasting hyperglycemia and postprandial hyperglycemia. Whereas if they are more of pregnancy-induced, then it is more likely that they have high rise of postprandial blood sugars. And fasting maybe once a day and postprandial thrice a day also would be enough for these kind of patients.
Dr. Subuna, 5 more minutes, Dr. Subuna.
Yes.
Yes. Next one. Dr. Karthika, can you tell about the fetal monitoring in diabetic patients?
The fetal monitoring will start from, in a case of, starts from the NT scan with the first trimester screening. Then at 18 to 20 weeks, a detailed target scan is very important because the overt diabetes mellitus can cause congenital anomalies. Then the diabetes which is diagnosed before 20 weeks, it is ideal to do a fetal echo because cardiac anomalies are more common. And from 26 weeks onwards, every 3 weeks, it is better to do a scan for the fetal growth and for the amniotic fluid LICA. And further, antepartum fetal surveillance also should be started, starting from 32 weeks onwards with a biophysical profile and or modified biophysical profile using NST and AFI alone.
Yes, the NT scan itself will rule out the CNS and the CVS anomaly, which is more common in the diabetes. And of course, echocardiogram is also advised after 24 weeks because that is more common in uncontrolled patients. Next
and
slide,
sometimes
please.
on a serial scans, just the abdominal circumference itself going much ahead of what is expected could be an indication that high sugars are there and could require peripheral insulin.
So we can predict macrosomia in these patients, madam.
Yes, yes.
Yes.
So Dr. Supriya, can you please tell us, like there's a patient now, a second patient who was diagnosed at 16 weeks. She comes at 33 weeks of gestation with the uterine contractions, painful uterine contractions, and you've diagnosed her to have threatened preterm. So should you give steroids and what are the concerns with steroids in these patients?
Steroids should be given, ma'am. It is recommended to give steroids because of the risk of preterm labor and also because these patients with the diabetes mellitus are because of the hyperinsulinemia in the fetus. There is an increased risk of having respiratory distress because of the poor delayed development of the lungs because of the deficiency of the surfactants. So the recommendation is to give these steroids. However, these steroids are known to have an effect on the blood sugars. They are known to cause further impairment of the blood sugar level. So these patients should be kept on a strict monitoring of the blood sugar levels.
And not only
insulin dose.
Yes. Either people who are not on insulin might require insulin or might require increased dose. And this might go even up to maybe a week or more also. So it's not only at the time when the drug is being given, we need to monitor them even beyond that.
Well, at least 3 days beyond you have to monitor.
Madam, sorry to interrupt, ma'am.
Yes.
Another 3 minutes, ma'am.
Yes, ma'am. Yes, ma'am. We're done.
Please wind up. Thank you so much.
Dr. Karpagam, can you tell me about the intrapartum monitoring of the patients?
Yes, madam. So intrapartum monitoring usually in medical nutrition therapy does not require any additional treatment. But if she is on insulin, the morning dose of insulin has to be skipped. There is no place for oral or hypoglycemic agents. Usually no insulin is required during labor. Her blood sugar should be maintained by 70 to 110 milligram per deciliter. Monitor 2 to 4 hourly in the latent phase and 1 to 2 hourly in the active phase of labor. Then suppose the blood sugar is low, less than 70, then we may have to start dextrose infusion, and dextrose with 5 units of insulin and 500 ml of dextrose at 125 ml per hour, and it has to be titrated. All throughout, we have to maintain this value of 100 to 110 throughout labor. So if it is poorly controlled, if the blood maternal hyperglycemia is high, we may face neonatal hypoglycemia. With the GDM, we should be always alert, and we should alert our team because we may anticipate CPD because of the increased shoulder dystocia. So operative delivery and trauma is high. So we have to alert the theater anesthetist and the neonatologist regarding the delivery of a GDM mother or a diabetes mother.
And it's better to go for a planned cesarean section if the baby weight is more than 4 kg.
More than 4 kg, yes, madam. Because of the bisacromial diameter will be high, madam. Yes, ma'am.
Just a word about the timing of the planned delivery. There is no clear consensus. Some people say that we can go even up to 40 weeks if it's well controlled. But if it's controlled, some others say that it is controlled with insulin, then terminate at 38 weeks. And if it's poorly controlled, of course, there will be an individualized decision. In the interest of time, madam, shall we go to the management beyond delivery? Dr. Meenakshi?
Yes.
Can you please tell us about what complications these women are prone for?
So this postpartum, once the delivery is occurred after 6 weeks, we have to. Hello.
Yes, ma'am. Yes,
Can
ma'am.
you hear me?
Yes.
Postpartum, 50% of this GDM patient will develop overt diabetes within the next 5 to 10 years. So in the next pregnancy, it depends again, the recurrence rate is around 40%. And especially those where there is early onset of GDM and those obese patients, the recurrence rate is more. And those patients with stillbirth and those patients with macrosomia, again, these are more on those who needed insulin during this pregnancy, they are more prone for recurrence in the next pregnancies. And these patients postpartum, if it is a normal delivery, if they are pre-gestational, we have to reduce the dose of insulin. And then if we have to monitor the blood glucose levels once we start them on proper diet, and then accordingly we have to give their dosage. And in the postpartum, after 6 weeks, we have to repeat the OGTT, 2-hour OGTT, and then we have to decide whether what modality of treatment we have to do. And further on, we have to monitor them every 3 years. We have to offer them OGTT, and so that we should help in preventing. And also we have to tell them about the lifestyle modification, weight reduction, exercise, and diet, so that they can postpone their onset of the type 2 diabetes. And regarding the contraceptions, these, can I tell about contraception, ma'am?
Yes, okay, ma'am.
So regarding contraception, barrier method of contraception is ideal for them. And we can also offer them low dose OC pills, provided they are not, they are non-smokers and they don't have any vasculopathy. And regarding the IUDs, yes, there is a chance of infection, but there is controversy. But the WHO has recommended that we can safely offer them the IUDs, which are for if they are planning for long-term family planning this thing. And the progesterone only pill is the next alternative. And if they have completed their family, we can offer them female sterilization. Better again, also we can counsel the male partner to go for vasectomy. And emergency contraceptives, yes, they can be used in all the patients, even the patients with vasculopathy, they are safe. So this is regarding the contraception in the patients with GDM and pre-gestational diabetes.
Okay, thank you. Ma'am, shall we go on to the take-home messages? So just before we conclude, so there are some very important things that we are perhaps doing wrong, and we need to improve on how we practice generally. So the incidence of GDM is much more than we appreciate, and it is important to screen each and every woman. RBS that we do as a routine for every patient is not enough. We should go with the DIPSI guidelines, which is very much feasible even at an outpatient visit. Maternal nutrition therapy and exercise will be enough to manage almost 80% cases of GDM if properly employed. So at least 2 weeks of MNT and exercise. And oral medications can be tried before resorting to insulin. we may be able to manage majority of them with only oral medications. And very, very importantly, 50% of women with GDM will develop overt diabetes within about 5 years. And their babies are also at risk for obesity and future diabetes. So we have a whole big population now which is at risk, and we can do something to see that they either postpone the fact that they develop diabetes, or also perhaps if don't even develop it, if they do appropriate lifestyle modifications, including the diet, exercise, weight loss, etc., so as to preempt the development of diabetes in these women and babies.
So I will wind up.
Suman Reddy, madam, can you put some points?
So I really congratulate the moderators, Dr. Geetanjali and Dr. Sugana, for carrying out this wonderful, elaborate panel on GDM, along with the panelists, Dr. Meenakshi, Dr. Shobha, Dr. Karpagan, Dr. Karthika, and Dr. Supriya. Of course, you all did a wonderful job. And we say that the child is the father of nation, and the mother is the designer of child. That is the intrauterine programming of the fetus in this mother with GDM leads to obesity, type 2 diabetes in the offspring, affecting future generations. So care of the mother starts preconceptionally only, maintaining desired plasma glucose levels. And in addition, of course, antenatally meticulous maternal and fetal surveillance and prevent complications, appropriate timing of delivery of the mother, and of course not neglecting the post-delivery follow-up with 75 grams of glucose at 6 weeks postpartum to detect diabetes. Of course, GDM is really a challenging situation, and of course, all of you, of course, gave us good take-home messages, and I'm sure all the delegates have made use of this panel discussion. And thanks, very well done, and thanks for this opportunity given by Tamil Nadu OBG Society and the Karnataka Society. Thank you once again.
Thank you, ma'am.
Thank you.
Thank you, ma'am, Dr. Suman, ma'am. And we'll move on to the next panel discussion on rhesus negative pregnancy.
Wonderful GDM discussion, but want of time, we are compelled to close the GDM. Anyway, wonderful.
Thank you.
You call the next panelist.
Okay, ma'am. So I invite the next panelist, moderators who are going to present on rhesus negative pregnancy. So Dr. Selva Priya S. is a consultant obstetrician, fertility and fetal medicine specialist, and director of Spring Fertility Fetogene, Oluguneseri, Nagarkoil, and she is the senior consultant, Department of Reproductive Fetal Medicine, Dr. Jayashekaran Medical Trust Hospital in Nagarkoil, Vice President of Nagarkoil Obstetrics and Gynae Society, Secretary IFS South Tamil Nadu, Chairperson and ECM Ethics and Medical Legal Committee, TNFOG, and Coordinator Foxy South Zone, Cell Member Foxy PCP and DT, President's Task Force Member. Okay, the next, I invite Dr. Anita E., who's an undergraduate from Stanley Medical College. She's done her MD-OG from Madras Medical College, worked as junior consultant at CMC Vellore, and at present she's a senior assistant professor at Tirunelveli Medical College. She has a teaching experience of 16 years, and she has also presented UVA Foxy faculty, and she received Best Service Provider in PPIUC in-session Collector's Award. And she has many published original research articles in international journals. Then the panelists are Dr. Manohar, Associate Professor, Mandya Institute of Medical Sciences, Mandya, presented papers and posters in state and national conferences, and he has various publications in national and international journals. Dr. Dharani Nalasivam, who is a consultant obstetrician and gynecologist, Jai Maruti Hospital, Erode, and she has done her MBBS from Tanjore Medical College and MS from Pondicherry Institute of Medical Sciences, and ultrasound training from Sonoscans, Coimbatore. She is at present the secretary of OG Society in Erode, 13 years of experience in OBG, past treasurer in Erode OG Society. Okay, the next panelist is Dr. Karpagal and fertility specialist. Her special interests are fertility, high risk obs and gynae endoscopy, and she's recipient of AICC RCOG traveling fellowship in gynae endoscopy in 2017, and she's executive committee member in OGC Chennai, peer reviewer for index journals, presented papers and posters in various national, international conferences and won prizes. She's a consultant at Sri Sai Specialty Motherhood and Nova IVF Fertility Chennai. I invite Dr. Shobha Bembelgi, who is a professor and unit chief, KIMS Hubli, ex-CC member, Kasoga, former president and secretary, HTOGS Hubli, MBBS from MRMC Gulbarga, and MD from Gulbarga as well. Involved in many health camps and awareness programs. She's delivered guest lectures and numerous paper presentations and publications. Next is I invite Dr. Geeta D, who is the head of the Department of Obs and Gynae in Dindigul Medical College and Hospital, Dindigul. And she is alumni of Madurai Medical College and has done her MD in Stanley Medical College and presented numerous papers in national conferences, recipient of AL Mudaliar Fellowship Award, past honorary secretary OGC, and member of ISAR, member of IAGE, ASRM, and SOFC. So I welcome all the panelists and the moderators, and can we please start the panel discussion on rhesus-negative pregnancy?
Thank you so much for introducing us and also introducing all our panelists, dear doctor. And good evening, everyone. Hearty welcome to the last session of this day, successful day one of OGCON, TNFOG and KSOG joint effort. Anita, are you here? Anita?
Anita irukala paru.
Anita irukanga madam, she's here.
Selva Priya irukala.
Anita, please unmute yourself and start sharing the screen. I still can't.
Yeah, she's there.
Selva Priya. என்ன ஆச்சு உண்டோ மியூட் ஆயிடுச்சு.
Now mute பண்ணல, it's automatically getting muted. Anita,
unmute. Can you please unmute?
Anita ma'am irukanga ma'am. Yeah, she's there but she's not
Rahiti, நீ ஏதாவது பண்ண முடியுமா பாரு.
We can view her screen actually, Anita's screen.
We can see your screen, ma'am, but it's WhatsApp has been opened, ma'am. Kindly reshare the PPT, ma'am.
Can I do the share? Madam, Amma, shall I share the PPT in the panel group?
Yes, ma'am.
It's already there in the panel group. In the panel group, already the presentation is there.
Sahiti, அதை எடுத்து போட முடியுமா பாரு.
Okay, ma'am. Okay.
Selva Priya, in the meantime, you can ask for your
I can, yes, my demands.
Anita ma'am, please share the PPT in the group, ma'am, so that I can share.
And we can.
There must be certain amount of love and responsibility towards fellow Foxians from South Tamil Nadu. So on behalf of myself and all the candidates from South, I hope and trust that all of you will wholeheartedly support us for the chairpersons. I'm going for medical ethics and medical legal committee. Kalpana is going for infertility. Dr. Jayarani Kamraj, madam, she's going for sexual medicine committee. So support us all equally so that we'll have a very strong representation of South in the national platform, and it will also energize us in so many ways. These meetings will become more and more prominent, and there will be a lot of growth. So I hope our panelists are
Priya, 1 minute. Dr. Bharati Rajshekhar is going for MCD committee.
Yes, I wanted to add from Karnataka.
Karnataka, yes.
So Dr. Bharati
from...
Rajshekhar also, she's contesting for NCD committee.
Yes,
hello, Selva.
Hello, madam. And thank you so much, team KSOG, for teaming up with us. Vidya madam, Rajeshri madam, and Suman madam, thank you so much for doing this wonderful program with TNFOG. So we have divided the next 40 minutes into 4 parts. The first part I'll be handling where we'll be brushing up the basics. And then we are going to have 2 cases with Anita will be dealing. And meanwhile, because we are dealing with we are freshening up with the basics, discussion of the two cases will be a little more easier. And then finally, we'll go to the fetus. So can you go to the next slide, please? When I say about freshening up few basics, I just want to know what is the basic pathophysiology of dealing with the Rh negative pregnancy. Can one of our panelists take it? Can we have it in order? Can Dr. Manohar sir elaborate on what exactly is the pathophysiology in short?
Good evening, ma'am. And
Yes.
the basic pathophysiology, because in iris pregnancy, in Rh negative mother, if she's having a Rh positive fetus, there are a chance of having an IgG antibodies if she's previously sensitized. And these antibodies, IgG antibodies, can cross the fetus, causing a lot of morbidity like hemolytic disease to the newborn, fetal anemia, and eye drops. So it becomes more important for monitoring these sort of patients.
Yes. So that's the basic pathophysiology, Rh negative mother with Rh positive fetus. So the mother is having anti-Rh antibodies. So they are going to have fetal Rh positive red blood cells are going to get hemolyzed. That is the basic thing we are concerned about. So can we go to the next panelist, Dr. Dharni? And yes, the next slide, please. What I would want to ask you is, can we just recollect the basis of isoimmunization? We've been talking a lot. There's a lot of difference when we studied as a student, as a PG, and now as a consultant working with the Rh negative mothers. Can we just recollect the basics of isoimmunization? You can post the next slide, please.
In case of isoimmunization, good morning, good evening, ma'am.
Hello.
When there is a patient with having Rh negative with baby Rh positive, there is a chance of fetal-maternal hemorrhage, which causes isoimmunization. Even a 0.1 ml of blood is enough for isoimmunization in a mother. And there are many reasons why there is fetal-maternal bleed. And the mother, after fetal-maternal bleed, mother will produce antibodies in response to that RBCs from fetuses, and antibodies are generated in the maternal blood, and it stays lifelong.
Yeah. So as PGs or students, it was so difficult to understand about isoimmunization at that point. But now we clearly know that the baby itself is being treated as an alien by the mother, and that the sequences that follows are the ones we are going to handle as consultants. So can I go to Dr. Karpagambal, madam, for the next one? Usually the fetal-maternal hemorrhage is less than 4 ml. What is the estimated fetal-maternal hemorrhage? It says 0.1, which is also responsible for the dramatic sequence. What kind of hemorrhage do you think is going to elicit all the sequence which we think is going to happen in the entire pregnancy? He said 0.1. It starts from as less as 0.1.
Yeah, good afternoon, everyone. There are a lot of we call them trigger incidents or trigger events that can actually lead to fetal-maternal hemorrhage. The volume can be as low as 0.1 ml, as we mentioned, and sometimes the maximum volume that we have.
Next slide, please.
Can be as high as 3 to 4 ml. But what usually happens is the maximum amount that we see, even with the we have the latest flow cytometry testing, is about 4 ml. So what happens? Because the fetal-maternal hemorrhage can happen with a miscarriage, or whenever there is an amniocentesis or a procedure done, even with abdominal trauma, these things can trigger a fetal-maternal hemorrhage. So that the fetal RBCs travel with the maternal circulation, the mother elicits an immune response, and that causes the hemolysis in the baby.
Yes. So whatever dramatic sequence we are talking about in Rh negative pregnancy is something which involves around 0.1 to 4 ml. That's it. But everything happens within that. The next slide, please. I would like to
Can I add, ma'am?
Fortunately, the immune response is only 10 to 15%.
Yeah, that is there. And then we will go to the next part of the basics. Dr. Shobha, madam. So once you see a Rh negative mother, what are the clear sequence of thought process that will follow in your mind? Like you're sitting in your OPD, you're seeing a patient with Rh negative pregnancy. What will be the sequence? The next slide, please.
Yeah, once the mother Rh negative, routinely we'll get the blood grouping, Rh typing done for as usual for all the antenatal mothers. Then if she is a negative, then we'll go for the husband blood grouping. If he is a negative, if the husband's blood group is negative, then it's a normal pregnancy. If he is positive, then we'll have to go for the if positive indirect womb test. to be done. And if he is positive, there are 50% of it depends whether there is a heterozygous or homozygous.
Yes,
50%. If he is a homozygous, the chances are less.
So this is the thought process exactly. We will be first interested in knowing about the husband's blood group, and everything is not over just when he is also negative. Again, heterozygous, homozygous also come into the role, so we need to be careful about it. So let's go into the freshening up. The next one, Dr. Geeta, madam, can you just tell the basics of ICT? We do a ICT for a RH negative pregnancy. What is ICT all about?
Indirect Coombs test is actually detecting the immuno and blocking antibodies. We need to test if the mother is RH negative and her husband is RH positive. During her first antenatal visit, we have to do indirect Coombs test, following which at 28 weeks, and we should see the titer levels. The titer levels should not cross the critical value. Am I audible, ma'am?
So, yes, you are audible. So basically, we are detecting the incomplete IgG antibodies which can cross the placenta. That is the basis of indirect Coombs test. So it's done with Coombs serum and containing antiglobulin antibodies. The next slide, please. So we'll go to Dr. Manohar again. Next slide, please. So if ICT is negative, if it's negative, and what next will be your thought process?
So once the ICT is negative, normally we do an anti-D immunoglobulin 300 microgram will be given at 28 weeks.
Yes.
And we also plan to get, after the delivery, the cord blood will be collected for the direct Coombs test, and also for the blood grouping, RH typing, and bilirubin levels, as well as the hemoglobin. And we arranged blood at the time of the delivery, and normally we keep about 15 to 20 immediate cord clamping has to be done at the time of delivery, and about 15 to 20 centimeters of the cord should be kept, and which has to be wrapped with the warm saline gauze pad, and inform the pediatrician at the time of delivery, and tell it's an RH negative mother and was being delivered, and the baby can be shifted to the NICU.
Yes. So that will be another part of the basics. And next I have the traditional pictures which will demo the direct Coombs test and the indirect Coombs test, which we will pass because there are interesting cases waiting ahead. Can we go to the next slide? Next slide, please. The next one. The next one. Next one. Next one. So we will just do this section of this part because we are talking a lot about direct Coombs test versus the indirect Coombs test. I thought it would be relevant if we read the table which is given here, which will give us a basic idea about what exactly we are trying to do with the ICT. So in direct Coombs test, it's a type of clinical blood test used to detect the antibodies or complementing proteins attached to the red blood cells, whereas in ICT, it's another type of Coombs test used to detect the antibodies produced against the foreign red blood cells. And this detects the antibodies or complement proteins attached to the red blood cells that will detect the antibodies. So in DCT, we use the washed red blood cells, and in indirect Coombs test, we use the serum. And in DCT, it detects the autoimmune hemolytic anemia, and here it's used prior to blood transfusions and in prenatal testing of pregnant women. So that's how we go with the basics of DCT and ICT. Also, we have few slides telling about the basics, which we have already seen in this presentation, so we will not discuss with that. Shall we go to the next one, please? I would, next one. And the next. Yes. So, Dr. Darli, madam, what do you think will be the anti-D prophylaxis? Just like that, in one single line. Anti-D prophylaxis for whom? And when will you give it? And what will you be giving?
It has to be given, anti-D prophylaxis has to be given for RH negative mother with ICT negative.
Yes.
It has to be given
when should it be given?
It has to be given after delivery, within 72 hours after delivery. And it is also given as a prophylaxis at 28 weeks of gestation.
Exactly. So can we go to the next slide? So when you talk about the timing, it is 72 hours of delivery if the baby group is RH positive and DCT is negative. Then even in first trimester pregnancy loss, we'll be giving after invasive procedures like amniocentesis, CVS, caudal synthesis, and antenatally at 28 weeks. Also in the second trimester and third trimester, if there is a role of APH and external cephalic version, which comes into the place. The next one. So talking about the dose and route, it will be an intramuscular injection, a dose of 300 microgram of anti-D immunoglobulins. So we need to understand that it neutralizes 15 ml of fetal RBC or 30 ml of blood. That's what we are actually targeting. We are expecting a transfer of 0.1 to 4 ml when we discussed first. And what we are trying to give is a dose which will neutralize 15 ml of fetal RBCs. So when there is a even larger fetal hemorrhage, which has been calculated, obviously, there will be a higher dose requirement. So the next slide. So in case of a large fetal hemorrhage, which will be occurring with traumatic delivery, abruption, manual removal of placenta, and stillbirth, IUD, twins, and eye drops, we have to always consider the dose of more dosage of anti-D. So next slide. I'll just go into the basics of brushing this. Dr. Karpagambal, madam, the KBS stain, that is a clear Betke test. Do we use it? The next slide.
Yeah, clear Betker test is a very good test, but it's an acid dilution method. It's not routinely used because, as you said earlier, we err on the higher side. We actually give more anti-D than what is required. We all know that more ml is the maximum required, but we actually give around 300 micrograms to neutralize at least 15 ml of RBCs, which is definitely good enough to cover up all the fetal hemorrhage taken place. So KBS is definitely not used. The only there is one advanced test called flow cytometry, which is more sophisticated, which will actually quantify the amount of fetal hemorrhage in most cases. So in that situation, if facilities are available, we would prefer a flow cytometry, which is definitely available in Chennai in many labs. And if it's not available, it's an acid dilution method of quantifying the amount of fetal hemorrhage if there has been recurrent episodes of fetal hemorrhage, which when we are not sure about the dose of anti-D that we had given already.
Yes. So exactly, even though we are not doing this test routinely, and we also know clinically the conditions where the transfer will be more than 15 ml, like as I said, the traumatic delivery, the abruption, manual removal of placenta. That time we will be always worried about the larger dose. Otherwise, whatever we give the anti-D is super sufficient to nullify almost 15 ml, and we are stopping there. So the next one is Dr. Shobha ma'am. There are conditions where there is no response, even if you give an anti-D, in your experience, what would you think will be the conditions? Even if you give an anti-D, it's not going to be of a great help.
It all depends upon the effect on the fetus. It depends upon the severity of the fetal-maternal blood loss. If it is a mild, then there may be a hemolytic anemia. If it is moderate, then there may be a icterus. If it is a severe degree, there may be a high drops. Again, in the high drops, it may,
So basically, even in cases if the patient is an immunological non-responder, if there's a coexisting ABO incompatibility, even if you give a dose of anti-D, it's not going to be helpful, and we need to be very careful about it. So I think I'll just ask one more basic question to Dr. Geeta madam, and we will not be going to the fetus now. We are going to go to the other two cases, which Anita will be dealing. So Dr. Geeta madam, how many cases of Rh negative pregnancies have required intrauterine transfusions in your clinical practice, and how many have you actually referred or done? Because we talk a lot about all that. How many? I'm curious about the numbers.
I remember 2 cases, madam. I sent to Mediscans Chennai. Both are fine.
Yes. Okay. So it's just to know make everyone aware that's how rare IUTs are required in our clinical practice. Even though we talk so much about Rh isoimmunization, so we have just brushed up a little bit of the basics. So this is the right time we can go into the cases, and I call Anita to discuss the cases with our panelists. Anita? Is Anita there?
Anita, can you please unmute yourself? Dr. Anita?
I'm not seeing her.
I can see her, but she's not unmuted herself, I think. She's
Anita ma'am, you are not audible.
Yeah. Now I can see her.
Can we just call her in?
Yeah. Yeah.
Yeah, I'll call
Could
her.
you? Yeah. Please come. Please here. The slides are coming. I'm not able to hear her only from
I'm
the
sharing,
beginning.
ma'am, from my end. I'm sharing from my end.
Oh.
We'll call
But
Anita.
Anita ma'am is not able.
Can we
Selva Priya,
Okay,
Ma'am, Anita ma'am,
okay.
can you rejoin ma'am? That will be better.
Till
We are
Anita
not
is
able to
coming,
hear you.
I will take care of this.
Okay.
So now we'll go to the management. We are
call
just
her.
very clear with the basics. So we'll go into the management of RH negative. So this is the case one scenario. This is basically an approach to a RH negative mother. A recently married couple comes to your clinic as she has missed her periods and her UPT is positive. Her gestation age is 6 weeks. A routine investigation revealed her blood group as A negative. So what next? Can Dr. Manohar take this question?
Yeah, once
We have
the blood
already
group comes as-
discussed. So the discussed part will go fast.
Yeah, so we get an blood grouping RH of the husband, and we also counsel that if the husband is an RH, if there is a possibility of getting a genotype of the husband, so whether if it is an heterozygous, the 50% chance of having a baby fetus having with the RH positive, and if he is homozygous, the chance of having a fetus will be almost 100% RH positive.
Exactly. The next slide, please. So when it comes to the counseling part, patient wants to know if her baby is at risk in the present pregnancy. Dr. Darni, could you highlight on that? And the next slide, please.
The patient has to be counseled regarding her, if the patient's husband is homozygous, definitely she is at risk for a baby having hydrops fetalis. And if the patient's husband is heterozygous, she can go for self-repeated DNA testing to check for the blood group of the fetus. And if the fetus is, if the baby is shown to be RH positive, and that baby is also at risk for erythroblastosis problem. And
so we will do a blood grouping and without ICT at the first visit. And the husband grouping will be tested. So we'll be doing an ICT. So if the ICT is negative, again, we'll repeat it at 28 weeks. Do we agree to this?
At 28 weeks.
Do all my panelists agree to this? We are seeing ICT in the first visit and then again we repeat it at 28 weeks. Do we all agree? I just need yes. And then we give anti-D at 28 weeks and anti-D after birth by doing a direct Coombs test. So we agree to all this, right? So the next slide, please. So this will be to Dr. Karpagamal, madam. And what is indirect Coombs test, the principal result and critical titer? I want to know the critical titer which will bother you.
Yeah, see the principle is actually, as we said earlier, it's basically detecting the unbound antibodies present in the because they wash out the RBCs which are already agglutinated. They add an antiglobulin and they found that free antibodies present in them. So it is actually a measure of how much of antibodies the mother has produced, whether the mother has actually reacted to the sensitization. So that is what is ICT. So that is, there are a lot of labs which give their own critical values. But according to the most of our criteria that we use, any level above more than 1:16 is considered very significant. But for other antibodies like KEL and all, even 1:4 or 1:8 can be very significant. As far as RH negative, RH anti-D is concerned, RHD is concerned, 1:16 is supposed to be considered very high critical titer. This means that the pregnancy is already sensitized and we have to follow up these women every 4 weeks with MCA-PSV Doppler. But if the MCA is depending on that, actually gives us an idea. So these are the patients who should not be given antenatal prophylaxis.
Yes. So 1:16 is the cutoff you prefer. Is there anybody else who wants to be alert with another cutoff? 1:8, 1:4.
1:8 also is okay.
1:8 is also okay to be alert. So shall we lock 1:16 as the titer to be alert?
Yeah, even otherwise, we'll be doing an MCA-PSV Doppler on a routine basis.
Obviously, this is only related to the titer.
Exactly.
Once it comes ICT positive, how much ever you are going to go with the titers and repeat values and everything.
Yes.
More important is evaluating the fetus and seeing the effect of this fetal-metal hemorrhage on the fetus with the MCA-PSV. That's going to be more valuable than even your titers, in fact. That is why I was asking for the titers. So
Even
more
then
than
we
the
are going to see-
titers.
Yeah,
Exactly.
we're going to see for the third space fluid accumulation, edema, everything. So that actually
Exactly. As long as the fetus can hold on. As
Yes.
long as the fetus can hold on, we are going to hold on. So we are going to be more towards that, because initially the titers were playing a major role. But now, as long as the baby is able to take it, we are going to take it forward. That is the main thing which is coming up now. So the next slide, please. So the indirect Coombs test can determine the maternal IgG responsible and reported as titer, which is equivalent to dilution. So usually a critical value of 1:32 is considered as a titer of clinical significance for anti-D antibody, and most others a critical value of 1:8 for anti-KEL antibody. So now the values are coming 8, 16, and 32. So we are going to be alert whenever the ICT is positive. Irrespective of the titer, we are going to be more alert by monitoring the fetus more vigorously. So the next slide, please. Next slide. So the key to the medical decision making, but it may vary according to the laboratories, like how Madam has clearly mentioned. So the follow-up titers in the same laboratory for serial monitoring is very important. If one laboratory is giving you 116, don't go to the other one to cross-check if that is 116. Go to them again to find out if it's 116. So each laboratory must define a critical titer based on the methodology adopted. And always when going for interpretation with the values, we have to ask for the comparative values in the lab, because each one would be using a different method. So it's very important that we have to define a critical titer based on the methodology adopted, upon which further management that includes serial Doppler scans to identify fetal anemia and intrauterine transfusion in severe cases decided. The next one. So now the question will be to Dr. Shobha, Madam. This will be related to sensitizing the events. Then see, what are the antenatal sensitizing events? Next slide, please.
The most commonly sensitizing events are termination of the pregnancy, antepartum delivery with a normal delivery, their insertion, extensive invasive prenatal testings, fetal loss like IUD, fetal reduction, ectopic pregnancies, abdominal trauma, abdominal and Rh positive platelet transfusions, manual removal of the placenta.
Yes, yes. And so even if it's a primary gravida, we have a series of events from the diagnosis of pregnancy till the delivery of the baby, which is going to keep changing the course of your vigilance all the time. So it's very important. We need to keep in mind, even if it's a primary, there are chances of so many things happening in the in-between period. The next one, please.
One more point to be added. If there is a previous history of blood transfusion, organ transplantation, all these
spontaneous. Yes, always they come to us as primary. They do not mention about the previous 40 days amenorrhea with the CAR test positive and eventually getting their periods. They wouldn't have considered it. So we have to be very careful. Even if they declare themselves a primary, we need to ask them for any history of missed periods, delayed periods, the CAR test positive previously. We need to be extremely cautious about it. The next slide, please. So the transplacental hemorrhage, the spontaneous transplacental hemorrhage is 75 to 80%. So in the first trimester, around 5 to 8% of the spontaneous placental hemorrhage takes place, which will be around 1 to 5 ml. And in the second trimester, if it takes place, which is very common, 14 to 18, 1 to 25 ml. In the third trimester, if there is a transplacental hemorrhage, which is the chance of which is around 25 to 30%, it can be up to 350 ml, and during parturition, the 50% of the transfer takes place, and it's around up to 350 ml. So this is the approximate percentage and the volume of hemorrhage which could be transferred here and there. Yes.
Dr. Selvapriya, can you hear me?
Yeah.
I've just
Very
joined
well.
through my mobile.
Anita, please come. Take
Thank
over.
you. Sure. Please, the next slide, please. Okay. Who's the next panelist who's supposed to answer? Dr. Shobha? Dr. Geeta, can you tell us what are the chances of sensitization if the woman was not given any anti-immunization?
For ABO compatible, it is 16%. What is the question, madam? Can you repeat?
Can you tell us what are the chances of sensitization if anti-D prophylaxis or was not given during the antenatal or the postnatal period?
Exact percentage I do. The chances are less.
You
only.
just, no, don't even talk about the numbers, madam. Just tell how much do you feel that the chances of sensitization can happen if you don't give an anti-D, that's all. So it's...
Ma'am, the chances of sensitization, as we see, in an ABO compatible pregnancy, it's about, which is nearly about 80% of cases, where the chances is about 16%. While in an ABO incompatible pregnancy, which offers a protection because the red cells are destroyed before they mount an immune response, we see that the chances of sensitization is only 1.5 to 2%. So the overall risk of immunization we see is about 13%. And the antepartum risk is only about 1 to 2%. It mainly occurs in the intrapartum period. Okay. So with continuing the case, now the same patient was given anti-D at 28 weeks of gestation. And the obstetrician does an ICT at 32 weeks again, and she gets a report that it is 1 and 2 dilution positive. Now the patient is worried.
Next slide, please.
Go about this, Dr. Dharani.
Ma'am, no need, because it is always, if we have given anti-D at 28 weeks, means there will be weak titers available. At least around 1:4% titers will be available. So ICT might be positive, mild dilution.
Okay, so now the ICT need not have been done, because as we know, after an ICT, after an anti-D prophylaxis, for several weeks, we see that the dilution, the ICT titers may be around 1:1, 1:2, but always less than 1:4 dilution positive. So there is no need to repeat. And even if we get a positive titer, a weak titer, no need to panic. And sometimes even if the baby is delivered, there may be a weak direct Coombs test positive in newborn also. And coming to the efficacy of anti-D, we see that the role of alloimmunization after anti-D is reduced by 90%. Postpartum anti-D, only if it is given, it reduces by 1 to 2%. And if both antepartum and postpartum prophylaxis has been given, the risk of immunization is reduced to as low as 0.2%. Now, we've already discussed this in the basics, whom to give. So we all know that in an Rh negative mother who has not yet produced any antibodies, we give it for routine antenatal prophylaxis and for any other potential sensitizing events during the antenatal period, and also for a postnatal prophylaxis. Now, whom not to give? So whom not to give? For women who've already sensitized, which means who've already got these antibodies, they should not be given the anti-D prophylaxis. And again, in certain cases where the woman is Rh negative, who is not sensitized, but when we do a father's genotyping, we find that it is Rh negative. And if he is positive and he is heterozygous, when we've done a genotyping of the fetus, if the fetus is Rh negative, we don't give the anti-D. So coming to the next slide, how do we manage the labor and delivery? So now this patient has received the antenatal anti-D. She's reached term without any complications. Now, how do you go about her labor and delivery? When will you terminate the pregnancy? What precautions will you take during labor and delivery? Dr. Manohar?
So if it is an ICT is negative, we can wait up to 40 weeks, never allow the pregnancy to cross beyond the 40 weeks. So one thing, and during the labor, monitoring by the partogram 1 and inform the neonatal intensivist, NIC pediatrician 1, and minimize the use of inhalers episiotomy as the risk of transmission, fetal-maternal hemorrhage risk will be there, and avoid using methadone. And if you want to do, if there is a manual removal of the placenta to be done, do a gentle MRP to be done, and early clamping of the cord has to be done, and 15 to 20 centimeters of the length of the cord to be kept, because if there is a need for an exchange transfusion, and this cord has to be wet, covered with the warm, moist saline pad.
Yes, definitely, sir. And what investigations are done for the newborn? is just brushing up of the basics, which we've done already.
Yeah.
Sir, can you please tell us what investigations?
Yeah, send the cord blood for the blood grouping, RH typing, hematocrit value, direct Coombs test, and the bilirubin levels.
Okay, so depending upon the direct Coombs test reports and the blood grouping, we are going to plan for the postnatal prophylaxis. Now, what is this anti-D immunoglobulin? We see that it's a polyclonal antibody, and we know it's about the dose is about a standard dose, which we give is 300 micrograms, and it neutralizes 30 ml of fetal blood or 15 ml of fetal RBCs. Now, it's given as an intramuscular injection, and a point to note is that it has to be given only in the deltoid region, ideally within 72 hours of birth. So now, more than 99% of fetal maternal hemorrhage is less than 4 ml. So actually, we give a higher dose. And we see only about the 50% of large fetal maternal hemorrhage occurs only in normal delivery. And we also see that the half-life of anti-D is about 24 days. So with respect to using whether polyclonal or monoclonal type of the immunoglobulin, we see that polyclonal is better, and because monoclonal cannot cover all the epitopes of the antigen, and so the protection may be slightly lower. So next slide, please. Can alloimmunization occur even after anti-D? Yes, it can occur because either it is because of the failure to give anti-D, or maybe because of the inadequate dose, or the patient has missed the prophylactic dose, there was an unrecognized fetal maternal hemorrhage, or the antibodies may be due to several other minor blood groups. And we see that anti-D may not be as protective as for the antigen. It may not be protective for other blood groups. So certain conditions, next slide please, where the large fetal maternal hemorrhage are expected, like placental trauma, cesarean section, manual removal of placenta, and intrauterine death, multiple gestations, or any other invasive diagnostic procedures, we may have to determine the fetal maternal hemorrhage with the tests like Crosset test, Clay-Horror-Bethke test, and flow cytometry. So as the previous panelist pointed out, we don't do these tests routinely unless we have a large fetal maternal hemorrhage and we want to specifically quantify the amount so that we adjust the dose of anti-D. Actually, we are giving a higher dose, so we are not doing these tests routinely. So now, several other points to note are, there is no need to repeat if the woman is not yet delivered beyond 40 weeks. And as we told, the anti-D weak titers will persist for several weeks after the injections. And if omitted at delivery, if omitted at delivery or because it was not recognized, not available, we can give even up to 28 days, which can offer a partial protection. And if delivery has occurred within 3 weeks from the antenatal dose of anti-D, there is no need to repeat after birth. And we should always try to give to women who are undergoing postpartum sterilization policy. So coming on to the next case, now that we've seen a woman who's gravida, who's a non-immunized pregnancy. Now we'll come to the management of women with red cell antibodies.
Yes, madam.
Okay, ma'am. Okay. So the second case scenario is a primary gravida at 10 weeks of gestation with a blood group of A negative. The husband is O positive. She has received anti-D in the first pregnancy, but she gives a history of not taking the antenatal dose. Her ICT at the first visit is 1:2 dilution positive. How will you counsel her? Dr. Karpagambar?
Yeah, because definitely this seems to be a sensitized pregnancy, whatever it is, even though the dose that was not adequate or whatever. So there is definitely risk of fetal anemia, and we have to be, she has to be under surveillance radar. So I always tell her that the chance can be low, but we will monitor, and we do a start scanning for MCA PSV Doppler from as early as 20 weeks to check for fetal features of fetal anemia, as well as following with the Doppler program.
Yes.
So that's what takes place in main counseling.
Rightly said, ma'am. We should always counsel the woman, because now that she has produced the antibodies, she is at risk of, the fetus is at risk of developing anemia, and she has to be closely monitored for the risk. So we see that theoretically speaking, like the risk of fetal anemia is greatest with anti-D and few other antigens like anti-C and anti-K. Now, this positive antibody screening during the antenatal period, it should always be followed up by a semi-quantitative titration test to determine the strength of the antibody and the risk of hemolytic disease of the newborn. So now how about doing a paternal and fetal genotyping? So how does it help? Dr. Shobha?
Yeah, paternal genotyping determines if father is a homozygous or heterozygous. Non-invasive fetal genotyping using maternal blood is now possible using the free fetal DNA extract from the maternal plasma.
Anita, are you stuck? Anita? I think Anita is getting stuck again.
Testing in the maternal plasma and can determine the fetal blood group. So if the fetal blood group is also negative, there is no need to test further. Okay. Dr. Geeta, what are the implications for the fetus and neonates from red cell antibodies? Rather, what are
fetus may have hyperbilirubinemia, neonatal jaundice due to hemolysis. There will be profound fetal anemia, non-human hydrops fetalis and hydropic fetus. All these things we have to look, we can see in ultrasound.
So all these are the fetal complications and we may have to monitor. And if monitored in treated cases, we see that in a non-hydropic fetus, the survival rate is nearly about 94%, while in hydropic fetus, the survival rate drastically reduces to only 74%. So there is a need to monitor all pregnancies in Rh negative mother who has produced antibodies due to earlier sensitization. So coming to Dr. Dharini, can you tell us, once you've detected the antibodies, how often should these levels be monitored during the pregnancy?
It has to be monitored every 4 weeks up to 28 weeks and every 2 weeks thereafter till delivery.
Okay, so what are the thresholds, Dr. Dharini? Can you tell us about the thresholds that are used and what is the critical titer and how do we report the testing?
It is the threshold is from 1:8 to 1:32 and the critical value is 1:16 is determined as the critical titer. 1:16.
Yes, so that again depends upon the laboratory to which we are sending the sample. And at most of the laboratories, the dilution, the critical titer is about 1:16. And if it crosses 1:16, a referral to a fetal medicine specialist should be made. And in developed countries, they actually quantify the amount of antibodies and they say that a level above 4 international units is a critical level for referral. And again, that depends upon the type of antigen, that is, whether it is the anti-D antibody or the anti-K. So if it is an anti-K antibody, the prompt referral to a fetal medicine specialist is necessary. And once the threshold is crossed, the value of subsequent quantification is doubtful. So there is no need to repeat the titers to see if it is still rising. We may have to go for more intensive monitoring and more close monitoring of the fetus with an ultrasound. And a point of caution is that in women with a history of previously affected pregnancy, they have to be referred to a fetal medicine specialist earlier. And because these women are at risk of having a fetal anemia, even at a very low antibody titer. So these are the women. So the past history from the woman is very, very important while monitoring a woman who has already had antibodies due to prior sensitization. So Dr. Shobha, if the fetus is at risk of anemia, when should the referral be made? So what are the conditions where we have to refer the patients?
If there is a rising titer levels above specific threshold and UST features are suggestive of fetal anemia, and if there is a previous history of unexplained severe neonatal jaundice, neonatal anemia requiring transfusion, or exchange transfusion. And risk of fetal anemia appears to be correlative with the increasing antibody titers.
Okay. So we know that whenever the antibody levels are rising, it's going above the threshold, we need to definitely refer these women to close monitoring with a fetal medicine specialist. So should Rh negative women have antibody?
Sorry for the
antibody
interruption.
Yes.
We will wrap up. You want to wrap up, is it? Tell me.
Sorry for the interruption. Yeah, we need to wrap up quickly, please.
So we will do something. We'll take regarding the effect on the fetus. So Anita, can you just give a summary of your final thing?
So the timing of delivery with red cell antibodies will depend upon the antibody titer, the rate of rise, and if any fetal therapy has been required. So the mode of delivery actually is based only on the standard obstetric guidelines. And even if a fetus has received a prior intrauterine transfusion, that's not an indication for cesarean section. So in general, we see that when the woman's antibody titers has been stable throughout, delivery should occur between 37 to 38 weeks of gestation. But if there is a rise in the antibody levels, then we may have to deliver her early. And we know that all these pregnancies are high-risk pregnancies, and they have to be monitored with a continuous electronic fetal heart rate monitoring during labor. And appropriate cord blood investigations to determine the grouping, the direct Kunz test, hemoglobin and bilirubin levels should be done. And we also see that what is the recurrence risk in future pregnancy? So once we have a woman with a history of previously affected infant or previously affected infant with hemolytic disease of the newborn, a prompt referral should be made to the fetal medicine specialist. And the risk of recurrence again depends upon the type of antibody, the paternal genotype, as well as the severity and gestational age at onset of fetal anemia. So with this, we conclude the management of women who has got a positive antibody screening. Now we'll just move on to a woman who's showing signs of fetal anemia.
Anita, I think we need to wind up. We need to give the concluding remarks. I'm getting repeated messages. We are short of time. Do you have take-home messages?
No, Selvapriya, participants வந்து குறைஞ்சிட்டே வராங்க. There is
no
continue.
Yeah. So we will conclude it here. Yeah. And when I have to talk a word about the fetus before winding it, so we have to remember the MCA-PSV. So MCA-PSV in fetal anemia, the MCA-PSV is increased because the blood viscosity is decreased, so the cardiac output is high. So there will be a MCA-PSV increase. That's what you need to remember. The normal value is between 30 to 40. If it's more than 35 or something, you have to be very alert. And if it is less than 25, there is arterial insufficiency, you'll be delivering it. Okay. And in terms of moms, any mom value is more than 1.5 elective deliveries should be decided. So when it comes to the fetus, there is a lot of role about exchange transfusion, depending on if you are able to do a cardiocentesis and find that the hemoglobin is less than 10, then you can do exchange transfusion, intrauterine transfusion. So I have to talk about the baby with Rh negative pregnancy, and I have given a very short, keep in mind the MCA-PSV, it will be increased and it has to be normally between 30 to 40. Thank you all my panelists. We are the last. I know we were on time and the previous people have exceeded their time and that's why we didn't get. Anyways, thank you so much. And Anita, would you like to add something before thanking Sampath Madam and Vijayalakshmi Madam, Revati Madam and everyone? And whoever is here, there are almost 120 people right now. Please be very, make sure you've received all your nomination forms, else approach the Foxy office or call me or call Dr. Madhuri Patel Madam for your forms. And please vote, please nominate. This is your chance to show the power of your society first, society. So do nominate, do vote and support the right people in all ways. Thank you so much, Sampath Madam, and thank you so much all my panelists, Dr. Manohar, Dr. Tarni, Dr. Karpagambal, Dr. Shobha Ma'am, and Dr. Geeta. And Anita, we missed you for a while, but thank you so much for being back on time. Yes.
Anita, we will have another one panel with the same topic with Dr. Anita. Okay?
Yes.
Thank you. Today, I want to tell we have 661 registration.
Fantastic.
Very nice. Very nice, Sampath.
Vidya Tobi Madam.
Yes, Selma, I am listening to you and it was a wonderful panel.
Yes,
We have to
yes.
do
Thank you so
one more
much.
repeat session of this panel.
Yeah, I want to
and,
come to
really.
Nagarcoil, no? Along with Sampath, I'm coming to Nagarcoil. Please come,
Yes,
please come.
Anita, we should make you moderator for another time. Anita,
Yes,
Priya, we will
she
do
has
it.
done wonderful.
Okay.
Wonderful.
Thank you.
Yes.
Thank you, Anita.
Thank you so
Anyway,
much.
thanks to all for
Cheers to TNFOG and KSOG for this wonderful program.
yes.
And thank you so much, everyone.
See you
Thank
tomorrow by 9 o'clock.
Thank you all, madam.
So much for the
Thank you, ma'am.
opportunity, madam. Madam, next
Thank
panel
you.
discussion
Thank
will
you,
also.
Sampath ma'am. Toby
Yes,
ma'am,
Shruti.
thank you, Revati
Yeah,
ma'am.
yeah, Shruti. Tomorrow
ma'am.
also you join, even though you are not a coordinator, you have to join.
Thank you so much.
No,
Yeah,
Shruti
ma'am.
should
Yeah,
be
ma'am.
there.
Thank you, thank you so
Thank
much
you,
for
ma'am.
giving me this
Yes, madam.
opportunity.
Thank you so
Thank you,
much,
Darling.
everyone.
Thank you.
Madam
Thank you.
Sampath, madam. Thank
See
you,
you.
madam.
Madam, we don't
Thank you,
discuss
Geeta.
about
See you all
Thank you so
tomorrow.
much, ma'am.
Okay, ma'am.
Thank you.
Thank you,
Thank you.
ma'am.
Thank
Bye.
you.
ma'am.
Thank you
Thank you.
very much.
Thank you
Radhika,
all.
See
thank
you
you so
all
much.
tomorrow.
Thank you so much, ma'am. Thank you, ma'am.
Vidya
Thank you,
Topi,
ma'am.
see you tomorrow.
Thank you,
Yeah,
ma'am.
yeah.
Vidya,
See
ma'am.
you tomorrow. Thank
Thank you,
you.
ma'am.